at the top, not from the bottom, looking at pus cells. So the first thing that we need to look at, and some of this is very basic, which is all given in books. What I would like to just point out is you all know color. We know that it should be light yellow or green. Red, we all know, is because of hematuria or hemoglobinuria. Can be coloring agents also. Deep yellow because of jaundice. I would like to just point out here, this also everybody knows, white or turbid urine is not only urine infection. You can get amorphous phosphates that cloud your vision and the urine, and you treat urine infections for that. So don't do that. We need to be careful about diagnosing amorphous phosphates. The second part is specific gravity. Udhar hamara nazar jata hi nahi hai. We just go down. So we need to understand that specific gravity is a very useful thing in renal conditions. So normal U volumic status, your specific gravity is 1010. If you have dilute urine, it is 1005. And a concentrated urine is usually 1030 above 1020. And how does it help you in clinical practice? Our patients teach us a lot. So if this boy, 6-year-old boy, presents with passing, the history is that he passes a lot of urine, goes very frequently to pass urine, and it has been present for months to years. And if you talk to the parents, they ho khub pani pito. So the simple test that you do is a urine routine. Diagnosis, not the front benchers. Some of them have heard me before. Diagnosis, you get a diagnosis on urine routine. It's not a urine infection. Let's not go to the pus cells. Okay. So what you're seeing there is a high specific gravity in a child who's going frequently, clearly not polyuria. If you want to listen to polyuria, come for the capsule talk later on also. So the diagnosis comes along with the urine routine and a history. So what you will find is this child is passing very concentrated urine, small volumes of urine. He's getting pre-void wetting, drinks small quantities of water and never wakes up at night. So this child has detrusor instability or an irritable bladder syndrome. The thing that you are worried about is whether he's got any of the diabetes conditions, and it's ruled out by a simple urine test because the urine is not dilute. That's how important a specific gravity can be. The other important issue is in the presence of a low specific gravity, please be careful about interpreting urine protein. And we'll talk about that when we reach the protein. The second part, which is often looked at, is urine pH. Again, we don't reach there. We directly go on to pus cells. And everybody has written short notes or long answers to pass your MD exams. And you all quote this. Unfortunately, Nelson has done a big disservice because everybody remembers only this. But can anyone explain what it means? What do you mean by urine pH being less than 5.5 for a proximal RTA? The reason I'm asking you the explanation is that is why we create mistakes in diagnosing renal tubular acidosis. So the point that is missing in all this, which your textbooks are telling you, is in the presence of severe acidosis. So when you have severe acidosis and your bicarb level is extremely low, 6, 8, at that time, when you check a urine pH in proximal RTA, the urine pH will be acidic. Whereas distal RTA, because the distal acidifying mechanisms are maintained, the urine pH is less than 5 in proximal RTA, whereas it's more than 5.5 in distal RTA, which means it becomes alkaline. Why is this important? Because when you suspect renal tubular acidosis, what you need to remember as pediatricians is when the child comes in, you have sent a blood gas. If you don't collect urine at that time, you are going to get all sorts of bizarre results. Dusra divshi sakali pathuvun tela kahi fayda nahi. Because you have already treated the patient. You have corrected the acidosis. You will not be able to interpret this. So this has to be done when the child is having maximum or severe acidosis, which is when the child presents to you. Okay. So unless you have done that, you're not going to diagnose renal tubular acidosis appropriately, that proximal and distal RTA. The other important issues with urine pH, if you have reddish urine with no RBCs, we talk of hemoglobinuria. And what happens to hemoglobin? In acidic urine, it elutes out, coats the lining of the tubules, and therefore you get acute tubular necrosis. So if you don't want to call me, alkalinize the urine so that you prevent dialysis. In other important issue to remember is protein readings change in alkaline and acidic urine. So you're going to misdiagnose proteinuria. We'll talk about that again. And in certain poisoning or urolithiasis, for example, uric acid stones, the treatment is to keep the urine alkaline. That's what is the clinical importance. So urine protein, as I have written, where most crimes get committed. Why? We forget that it's a semi-quantitative test. The urine protein reading changes based on what I just described. So higher pH causes a higher protein reading. A lower pH causes a lower protein reading. If you have a low specific gravity, the protein reading becomes lower. If you have a high specific gravity, protein reading becomes higher. How are you going to diagnose proteinuria based on that? And you will miss proteinuria completely. Clinically relevant? Here, this is a 5-year-old boy who comes to you with edema and typical presentation of nephrotic syndrome. You do all the tests and you start treatment. You give him prednisolone, and within 2 weeks, he diureses extremely well. At 4 weeks, you start tapering off the steroids, say 4 weeks, 6 weeks, whatever, and you cannot taper off the steroids. So now you say that he's a frequent relapser and you want to add another agent. Now, the first question we need to ask is this boy really steroid sensitive? The answer I get is, but the urine is trace protein. Well, the urine is trace protein, but as I said, it can change based on the readings that we just said. So when you actually did a protein creatinine ratio, when you thought the child was in remission, the ratio was 6. The normal was less than 0.2. So anything more than 1 is significant proteinuria. So this child is steroid resistant. You can give steroids all your life. He will never go into remission. And that's the problem with relying on a semi-quantitative test. So the lesson is, when you think the child is in apparent remission, do a protein creatinine ratio to ensure that the child is steroid sensitive in terms of nephrotic syndrome. To show that I'm not fibbing, you can look at the date. It shows absent protein and the same urine ratio is 5.185. So other conditions like dysplasia or posterior urethral valves causing dysplasia, you get dilute urine. So in the presence of a very low specific gravity, you will have proteinuria, which will be missed completely because your protein reading is trace or absent. So if you do a protein creatinine ratio, you will often find nephrotic range proteinuria. And this is important because this damages the kidneys. So if you don't pick this up, long-term CKD. The next part in the urine routine is blood. So occult blood, 1+, 2+, positive, not negative, whatever. So just to give you an example, this is a 15-year-old boy who had history of fever for 2 days, had a mild cough, and this urine, don't ask me why it was done, it was done. And then the parents wave this report in front of you because they have gone on Google and they've read about everything, including cancer. So this is the report, blood positive, pus cells 5 to 8, RBCs 2 to 3. So my question, what would you do for the hematuria that is present here? Nobody heard me last week? Okay, the answer is there is no hematuria. So diagnosis of hematuria is not based on occult blood. Diagnosis of hematuria is based on number of RBCs per high power field that you see. So for persistent microscopic hematuria, you need to have more than 5 RBCs per high power field in at least 2 or 3 samples taken 2 or 3 weeks apart. So occult blood positive is because of a sensitive dipstick. The tetramethyl benzidine reacts with the peroxidase, the pseudoperoxidase reaction of heme. And therefore, even tiny amounts of blood, which don't constitute hematuria, will give you a positive result. So you can see it in normal patients also. Forget children. Even in adults where they are more worried about hematuria, where prostate is a big problem, this is called a pseudo-hematuria. So it's not treated, it's not investigated. So if you have got clear urine with occult blood, it's not significant. Red urine, occult blood, no RBCs is hemoglobinuria. That you cannot ignore. Okay. So the 3 cells that we commonly look at, epithelial cells, pus cells, and RBCs. So epithelial cells in children, not much significance, but if you have a high number of epithelial cells, especially in girls, it usually means the sample has not been collected properly. Pus cells, I'm not going to talk much about it because I think there is a talk about UTI soon after this, but this is the one that gets us into most troubles. Remember, pus cells stroke inflammatory cells. So pus cells is not equal to urine infection. So they are not pathognomonic of a urine infection. When we say significant pyuria, it means more than 10 cells per cubic millimeter of uncentrifuged urine or more than 5 per high power field of a centrifuged urine sample. And the differential diagnosis of presence of pus cells is all this. So any inflammation anywhere in the body. You can have appendicitis, which gives you pus cells of 150 in the urine. Any forms of nephritis, glomerulonephritis, interstitial nephritis, dehydration, any kind of fever, hypercalciuria, and don't forget systemic conditions also. Anyway, somebody will be talking about urine infection, though I will touch upon something else. So this is a 2-year-old girl, because we've all been told about specificity and sensitivity of tests. So this is a 2-year-old girl who comes with history of fever for 2 days. There's no significant past history. And you get a urine test done. And this is the report. You get nitrites positive, pus cells are 3 to 4. And they come back to you in the evening with the report. But by that time, the child has developed a cough and a cold, because the parents are also suffering from the same. So the question is this a urine infection? Because you've all been told specificity of nitrates is 97%. UTI, not UTI? Yes or no? What will you ask? So what you need to ask is ask about the urine sample. If you take the sample in the morning, send it to the lab, and somebody examines it in the evening, this is the report you're going to get. Okay, so if a sample is kept at room temperature for more than 2 hours, you're going to get this kind of report. So false positive nitrate is if it is not a fresh urine sample. If the dipstick are exposed to air frequently, you keep on opening the lid of your box and closing it very frequently, 50% will become false positive within 2 weeks. And then there are certain medications which also interfere with nitrite estimation. So be careful about interpreting only on the basis of nitrite. It should be symptoms along with what you suspect. RBCs, we just talked about it. In presence of more than 5 RBCs per high power field in 2 urine samples done 2 weeks apart is persistent microscopic hematuria. And presence of red urine with many RBCs is clearly gross hematuria. Casts tell you the story that happened in the kidneys. So you have RBC casts in hematuria or nephritis, granular casts in nephritis, white cell casts in pyelonephritis, and hyaline casts in heavy proteinuria. We see crystals very often. The parents wave the reports at you because everybody is worried, and our anxiety multiplies also. So when you see calcium oxalate crystals, it does not mean the child has hypercalciuria. No, you have to measure the calcium to say the child has hypercalciuria. This is often seen in normal people also because you're drinking less fluids. Uric acid crystals can also be seen, especially in neonates. Urate crystals leave a pink stain on the diaper. So don't call that as hematuria. This is commonly treated as urine infection. You have a bang normal urine routine, but the bacteria is positive. Again, it's because of the same reason that we talked about earlier. You take a sample in the morning and somebody examines it in the evening, and therefore they get bacteria positive. Only bacteria positive with no symptoms, no other positive elements in the urine routine is not evidence of a urine infection. And then we have combination. We are all fond of fast food. So combined meals. So sometimes combination of factors helps us to diagnose certain things. So this is an 11-year-old girl who had fever and vague abdominal pain for 2 days. There's no significance. So the history is short, because I'm going to tell you the last case is a long history. Who's well grown, blood pressure is normal, and systemic examination is normal. And fever continued for 2 more days. This was done somewhere else. She was given IV antibiotics after cultures were sent. But she had had tests done on an OPD basis and admission. And this is the urine test that had been done. Protein 1+, specific gravity 1005, sugar 1+, and white cells 10 to 15. Diagnosis? It's a very common condition which we never diagnose. So these are the other tests that were done. The cultures were negative. Sugar was normal in the blood. Creatinine was elevated. And if you note, there is a combination of factors. There's hyposthenuria, dilute urine. There is presence of sugar with a normal blood sugar. So you have something like glycosuria. The blood sugar is not elevated. And proteinuria with minor hematuria. The ultrasound was normal. So what this girl had was acute tubulointerstitial nephritis, commonly seen because of what we do to the patients. NSAIDs, antibiotics, and infections can also cause it. So sometimes a combination of features can help you diagnose a condition in the urine routine. This is the other one, 8-year-old boy. This is a very common thing that happens, who presents with mild puffiness of the face for the last couple of weeks, which is seen in the morning and disappears in the evening. And there's no significant past history. Now, examination is normal. And this is the urine test that you do. So which one are you going to chase now? What's the next step? Yes, you heard the lecture. Good. Right. You're absolutely right. So chase this, not this, is what I'm trying to say, the combination. So this child had nephrotic syndrome because the protein creatinine ratio was elevated, and the boy had signs of nephrotic syndrome in the blood tests. But my question still remains. With UTI, I'm taking over a little bit of Pankaj's talk, I'm sorry, but I had to put this as a combination feature. Is it with UTI or without UTI? You say that and you have to give antibiotics to the patient. Just because there are pus cells in the urine does not mean there is urine infection. Acute glomerulonephritis is inflammation in the kidneys. Therefore, you get RBCs and pus cells. We don't treat there. But when you get nephrotic with pus cells, we treat with antibiotics. Why? Nephrotic is the same condition. You have got inflammation in the kidneys. So you are allowed to have pus cells in the urine. So unless there are signs and symptoms of a suggestive urine infection, it is not a urine infection. So sometimes combination features help you reach the right diagnosis. And finally, so this is just two days ago, just to tell you that this is a classical nephrotic with pus cells in the urine. And finally, to finish off, this is a 2.5-year-old girl who presents with poor weight gain. Birth weight 2.8, 1 year 7.5, end of 2 years 7. She has excessive thirst, excessive urine after the first birthday. And this is the urine test. Similar to the first child that we talked about in the combination features. If you have a long history with sugar positive, then you need to investigate for other things. So this child had hypokalemia, hyperchloremia, acidosis. This child had proximal renal tubular acidosis, and these are cystine crystals in the eyes. So a urine routine may sometimes give you the diagnosis before you even embark on major tests. So this is a difficult condition to treat. We are not talking about that. So to finish off, don't use urine routine as a routine test. Use it to get a specific answer and look at all the elements in the urine test, not just the pus cells. Thank you.
I request Pustake sir to felicitate our lecture. Thank you, sir. During our residency days, the registrars and tutors expected us to have a urine report and CBC with us. We were expected to do the urine report in side lab and do the test and tell it as a 1+ to 4+ urine. The analysis did not end here, and the qualitative analysis doesn't lead us anywhere. If we suspect a patient with nephrotic syndrome, We were asked to do a 24-hour urine albumin test. With the positive report, start the patient on prednisolone and continue the treatment till the albumin clears or the patient is puffed up due to steroids. Over the past decade, we have started fine-tuning on the type of nephrotic syndrome and treating them with proper drug and proper duration. The drug of choice depends on center to center and teacher to teacher. We have Dr. Uma Ali to give us consensus statement on how, what, and how much of treatment for the management of nephrotic syndrome. Over to you, ma'am.
Yeah. So good morning to everyone. So I've been asked to speak on the guidelines on nephrotic syndrome. So we are essentially going with the guidelines with the Indian Society of Pediatric Nephrology has brought out. The first guidelines were in 2008 and 2021, there's a revised guidelines because in this last 15 years or more, we have a number of newer drugs which have come. Though the therapeutic armamentarium for nephrotic is not large, but even adding one or two, it gives us more room for doing things. But it has also led to confusion of which drug to use, overuse of drugs and misuse of drugs. So I will quickly run through these guidelines, which are meant to guide us to treat these children in an optimal way. Okay, so this is a 2-year-old child with puffiness of face, edema, feet, decreased urine output since 2 weeks, 15 kilos, 90 centimeters, 100 by 60 BP, and rest of the systemic is okay. Now, important thing is that the physical examination to rule out infections and systemic disorders is important when we are dealing with the first attack of nephrotic syndrome, so that we make a clear diagnosis that this is a primary nephrotic syndrome. And always investigate before treating. And investigations are of two kinds, those which we need to do and those which we don't need to do. Now, on the left-hand side, we have a urine routine, which shows albumin 3+, occasional granular cast, a urine protein creatinine ratio of 4.2, a BUN, creatinine, serum albumin, and cholesterol. So generally, the edema, the massive proteinuria, hypoalbuminemia are the essential components. There's a recommendation to do Manmantu test because of the high prevalence of tuberculosis in our country before starting steroid therapy. X-ray test is not mandatory. It's subject to what you think if it's needed. Urine culture should not be done. And there is no requirement for ASLO, C3, ANA, hepatitis B, ultrasound, etc. Unless you're suspecting clinically something else, you have some clues for some other issues. So the first attack we treat with steroids, prednisolone. This child is 15 kilos, so 2 mg per kg becomes 10 mg TDS. But there's a lot of practice that even if the child is 20 kilos, they get 10 mg TDS. So the initial treatment has to be based on either weight or body surface area. The question also comes, many of these things are added on, diuretics, H2 blockers, antacids, and these are not really needed. So diuretics are avoided unless the edema is very severe. Treatment with steroids itself will lead to diuresis in 5 to 10 days because majority are steroid sensitive. Antacids, H2 antagonists, etc. are not needed unless after giving steroids you find GI discomfort. It's important to give steroids not on an empty stomach, but to give after milk or after some feed, etc., and then it will not produce acidity. Okay. There are 5 Ds which we need to speak to the parents when we see. One is about the diet, which is always important, that the diet should have normal calories. Once upon a time, we used to give high protein diet. I think Pankaj may be remembering also, we used to tell them in Vadia to give 6 eggs in the day. to thinking high protein was needed, but now we know that high protein given for a long time actually burdens the kidney and may cause damage. So normal age appropriate protein intake is what is needed. And careful of fats because of the high cholesterol, so saturated fat should be avoided. We need to teach them to do either dipstick or test for proteins by boiling and keep a record of it, and to follow up regularly, and also advise them not to take pulse polio, because that is one thing which may cause a problem. Now, this child 4 weeks later has no edema, urine albumin is negative, Cushingoid phase, blood pressure is 120 by 80, which is high for this age. We should not eyeball blood pressure, but we should check it according to the charts. And for this age, this is a high BP. So the question comes, okay, 4 weeks are over. Should we shift to alternate day or should we add antihypertensives? So you do land up with situations where you have a trade-off and you have to weigh the pros and cons. Now the ISBN guidelines are the initial episode should be treated with prednisolone, 2 mg per kg per day or 60 milligram per meter square body surface area for 6 weeks, followed by 1.5 mg per kg or 40 mg per meter square as a single morning dose for next 12 weeks. That means you're looking not now anymore at 4 weeks of daily steroids. You're looking at 6 weeks of daily steroids. The trade-off is that you do see more steroid side effects, that patients do get little more Cushingoid, some of them do get little hypertensive. But the recommendation still stands because of the observation, which was subsequently validated, that when you treat the initial attack with 12 weeks of steroids, for the next 2 years, you probably will get lesser number of relapses. So it's not for the immediate result, but hoping that you may be able to reduce the number of relapses in the next 2 years. So despite a little hypertension, one should add antihypertensives and continue and complete the course of steroids. Now 12 weeks are over, with alternate day steroids, antihypertensives could be tapered, omitted. Steroids were omitted after 6 weeks. It's important that they get a dose of pneumococcal conjugate vaccine after 2 weeks of steroid omission, because that's one infection they are very prone to. So the recommendation is that all children with nephrotic syndrome should receive pneumococcal vaccine. And if they're 2 to 5 years, then at least one conjugate vaccine dose if they've been prior immunized, and repeat with a polysaccharide vaccine after 8 weeks. Now, this child, steroids have been omitted, and after 4 weeks, the child comes with fever, abdominal pain, and the ascitic tab done shows 125 cells with 70% polys. Now, is this peritonitis? And the child also shows urine albumin 3+. Should we restart steroids? Should we only treat the infection? So here, peritonitis is defined as more than 100 WBCs, if you find, and more than 50% neutrophils. So then you should consider it as a bacterial peritonitis, and you should treat the infection before starting steroid therapy. Of course, a number of choices of antibiotics which people use, Ampigenta, Ceftriaxone, Piptaz, Vancomycin, the last being the most widely used because people think child is immunosuppressed, should hit hard, etc. But the recommendation is not for that. The recommendation is for giving third generation cephalosporins or any penicillin group with aminoglycosides. And to be realistic, this works very well. Most of the organisms causing peritonitis in nephrotic syndrome respond well to third generation things. So you can need not expose them to higher antibiotics in these days of resistant organisms. Stress dose of steroids are important and needs to be given in anybody who has received steroids earlier high dose steroids for more than 15 days in the past year. So if this child has had earlier steroids in the past year, then they do need a stress dose for any major infection. Stress dose hydrocortisone is 2 mg per kg, which you can give in divided doses for 2 or 3 days till the acute phase is over, and then can be tapered and omitted. So this is not the steroids that we give for therapy. This is not prednisolone 2 mg per kg. This hydrocortisone to prevent adrenal crisis. Now, after the infection is over and after 10 days, the urine albumin is still 3+. So now we start treatment for the nephrotic and give prednisolone 2 mg per kg. But here now we don't need to give for 6 weeks. This is a relapse. So we give enough to get remission, which is defined as urine albumin negative for 3 consecutive days and corroborated if needed by your urine protein creatinine ratio. And if that is negative, you can shift the prednisolone alternate day for 4 weeks and then omit it. So the usual duration of steroids for a relapse, therefore, won't be more than 5 to 6 weeks totally, your daily plus your alternate day. So prolongation of therapy is not required for treating infrequent relapses. So anybody who's getting just 1 relapse in 6 months or 2 relapses in a year, just treating the relapse is sufficient for 5 to 6 weeks. Frequent relapses are when you have 2 or more attacks in the 6 months following the initial treatment, or 4 attacks in any year. These are frequent relapses, so they need to be addressed separately. And the same group of frequent relapses, you call them steroid dependent. If they relapse while you're tapering steroids or within 15 days of stopping steroids, and if this occurs in 2 consecutive relapses, because one odd relapse may happen this way, but if it happens consecutive second time also, then you label them as steroid dependent. Essentially, their treatment is similar to frequent relapsing, except that there are more severe variety of frequent relapses, and hence often may require stronger medications. Now, this child had 2 more relapses in the next 4 months, so was labeled as frequent relapser. Now we induced remission. Now we have many options. What should we do now? We have to now give this child something to sustain the remission. We can't just stop like an infrequent relapser because he's going to come back. So do we continue steroids on tapering alternate day for a longer duration? Do we add levamisole? Do we add mycophenolate? Do we add cyclophosphamide, cyclosporin? So now there are many options. Now the recommendation is that if you have now diagnosed frequent relapser for the first time, continue on steroids and tapering dose, maintain on the minimum dose on which they're able to maintain remission, often about 0.5 to 0.7 mg per kg on alternate day, which has been recognized as a relatively non-toxic dose of steroids for a period of 6 to 12 months. So you can give a longer course as long as they're maintained on a lower dose. So this child was continued on alternate day steroids at 15 mg, which is actually a little higher dose for him. It's 1 mg per kg. Question comes, should we add calcium, vitamin D? But on tapering to 10 mg per kg alternate day, which is about 0.6, he relapsed again. So calcium and vitamin D daily should be given if steroids are given for more than 3 months and should be continued as long as steroid therapy is needed. So now we have come to 10 months after initial presentation. He maintains remission if he's given 15 mg alternate day, which works to 0.9 mg per kg, but he relapses on tapering. He's Cushingoid, his BP is normal. He's got a normal weight gain, but he's gained height only by 1 centimeter in the last 10 months. There are no cataracts when we examine him. So the only steroid side effect we are finding is when we measure height. So very important to monitor height and height velocity. If that is not going according to what is appropriate, then you have to consider that as steroid toxicity, and eye examination is a must. So now the question comes, what do we do? We've given 10 months of steroids, he's still relapsing. Should we biopsy? Should we add one of these drugs which we have with us? Now, renal biopsy is not needed in any child who's steroid sensitive. So even if they've had multiple relapses, if you're giving steroids and they respond, they will turn out to be minimal change. And that is the reason that biopsy is not indicated. So what you need to do is actually evaluate for steroid toxicity closely. Levamisole has a moderate steroid sparing effect. So often it is used as a first line. The current ISPN guidelines mentions that you can use either mycophenolate or levamisole as a steroid sparing agent in those where steroids alone is not working for you, or you want to reduce your steroids which you're giving. However, if they're severely relapsing, they have already some steroid toxicity, or they have limited compliance, then they may be better off getting a course of cyclophosphamide, because cyclophosphamide can be given for a period of 3 months. It's a drug which can be given only once in lifetime to prevent future gonadal toxicity and potential for malignancy. So it has to be wisely chosen. It preferably avoided in younger children who are more prone to infections, and avoided in pubertal age group because of the gonadal toxicity. Cyclosporin in the setup of frequently relapsing or steroid dependent, cyclosporin or tacrolimus is used if you're relapsing despite the above medications. So it's not come under control, then you go into it. The new guidelines have also defined what is a difficult nephrotic syndrome in a steroid sensitive patient. So patients who are frequently relapsing in spite of you having tried levamisole or mycophenolate and cyclophosphamide, patients who have obvious steroid toxicity, patients whose relapses are associated with life-threatening complications like severe infections, thrombosis, etc. So in these children, you should consider cyclosporin or tacrolimus. And it's important to remember that although we said no biopsy, if you're planning to use calcineurin inhibitors, a recommendation is to biopsy before using calcineurin inhibitors, because they themselves are nephrotoxic, and you need to be clear what is the state of your tubules interstitium before you subject them to calcineurin inhibitors. The last drug, rituximab, which is, I think, misused pretty widely because many government hospitals give it free of cost. So it's used as first line, second line before levamisole, everything. But the recommendation it is that in spite of calcineurin inhibitors, if you're relapsing, then you can consider rituximab, which is given either as 2 weekly doses or 4 weekly doses and should be monitored for B cell depletion. Now, supportive therapy, do we need diuretics? Not if you're non-steroid sensitive, but if there's moderate or severe edema, you're not expecting rapid diuresis, a weight gain more than 7%, then furosemide should be given. The dosage has to be good. It has to be 1 milligram or 2 milligram per kg per dose, because will not act otherwise. But be very careful that there is no hypovolemia. You should not give it to anybody who's just recently suffered from vomiting or diarrhea. Very difficult to assess volume in a nephrotic child who's edematous. So careful attention to pulse volume, BP definitely is there. But also if you've done tests, then look at the hematocrit, look at the BUN. If the BUN is elevated, the hematocrit is elevated, it may be a volume contracted patient. So then avoid diuretics. Instead, they may require a little bolus. Diet, we already said. One few things, the salt comes mostly from commercial foods. So all your kurkure, lays, chips, burgers, these are the ones which are giving you extra salt. We don't advise to omit salt from the daily food because then the children won't eat anything and it is counterproductive. So added salt and commercial foods, pickles, papad, these are the things to be avoided. There is no need to restrict water unless the nephrotic child is oliguric. So in the oliguric phase, you might need to restrict. But once they are non-oliguric, they can have water according to their thirst. Live vaccines to be avoided on immunosuppressive therapy can be given 1 month after omitting steroids, levamisole, MMF. If you've given cyclophosphamide, then it's 3 months later. If you've given rituximab, then it's 6 months later. I'll just touch a definition of steroid-resistant nephrotic syndrome. If there is absence of complete disappearance of proteinuria, documented also by your urine protein creatinine ratio, despite 6 weeks of daily steroids, the changes from 4 to 6 weeks now, given in the right dose. So biopsy is essential for these children. There is no single definitive therapy, but amongst the various drugs, probably calcineurin inhibitors may give you somewhat better results than the others. So I'll just end with the nephrotic do's and don'ts. This similar to what Pankaj put up, a nephrotic boy with urine albumin 3+, 6 to 8 RBCs, 5 to 6 WBCs. And should we start steroids, investigate, treat with antibiotics, send calcium creatinine ratio? And the answer is definitely investigate before treating if it's a first attack. Establish the diagnosis, check renal function, do your routine test. Don't start steroids before investigating. Don't over-investigate. No need for urine culture. Some pus cells you find off and on in nephrotic. If they are not febrile, it's not a UTI. And no need to do calcium creatinine ratio because microscopic hematuria may sometimes be found even in minimal change nephrotic. So these are his blood counts. So he has a WBC of 15,000, polys of 65. And should we give him antibiotics? Should we give him albumin? His serum albumin is 1.2 grams. Should we give him Lasix? Should we give him steroids? So the answer here is no to antibiotics. Don't treat the counts, treat the patient. Patient is afebrile, well, no need to worry about the counts. We never give albumin for low serum albumin. Albumin infusion is always for an oliguric nephrotic who has not responded well to diuretics and is taking time to respond or has additional problem. So one may consider giving albumin followed by Lasix because albumin also has its own risk of hypertension, pulmonary edema, etc. And there is no Lasix till we've not tried the steroid dose for him. And definitely we need to give steroids. Okay. Now, one other thing is the number of other steroids which are there, deflazacort, solumedrol, IV. No role for any of them, only prednisolone 2 mg per kg per day. Avoid these other steroids. And last, very common, child is on alternate day steroids, develops cold cough, and urine albumin becomes 2+. So should we give amoxiclav, azithromycin, nebulize, give steroids, wait for 4 to 5 days till cold cough is better? So this is a very important point I wish to make. The amount of azithromycin which nephrotics get given by pediatricians and self-taken, because last time you prescribed it, now they prescribe it themselves, is almost that their blood is azithromycin. That's the amount they have. So most of these are viral infections, and viral infections will trigger a relapse. So just treat it symptomatically. Don't give amoxicillin, azithromycin, because in these days of increasing resistance to antibiotics, we need to preserve what we can. There's no need to nebulize. You can wait for cold and cough to resolve and then see if the proteinuria persists, treat it. You can also, if the child has been on alternate day steroids and you're sure it's a viral respiratory infection, you can temporarily for 7 days make it daily steroids. This has been shown to reduce the chances of relapse with the infection when the infection goes away. So this is one option you have. So I'd like to end with this.
I request Kulkarni ma'am to felicitate Uma Ali ma'am. Thank you. A difficult urinary tract infection is the one which either the urine never clears off or even worse, ending with complications. I request Dr. Pankaj Bansali to make the things easy and identify and manage difficult urinary tract infection. Over to you, sir.
Thank you. Now, the topic for me is difficult urinary tract infection. Now, difficulties in UTI. Generally, urinary tract infection, most of us consider it as a simple infection, which involves kidney, ureter, bladder, or urethra. And most of the organisms are still very well sensitive to commonly used antibiotics, may it be oral or sometimes injectable. But nowadays, we are facing problem even in treating UTI at multiple levels, because sometimes what we used to say, more knowledge creates more confusion. So now the difficulty in treating UTI can be at multiple level. It can be difficult to suspect, difficulty at the level of confirmation or ruling out the diagnosis. Sometimes difficulty in treat so-called common and routinely manageable urinary tract infection, and difficulty in preventing recurrences. Now we'll go through cases. A 2-year boy presented with fever at the periphery of 2 days. There was no obvious focus. And the most commonly overused and misused antibiotic, that is cefixime, that was started from a general practitioner in the periphery. Luckily, as we know, most of the fever in pediatric population are because of viral infection. So anyway, they were supposed to respond within 3 days, and the credits goes to cefixime. And probably few credit for overuse of cefixime even go to medical representative. So now it is getting used as a magical remedy even for URTI, which I don't think there is any link between that. But this child followed after 5 days, and this time child had fever, vomiting, dehydration, and when investigated, it showed raised counts with plenty of pus cells. Now, I'm not going into RBC because Dr. Pankaj has already explained in detail about RBCs in the urine. So child was started on IV fluid and obviously injectable antibiotics. Now, as child has received cephalosporin, he was shifted to piperacillin tazobactam and linezolid. Now, before starting antibiotic, do you recommend any other investigation? Urine culture, yes, very good. But when we suggest for urine culture, most of the time we get respond that our lab is not reliable. And anyway, most of them do respond well. So why shall we spend for urine culture? So culture was not done. And on the top, what is the role of linezolid in urinary tract infection as first line antibiotic? Spectrum is entirely different. So anyway, after 40 hours, fever was still persistent, and repeat investigation showed persistent pus cells, persistent raised counts, and now creatinine has increased to 1.2. Now siren rang and patient was referred to higher center. Now, when we see deranged creatinine in urinary tract infection, multiple parameters do come into mind, and most common amongst them is medicine. It can be NSAID, maybe mefenamic acid, ibuprofen, or drugs like cephalosporins. In the setting of dehydration, simple drugs can cause significant nephrotoxicity. Fever, dehydration is a high risk factor for any drug toxicity. Then other causes can be infection itself, another can be shock or poor perfusion. So when child came, already child was in hypotension with altered sensorium, urine culture was sent and was started on meropenem. Already received piperacillin, cephalosporins with linezolid. Meropenem was added. Gram stain show gram-negative bacteria. Culture grew Klebsiella, and that was sensitive only to cholesterol. Now, even nowadays, we are seeing a lot of community-acquired, highly resistant bacteria in urinary tract infection. Initially, we used to always think whenever resistant UTI is generally only after hospitalization, catheterization, prolonged hospital. But nowadays, even community acquired UTI are coming with resistant bacteria. So the role of culture is very important in these patients. After 2 weeks, child improved clinically, fever resolved, urine became normal, but creatinine didn't come back to normal. So this child unfortunately had single kidney, and on follow-up it also showed reflux. We biopsied this child just to rule out whether there is any other pathology, something like tubulointerstitial nephritis by medicines, because in those scenario, steroid may have a role. I'm not saying always PIN has a role, but maybe. And to our surprise, there was no tubulointerstitial changes, and it was only pyelonephritis which has caused damage to the kidney. Now this child on follow-up still creatinine is above 1. So maybe if we would have picked up sensitivity at beginning, probably we could have halted the prognosis, halted the progress of renal dysfunction. So urine culture is very mandatory whenever we suspect urinary tract infection, and we are seeing pyelonephritis with acute kidney injury. And don't delay appropriate antibiotic, and that will be helped by culture report. Second case, a 4-year girl who presented with 3 episodes of culture proven symptomatic urinary tract infection within 1 year. Now, with awareness created by IAP, Pediatric Nephrologist Society, I think most of us are following that every urinary tract infection shall have sonography. Every child with repeated UTI shall have MCU and DMSA scan. But to our surprise, despite repeated UTI, there was no reflux. Then a sad part, when we think as one cause for underlying disease, we try to overlook for other causes. Yes, reflux is more common cause, most common cause for repeated UTI and renal scarring, but that is not the cause, the only cause for UTI. So are we missing something? Whenever child presents with UTI, even with first UTI, few of the points in history and examination are mandatory. And particularly when child is presenting with repeated UTI, then these points have very high importance. What was the antenatal scan? Whether was there hydronephrosis, hydroureter? How was the bladder? How is urine stream? Most parents feel urine stream is normal without knowing what exactly normal urine stream is. So if possible, we can look for voiding pattern, or at least ask them to get a voiding video. History of constipation. This is one of very high risk factor for repeated urinary tract infection. Then holding maneuver, what we call Vincent's curtsy, where child apply pressure over the perineal area and avoid going to bathroom. On examination, are there signs of spinal dysraphism? Is there synovial adhesions or tight phimosis? Now, these all factors increases risk of repeated UTI, and I think it does not take much more than hardly half to 1 minute to look for these points. I know we have been taught in our pediatrics that every child presenting in our OPD for first time should have genitals examined, but in a busy OPD, most of the time we forget that point. Now, in this child, his ANC scan was normal. He had history of holding urine, and she used to pass urine hardly 2 to 3 times in 24 hours. So that is significantly less amount of urine. She had history of constipation since last almost 1 year, and USG showed initial USG was reported normal, but most of the sonologists forget to assess in detail about bladder, because sonology needs full bladder distended volume, wall thickness of bladder during distended space, and how much is the post-wire residue. And this requires time, and busy sonologists generally don't find time to look for these minor points. So if I don't get report with these pointers, I will send back again to radiologist to look for this. And once or twice, once you send, the next time child come with proper report. So we need to emphasize sonologist for these points. Now for 4-year child, bladder capacity of 200 ml is quite high, and post-wide residue is also significant. So this, what we are dealing here, probably child has holding maneuver with constipation, all that has triggered for over-distended bladder. Now, whenever we see some bladder abnormality, one thing that we thought of is neurogenic bladder, but it may not be. Now here, before advising any further investigation, what we need is adequate treatment of constipation. Adequate does not mean that when child presents, we give laxative, purgative, and once child relieve, we stop medicine. No, we may need to give longer course of medicine so that he is completely treated of constipation. We need to train bladder. In our culture, we start bowel training quite early, but bladder training is almost missed by most of our parents. So every 3 hourly, parents should be emphasized that child should void every 3 hourly. Child should be encouraged to go to washroom for voiding. And many of these problems related to bladder can be cured because of adequate treatment of constipation and proper bladder training. Third case, a 1-year girl hospitalized for acute pyelonephritis. USG showed right-sided mild hydronephrosis and reflux on that side. So child was advised follow-up. Child presented after 1 month as a routine follow-up without any symptoms. Now, what investigations do we need in this child for follow-up? Definitely no sonography or MCU, because we are not expecting magic that within 1 month everything will resolve. But every nephrologist is emphasizing on urine culture. So patient underwent urine culture. It showed E. coli with significant colony forming units and sensitive to injectable antibiotic. NFT is nitrofurantoin, but nitrofurantoin is not a good drug to treat pyelonephritis. It can be used only and only for prophylaxis. So child was started on piperacillin trazobactam. After 2 weeks, child presented with high-grade fever, dysuria, turbid urine, plenty of pus cells, and again raised creatinine. So can it be because of reflux or can it be something else? Because so-called 3 episodes within 6 weeks of time is too much for a kid and even for parents. So if we go for first slide, at presentation, child was asymptomatic. So what is this? This is asymptomatic bacteriuria. Urinary tract infection cannot be silent. There might be some non-specific features. Maybe child present with diarrhea, failure to thrive, or urinary tract symptoms. But if child is asymptomatic, don't emphasize on repeated urine culture. I'm sorry to say, but many of our pediatric surgeon has habit of every reflux patient following up with urine culture and then treating urine cultures. Right now, what madam said, we are not treating reports, we need to treat child. And asymptomatic bacteria means these bacteria have colonized our uroepithelium and they are not harmful except in immunocompromised patients. And we don't need to eradicate them. Same thing what happens when we use high-dose oral antibiotic that clears our gut flora and exposes us to more pathogenic organisms. So same thing happened here also. So we don't need to treat asymptomatic bacteriuria. Now, the last case, a 6-year boy presented with urinary frequency, urgency, urge incontinence. There was no fever or dysuria. And classically, there were no nocturnal symptoms. It was only daytime child was complaining. And it was somewhere around when child started going to schools. Urine didn't show significant pus cells. Culture was stained. And as child had lower urinary tract symptoms, our first differential was urinary tract infection and child was started on cefixime. Followed after 3 days, symptoms were still persistent. Urine culture came sterile and sonography also was normal. So what is it? Dr. Pankaj just mentioned his slide. It is in simple language, we can consider it as an irritable bladder. So it is not urinary tract infection. It is not stone. It is not hypercalciuria. But we have found many of the kids presents with just irritable bladder with increased urinary frequency. And after COVID, we have seen a lot of patients coming with these vague symptoms. Most of them do resolve spontaneously. We don't need significant medications for them, but few of them take longer duration, even up to 2 to 3 months also. Sometimes anticholinergic can be of help in these kids. So before starting antibiotic, even we shall be sure that we are treating urinary tract infection we have diagnosed it and then start management. Because once we label as a urinary tract infection, then next investigation will start. Now, every UTI shall have a sonography. Every UTI in less than 1 year age shall have MCU as well as DMSA. And every UTI less than 5 year, even if sonography is normal, shall have at least DMSA scan. Antenatal sonography, which most of the Western literature do allow that if antenatal sonography is normal, we don't need to be very aggressive. But frankly, at least where I practice in Aurangabad and surrounding area, most of the sonography are not done very properly, and many of the things on antenatal sonography are missed. So probably this might be the first occasion, first contact with the patient where we can pick up urological abnormality and don't allow patient to progress in CKD. Untreated, improperly treated UTI can cause scars over kidney, and they can be harbinger for early onset hypertension, second or third decade hypertension, or even CKD. Now, there are few points again. Whenever there is an antenatal hydronephrosis, one sonography is mandatory after delivery, even if third trimester sonography is normal. If child develops UTI, even if last sonography is normal, we shall plan MCU, because even with resolved antenatal hydronephrosis, 20% of kids can have reflux. So UTI with history of antenatal hydronephrosis, MCU shall be done. If pelvis diameter is more than 10 millimeter, further workup is required. And good urine stream does not rule out anything, not even posterior urethral wall. It's very common practice. Gynecologist says that if child passes urine, you don't need to worry, the swelling over kidney is going to resolve. But it is not like that. Even we see posterior urethral wall, where we expect urine stream should be abnormal, can have normal urine stream. So don't consider normal stream as a pointer to rule out PU wall. This is the last side. Probably every year we are seeing one patient, well operated case of meningomyelocele, where child was followed up well for lower limb, for bowel habits, doing well neurologically, and progressed to CKD. Because the part which is missed many of the time is to assess bladder. Whenever we operate meningomyelocele, we need to follow up bladder structure and physiology till child grow up, because they can land up with neurogenic bladder and progress to chronic kidney disease. Thank you.
Thank you very much, sir. Friends, it was very enlightening session involving two stalwarts pediatric nephrologists, Dr. Pankaj Deshpande and Dr. Pankaj Mansali. And the goddess in pediatric nephrology, none other than Dr. Uma Ali Madam. So we are blessed to have all of you. All of them, they gave clear-cut messages and they were very precise. So it was very difficult for us to give you take-home messages. But still, we will give some highlights from sir's talk. He said community-acquired UTI, we have to take seriously, we have to treat appropriately. And you don't treat asymptomatic bacteriuria, you said. You have to do sonography in every UTI, as you said. As far as Dr. Pankaj Deshpande sir's talk, we generally neglect specific.
We have to wind up.
Yes, thank you.
Thank you, sir. I would request Sandorkar sir to felicitate our speaker. I request Dr. Chopra to felicitate our chairperson.
Let's move to the equally exciting panel. I invite on stage speakers, Dr. Uma Ali, Dr. Sagar Lad, Dr. Lakshmi Bond, Dr. Kedar Malvatkar, and moderator, Dr. Jitendra Gawane. Intravenous fluid infusions have become the sine qua non of medical treatments. Infusions act as a multipurpose vehicle to transfer fluids or other soluble materials into the bloodstream, notwithstanding the millions of bottles of IV fluids used right across our country as a ruse of having treated the patients. Does it need to be reinforced that IV fluids themselves should be considered as drugs or as best carriers of drugs? We then have named them with alphabets nearly from A to Z without bothering to know which contains what. The quantum given most of the time is still the bottle that is empty. Therefore, what are the contents? When are they to be given? How much and at what rate must be clear in our minds. To discuss this today, we have with us these experts. I request to start the session.
Good morning, good afternoon, everyone. Thank you, organizers, Sharmila ma'am, for giving us opportunity to conduct this wonderful talk. Friends, when I was a junior resident in pediatrics in first post, and my counterpart friend was in medicine people used to write just order like 1.RL, 1.DNS and 1.5%, and that's it. But when here in pediatrics, we used to calculate and what fluid, this and that we used to write, and then we used to get confused and they used to laugh at us. And I was wondering whether I used to envy them that they are writing so easily. But to further complicate this matter, last 15 years, many things have been changed over in using the fluids in practice. As Madam said, these IV fluids needs to be taken very seriously when they are invasive, and it should not, it plays with the life of a child. So I am very fortunate to have wonderful panelists headed by Umali ma'am, Kedar sir and Sagar and Lakshmi ma'am. So I welcome you all. Let us start the session. First, I will ask Kedar sir. Sir, what is the total body water content of our body, and why should we take this IV fluid as a very seriously?
Homeostasis of fluid is absolutely constant in our body, and it is required for the normal functioning of all the organ systems in the body. So basically, in health, this homeostasis of fluid depends on intake, output, and distribution of fluids across all the compartments of the body. Now, when you come to the total body water, the maximum amount of water is in fetus. It is about 90% of the total body weight. And as the fetus grows, in preterm, maybe probably it is 75 to 80, and at term, it is around 75% of the body weight. As the body grows, the body water becomes less in percentage, and at about 1 year, it is about 65 to 70%. And in adults at puberty, as there is pubertal growth, the fat content in females is more as compared to the males, and in males, the muscle content is more, muscle cells are more. So the females have an adult body content of around 55%, and adult males have around 60%.
So friends, most of the body weight what we are having is constituted by the water. Almost 65% to 75% in all age groups we have a water. So we need to know, we need to maintain the equilibrium between this biggest compartment. I want to ask Kedar sir again how this water is divided in various compartments.
Water is basically divided into an intracellular compartment and the extracellular compartment. In fetus or in newborn, they are almost equal, but as the body grows, they form about the intracellular compartment is about twice that of extracellular fluid, or in other words, it is about 40% of the body weight, whereas the extracellular fluid is about 25 to 30% of the total body weight.
Right. So 25% is in extracellular fluid, that is plasma and interstitial fluid, and intracellular is 30 to 40% of the body weight. Now, Kedar sir, to maintain this equilibrium in disease and health, we need to know what available options of IV fluids we have. So can you elaborate on that?
Basically, IV fluids are divided into two basic types, the colloid fluids and the crystalloid fluids. Crystalloid fluids are those with electrolytes as the micromolecules or the low molecular weight crystals. And the advantage of crystalloids is they move around the membranes easily. They pass through all the membranes. Colloids are with higher molecular weight substances as and they remain in intravascular phase for relatively more amount of time as compared to the crystalloids. They are supposed to be about 2 to 3 times better than crystalloids. But unfortunately, there are no definite advantages of using colloids over crystalloids. We'll be discussing that later on in each of the conditions.
Yes, sir.
In general statement, I would say they are no definite because colloids have a lot of side effects in the form of anaphylactic reactions, then probably pre-renal azotemia, then coagulopathies, nephrosis, and some metabolic abnormalities with albumin. Okay.
So-
Enumeration of fluids, the routine fluids, normal saline, dextrose normal saline. I will not go into details of the contents and other things, but these are listed. On left, they are crystalloids and right-sided fluids are colloids.
Right. So we are these various options of fluids available in our basket, and we have to select very wisely and judiciously which one to use in which condition. So I ask Lakshmi ma'am, what are the indications of IV fluid? These are for resuscitation, maintenance, and replacement of ongoing fluids. So we use these fluids for resuscitation or for maintenance of the equilibrium or for the replacement of ongoing losses. Dr. Lakshmi, can you tell me about when and what we should use in resuscitation? Can you start from whether there is a need for resuscitation?
Basically, resuscitation means reloading or restoring the circulatory volume when it is going to be collapsed. So if you consider it, it is a 3-stage process. If you consider the resuscitation, first is look it for whether the signs of hypoperfusion, if the child is having, that is any signs of shock, if it is there, signs may be delayed CRT, hypotension, oliguria, or altered sensorium. If it is there, then you need to go for the resuscitative fluid that we know according to the EGDT, early goal directed therapy, that is 20 ml per kg of the NS bolus. And if it is needed, then give it more according to the survival sepsis guideline. But if it is not there, the signs of hypoperfusion is not there, then think about whether, look for the child if it's having mild, moderate, or the severe dehydration according to the WHO criteria. That is, if it is 3 to 5% or 5 to 9% or more than 10%. If the signs of dehydration is there, then go for the deficit fluid, calculating the deficit fluid according to the percentage of dehydration. And in both of these two phases, you need to look for whether we can go back, whether we can encourage the oral feed or the enteral feed at any time of these stages. And the third, most important stage is the type of dehydration we are looking for. That is whether it is a hypotonic, isotonic, or the hypertonic type of dehydration. And during both of these 3 phases, you need to look for the urine output, the electrolyte balance, and the electrolyte you need to check for, and obviously the osmolarity also, but we don't go for routinely. So these are the 3 phases we need to consider.
Yeah, so very well said. We need to know whether the child is having shocky features or the child is dehydrated, or whether child can take orally. If child can take orally immediately, we have to switch to oral therapy as early as possible. So coming back to resuscitation fluid, can you elaborate more?
So resuscitation fluid, as it said, we need to give it rapidly, but depend upon the volume status and the comorbid condition, we need to decide how much amount of the fluid we need to give. And again, the fluid of choice is always and always the isotonic fluid. And we need to look for but where we need to stop. It is easy to give more and more, but in hypovolemic shock, septic shock, depend upon anaphylactic shock, cardiogenic, and dengue hemorrhagic shock, which we'll be discussing, the amount of fluid we need to give is depend upon the volume status and the comorbid condition of the patient. And Where we need to stop and go back to the stage 1 and stage 2 and start the maintenance fluid is depend upon the signs of improvement when the patient is showing. The clinical signs of improvement that are more reliable. So go back to the maintenance fluid and start the enteral feed as early as possible.
So resuscitation fluid used always is a isotonic fluid, isotonic saline we should use. As madam said, will you
Yes.
elaborate the signs of?
Yes, signs of
yeah.
dehydration as already said, and the poor perfusion, hypoperfusion, that is the delayed CRT, tachycardia, oliguria, hypotension, and one more is the altered sensorium, which should be there. Then the signs of dehydration according to the WHO criteria. This is the second step, that is mild, moderate, and the severe. And the type of dehydration. This is the 3-step process which we have to go while assessing the patient and starting on the fluid.
Yeah. So we decided, we resuscitated this child and we decided that now this child requires IV maintenance fluid. The most important part of our practice is maintenance IV fluid. So the goal of maintenance IV fluid is to prevent the dehydration, to prevent the electrolyte imbalance, to prevent the ketosis, and to prevent the breakdown. So Umali ma'am, we decided that we should start IV fluid and we are planning for starting the IV fluid. So how we should go ahead from this point onwards?
Can I take the liberty of making some comment on resuscitation?
Yes, ma'am.
before?
Yes, please, ma'am.
See, our ideas have changed over time. One thing important in medicine, we keep unlearning and learning because we never know the real truth of the body, as Dr. Suhas Prabhu pointed out. So we were the same people who said 20 ml per kg, give as rapidly as possible, not improved, give another 20, give another 20, at least 60 ml per kg before you start dopamine. The whole thing is reversed now because increasingly it's coming to light that when you push normal saline like this, you're actually harming the glycocalyx layer of the endothelium. And that's one of the things besides your sepsis, which gives you capillary leak, edema, etc. So become more moderate in how you give the fluids. So if you have a hypotensive patient, saving life is the most important. Push 20 ml per kg, push rapidly, bring up the BP. But if your BP is normal, but you have signs of shock because of poor perfusion, there is no need to push very rapidly. You can go more moderate, give 10 ml per kg, and after each bolus, reassess, do you really need the second one? If you still need, go ahead. But if you feel you've restored, there's no need to go further ahead. So these are some of the changes that have come around of being a little bit more cautious. But same time, it's a fine balance because you don't want to keep the child in a prolonged state of shock. So this is where the clinical examination after each bolus becomes very vital to decide whether more fluid or not required. So I'll come to the question which you addressed, that's a maintenance fluid. When we say maintenance, why do we need fluid? Because there are some losses occurring even when we have no disease. We call it insensible loss because we can't measure it when it comes from the lung and skin, and sensible loss from the urine because we can measure it. And the combined, including your stool losses, is what we lose every day. If somebody cannot take orally, and if we do not give that, then you're going to cause deficit. So it takes, but what we give should meet criteria that you have to maintain euvolemia, you have to maintain euglycemia, your electrolyte imbalance, and an important thing to keep in mind is your osmolality, which we often ignore when we are giving maintenance fluid. So these are your goals. So when we give maintenance fluid, should I go further?
Yeah.
The choice? Yeah, we have always learned by one study of Holiday Barrett in Holiday Segar in 1950s, which was a study on just some 40 odd children who were healthy children. And based on how much fluid are these children taking, how much electrolytes are they consuming, they derived this, that 100 ml per kg for the first 10 kg, which we all know, I won't repeat it, 2 to 3 milliequivalent sodium, potassium, and have been using because healthy infants grow well on that much fluid and electrolytes. But does that apply to sick children? because your physiology changes when you fall sick. Okay. When I'm saying sick enough to be hospitalized. Now, if you go back, nature never does anything redundantly. We call it inappropriate ADH. But the ADHs come why? Because in those sick, they cannot go to the river to drink water. So they will be deprived of water. So nature created ADH. Okay, so the more sicker you are, the more ADH will throw. Now, what has been in evolution for so many years is not going to change so rapidly just because we foolish doctors don't understand it and push in IV fluids. Okay? So we have iatrogenically created many problems by giving IV fluids and inappropriate to the natural events which are occurring in response to disease. So because you have ADH, what happens is that you won't be throwing out water. You will retain all water. Now, if we give some dilute fluid, like 1/5 saline or isolate P, it is 70% water. Yeah. Okay. So the water, we are always looking at sodium content of IV fluids, not the water content. Now that 70% water, this child may not be able to excrete part of it or all of it and will retain and dilute the salt. So that is how this whole business of hyponatremia in sick children have come up. And they've been where children have gone for simple things like herniatomy, elective appendicectomy, and have died post-operatively. This happened in US and was found to be hyponatremia. The only thing was the fluids. So now isolate P is actually banned in UK. They are not supposed to have it on the same floor where pediatric patients are kept, just so that it's not by mistake given. That means it goes that because of this ADH, which is present during illness in most sick children, we should give fluids which are not very dilute. Now, the more sicker you are, then even maintenance give us NS or DNS, depending on your glucose needs. Maybe children in the wards who are not so sick like children in ICU, at least half NS, half DNS, they should get and not isolate P or 1/3 during the acute phase, first 2-3 days of the illness. So the importance is seeing that we are having even your half strength NS is 50% water. So it's not suitable for ICU patients. And when you come to NS, that's only one which is 0% water, it's only salt. So that is why for maintenance also you give normal saline in ICU. But for less sick children, you may choose half NS as a safer option to prevent iatrogenic hyponatremia, which can cause cerebral edema and even herniation and death. So that is how the rationale has totally changed of how we are giving.
Yes, sir. So out of this talk, if you remember this thing told by madam that if the child is sick, we are giving the bolus initially and creating a disturbance in body's adaptive mechanisms to help this child. So the antidiuretic hormone is already there in body, and if we are offering the isolate P, then we are creating more problem, and a normal child like post-operative herniatomy also died in that case. So please remember, isolate P should not be used for sicker children as a maintenance fluid. So which fluid to give for sick children, ma'am? One more time we will reinforce.
Yeah, so basically for sick children, even for maintenance, we are not using hypotonic fluid. That means isolate P, 1/3 DNS. And we should use fluids with less water content, like NS, or if they're not very sick, then ringalactate, if a little water can be allowed. And in the wards, half NS. Exceptions are newborns. Newborns don't come into this category at all. And other things, like you cannot have, just like you don't have one antibiotic for all illness, you don't have one prescription for all patients. Now, if I have a patient whose basic sodium in ICU is above 140 or 145, I will not use full strength NS. Okay, because I'll cause hypernatremia now. There's something that is preventing water excretion in that child, in sodium excretion. The other thing is that if there is a cardiac patient or a child with a renal problem who's this thing, I would be very cautious about using full strength NS because it may tilt their balance. So these are few exceptions which we have to make when we are using.
Right, ma'am. Ma'am, when to use normal saline only versus DNS as a maintenance fluid?
I think DNS, sugar, we don't want to use if the child has a CNS problem or has burns. We want to use plain NS, just monitor the sugar because they get stress hyperglycemia.
Yeah.
But for others who don't have other illness, check if the blood sugar is normal. We
Right.
can use DNS.
So blood sugar is
for
normal,
maintenance.
then we can use DNS. Otherwise, in CNS cases, the stress is so much that the stress hormones are released and that itself takes care of the sugar. Ma'am, many of the times you were saying Holiday and Sega formula, and many of the times we use weight as a parameter to calculate all things. Are there certain conditions where we want to look at the body surface area and not weight for the calculations of fluid?
I think one is burns,
Yeah.
where body surface area is used. And also as the child gets older,
Yeah.
over 30 kg, if you start calculating on body weight, you end up giving enormous amounts
Right.
of fluid. So for about 30 kg, it may be better to go by surface area.
Absolutely.
More moderate in your.
Yes, so we are now having obese children, and in them body surface area calculation is better than per kg calculation. Dr. Lakshmi, there are few conditions where we want to restrict the fluid and not give the Holiday and Segar formula wala fluid.
Restriction of fluid, as madam said, is in a normal child, the kidney is functioning normally. That is, kidney is excreting the volume in a normal way. But in case of the sick children, the ADH is on a higher side. So the kidney is not functioning in a normal way. The certain condition like the oligouric phase and in the AKI, we are giving just insensible water loss plus whatever the urine amount the child is excreting, that is ml per ml. So that is the condition where we need to restrict the fluid. The other condition is where the minute ventilation of the patient is on a higher side. That is a minute ventilation in case of the respiratory distress. That may be because of the respiratory causes, that may be because of the cardiogenic causes, or maybe because of the metabolic acidosis or the septic shock. But when the patient is on a mechanical ventilatory support, that 30% of insensible water loss is prevented and preserved by the humidified ventilation we are providing, either by the NIV mode of ventilation or by the invasive mode of ventilation. So we need to restrict to the 70% of the maintenance fluid in those cases. So these are the two conditions where we need to restrict the fluid. And again, the madam has said that in the resuscitative phase also, we need to think of where to stop. That is the utmost important. And according to the reset guideline, that don't give on giving the fluid 20 ml, 20 ml, as per the said by the madam, that it is a dangerous thing which is happening and injury is there to the glycocalyx and the renal injury, and the ICU is prone for the injuries like this.
Yes.
So these are the two conditions. Again,
there are a few conditions where fluid overload can occur. So where we should be very alert for that.
the fluid overload, we need to monitor it frequently in ICU. What we call it as a fluid overload is a fluid input, whatever we are giving to the patient, minus the fluid output in the liter we were getting, and whatever the drain the patient is having, that amount. This is what we need to calculate the fluid overload daily, about 12 hourly also, and multiplying it by 100, we get the percentage of fluid overload. So we need to think about that. It should be less than 5% always in your ICU. And if it is 5 to 10%, it increase the chances for mortality if more than 5% fluid overload is there. And if it is more than 10%, then need of the renal replacement therapy is also on increased mode. So risk factor which the patients at risk on fluid overload are congestive cardiac failure, cardiac surgery, renal failure, AKI, even in case of the ARDS on ALI and septic and the septic shock. Anything?
Right. You want to add?
No, I think fluid overload is one of the most important things in ICU patients.
Absolutely.
which has been increasingly recognized as a major contributor to a poorer
Mortality.
outcome, irrespective of the severity of illness. After it occurs, getting rid of it with diuretics, sometimes not very effective, then you land up with having to dialyze that patient to remove that fluid. So right from the beginning, once you've resuscitated, we need to be very conservative in the amount of fluids we're given. And some of the things to look at is all the drugs, multiple drugs go
Right.
in ICU, and each one is in some vehicle of 10 ml, 20 ml, 25 ml. They are all adding to your fluid intake. So they have to be kind of curtailed to be in smaller volumes, so that in the end, if you add all that, you might find that you don't even need maintenance fluid. Your child is ventilated as it is, so insensible water is not there. Urine output is not very high. So child is really not losing much. And already so much IV drugs are going on. So many times you end up, if you put everything in calculation, that the amount you need to give is actually very little. So we have to be a little conservative to prevent fluid overload.
Right. So whenever patient is in ICU, please make a note of what medications we are giving and in what vehicle we are giving, like in 10 ml of NS or like that, and calculate and deduct that from your total maintenance fluid, so that we don't land up in a overload state. So these patients who are on maintenance requires monitoring. Dr. Kedar, can you tell how to monitor these patients who are on IV maintenance fluid?
Whenever we start any fluid, I think we should treat it as a drug rather than a fluid.
Absolutely.
So any principle of drug therapy should be applied to the fluid therapy. Secondly, when we start fluid as a resuscitation or the initial maintenance or any case of deficit of fluid or dehydration, then we first have to see whether the child is responding to that. The first probably clinical symptom is the improvement in the sensorium, in reduction in the anxiety, reduction in the irritability and other things. The second is the clinical signs, the pulse, the blood pressure, and the skin and the tongue. For example, the dry tongue will become the
Correct.
moist in appearance,
Yeah.
and the dry clammy skin becomes the change into warm extremities, and the skin turgor improves. The third thing is the monitoring of urine output.
Very
Every PICU monitors urine output hourly or even before that, and it should improve to 0.5 to 1 ml per kg per hour to say that the fluid correction is going on adequately. We can have daily or twice a day weight even to monitor fluid.
Correct.
Apart from this, some investigations like bedside USG, many adult ICUs follows daily or twice a day bedside USGs. In probably PICUs, we don't follow that too much, but to monitor the IVC and other things.
Size
And
of
of course, the invasive investigations like hematocrit, blood urea, urine electrolytes, and further invasive procedures like CVP monitoring and other things. So in this way, we can monitor fluid therapy appropriately.
Yeah.
And after correction, we have to monitor, as has been rightly conveyed, the overload of the fluid also. So we have to initially probably increase the fluids and then probably decrease the fluid if it is adequate.
Yes. So, Umali ma'am, most of us are having small nursing homes in periphery, and better said than done is very difficult to monitor urine output. Per hourly monitoring is just a dream for most of us. So how we should go about it?
I think this is a very important question, because we tend to talk of, because maybe we've trained in bigger centers and seen all this, but that may not be always applicable where we are practicing. So I think one is, who needs a urine output monitoring, closely. I think one is the parent themselves can monitor if the child is not very sick, that how many times the child has passed urine. So with these days with the diaper on, many times they don't know. So in which case the option is, if diapers are being used, then diaper weighing. That can tell you roughly if it's removed and you weigh how much it is. You get an approximation, which is fair enough. So one is the mother's counting if they're not dissing, then the diaper weighing, which is simple. In in a male child, one can use an external collecting like a condom catheter, etc., which is not invasive, can be
Non-invasive.
just applied. And even if you collect for 6 to 8 hours, you get a rough idea,
Right.
okay, this kid is passing urine
Yeah.
well. Now, if mother
Correct.
just tells me it's enough. And if he's not, then it rings an alarm bell. So that initial
Correct.
6, 8, 12 hours, if you can manage. In girl child, it's little more difficult because there's the bags and all that. They don't stay in place. You can try, but they often slip off with the child's movement and everything. If that is one option. So the only option in girl children is to have either diaper weighing or mother keeping it open and seeing how much urine the child is passing.
Right.
Would be there. So I would say that urine catheterization, which we do routinely in
ICUs,
bigger
yeah.
ICUs, I don't think we need to do that, but we need to definitely see urine output and identify those at risk, which you'll be able to in the first 8 to 12 hours of admission.
Correct.
You know, so then you have tried that those who have not likely to get problems, and those who may land into problems, and those who may land into, keep a closer watch for a longer time.
Right. So first few hours of admissions are very crucial, and we always have alternative methods of monitoring urine output, and don't just say that this is per hour monitoring is difficult in our scenario. We can do that in various methods, what madam said. Sagar, I want to know, so there are some special situations, epidemics, and right now seasons of the hemorrhagic fevers going on. So I want to know special situations require special fluids. So one of them is dengue, DK, and I want to know about neonate also, sick neonate especially.
Now, very important in the dengue is a fluid management, because dengue are very fluid sensitive, and not all the dengue, but especially when the dengue is in a leaky phase, and the fluid of choice is a normal saline or a ringer lactate. Now, as per the WHO guideline, when a dengue, it can be present as a compensated shock when the BP is maintained, or maybe a hypotensive shock. So when they are in compensated shock that the BP is maintained, our goal is to maintain their blood pressure to prevent their leaky phase. So you start with the isotonic saline. Initially, as per guideline, you can start with a colloid of 10 to 20 ml per kg over 1 hour. And then you monitor the child. If the child is still in a leaky phase, the sign of a peripheral perfusion is poor, you can start with the fluid of a 7 ml per kg, 5 ml per kg, 3 ml per kg, or 1 or 2. It is all the monitoring that we need to do. Very important thing is that we need to monitor the BP along with your, if possible, put a invasive BP line or even a non-invasive BP line along with a urine output. In this case, ideally, we should put a urine catheter and see how much fluid is going in and how much fluid is coming out. If the child is not improving, if the hematocrit is start increasing, then secondary you use a second bolus of a crystalloid. Now, as per guideline, the main fluid management is normal saline, but normal saline, excess of a use of a normal saline can cause a metabolic, hyperchloremic metabolic acidosis. You can use a ringer lactase as the fluid for the dengue, but current trend use of a colloid as a 5% or 20% of albumin is very good as a starting fluid. The only problem with albumin is a cost, but the cost is not much factor in the patient. You can start with a straightway albumin. 5% albumin you can use as a maintenance fluid also, or a 20% albumin you can run it over 24 hours also, which is a colloid. And if you use a colloid in early phase, especially in the compensated state or in the hypotensive state, definitely it helps. One second important thing I want to stress, when you give a fluid in a dengue, they are very fluid sensitive. If the intracath is out, the BP goes down. So when they're especially in the leaky phase. Secondly, use a syringe pump or an infusion pump when you are going to give a fluid in the dengue patient, especially in the state of a shock. Or sometimes you use a dialer flow, what you can use, so that exact calculated amount of a fluid will go in the child. And definitely you to monitor every 1 or 2 hours, then accordingly you titrate the fluid of the child.
Right.
Especially in the hypotensive phase, you should be very cautious, because this hypotensive phase very likely to go into the cardiorespiratory arrest. And we have seen once they go into the shock, it is very difficult to revert them back in spite of giving an inotrope, vasopressin and everything. So we don't want that compensated phase to go into the hypotensive state. And definitely when they're in hypotensive, you must give lots of a colloid, especially albumin. Generally, they don't need a platelet, they don't need a FFP. If the hemoglobin is dropping down, definitely they use a PCV, which can act as a colloid and can increase their blood pressure. Usually that leaky phase lasts about 48 to 72 hours. Don't give any Lasix or furosemide during the leaky phase. The condition can become worsened because in this case, there is a less intravascular volume. So we need to maintain intravascular volume by giving either a crystalloid or colloid.
So Sagar, this leaky phase usually lasts for 24 to 48 hours. And what is the time of reversal we should pick up clinically?
Yeah, especially the child show the sign of improvement. BP started stabilizing, urine started improving, especially they go into diuretic phase when this leaky phase goes down. Then automatically the BP started stabilizing, heart rate started coming down. All the signs like capillary refill time, peripheral warmness, all started improving, and child obviously show improvements. At that time of phase, you start decreasing the fluid and come to the either a 2 or 3 ml per kg, and then titrate the fluid as per the urine output. Sometimes we need a restriction also. Sometimes with so much of a fluid, they may get bloated up. In that case, you might need a use of a diuretics or restrict the fluid when they passes from the leaky phase.
So recognizing the reabsorptive phase is very important in dengue fluid. Otherwise, we will end up in more complications than the leaky phase. What about DKA fluid?
Now, again, the DKA is lots of guidelines. This is a recent guideline by British Society of the Endocrinology and Pediatric and 2021 guideline. Generally, the difference in a bolus of a DKA and a shock is to give a bolus of a 10 ml per kg over a 1 hour. But if the child is present in a severe shock because of a DKA, even if you are giving a too much of a boluses, you can give 20 ml per kg over 15 minutes and then give 2 boluses. If the child is not improving, then you start on an inotrope. Too much of a fluid in a dengue is dangerous because it increases the cerebral edema, and the main cause of a death in a DKA is because of a cerebral edema. So fluid restriction is very important. Don't use a liberal use of a fluid in the DKA. It should be slowly giving the fluid in DKA.
Yeah. So before colloids, I want to ask
one more. I want to stress about what already Madam has told about using the fluid in the resuscitation.
Yeah.
There is a lots of studies, recent study in 2011, which was done in the Africa, that had changed the scenario that instead of giving 20 ml per kg of 3 lots, the child can land up into the problem. So use a 10 ml per kg of the fluid, reassess the child. If the child is improving, then you can no need of giving too much of a bolus. Studies are called a FEAST trial, which was done in 2011 in African children, and they have seen that majority of the children were anemic and with malaria, and they found that too much of a fluid landed up into the in the complications. Same scenario in a developing country in our India. So majority kids are anemic also. So don't push too much of a fluid in the children.
Yeah. So at this point, I want to ask about sick neonate, also day 3, day 4 old child. Should I use DNS or should I use ISOP?
Especially in the newborn, the physiology is different. So specifically, they need isolate P. More of a water content should be more because there is a more water loss in the child in the newborn. So only newborn less than 1 month, you use either isolate P or you make a 10% dextrose with a CRL and with a KCL and monitor the blood sugar of the child.
Correct. Thank you.
Yeah, so that is the only scenario that you use a 0.45 DNS in newborn, 1.5 times of a maintenance fluid. Yeah, only
we will discuss in colloids.
Yeah.
So Dr. Lakshmi, can you elaborate about colloid use in practice?
Yes. Colloid, as sir has said, it is a plasma expander, and 80% of the intravascular oncotic pressure is made up because of the colloid. If you give crystalloid to the patient and after giving almost 1 liter of the crystalloid, after 1 hour, only 250 ml remains in the intravascular volume. That is the only disadvantage of the crystalloid when it gives to the patient. And that is the only advantage of the colloid when in a practice. Natural colloids and the synthetic colloid, it has been divided. The natural colloid, we are having the albumin, and in a synthetic colloid, we are having the gelatin starch and hydroxyethyl starch and polysaccharides. But in case, as there is a lot of debate about colloid versus crystalloid, and lot of studies are there. And according to the survival sepsis guideline in 2016 recommendation, there are only weak recommendation. And if we are increasing the volume replacement and the septic shock and the sepsis, when patient requires substantial amount of crystalloid, when the requirement is on a higher side, that is, sir has said, In a special scenario like dengue hemorrhagic shock, the albumin is recommended, colloid is recommended. Yes, of course, in case of when there is a hemorrhagic shock, blood is recommended. In case of the coagulopathy, plasma is recommended. And like a dengue hemorrhagic shock, the colloid is recommended, and sir, as said, gelatin, gelfusin, what we are using, that is in a special situation. But here, what comes a role that what is safe, what is accessible, and what is at a cheaper rate, that you need to decide according to the patient, your patient, and accessibility, which what is available. So crystalloid is the safe, it is available and accessible.
Yeah.
So
Correct. So a lot has been said about nowadays about using albumin early. Sagar, you will take or
Yeah, the indication of albumin is especially use of a colloid in special situation like hypoalbuminemia if documented, nephrotic syndrome in the plasma exchange, and cardiorespiratory surgery, cardiothoracic especially where you need urgent to maintain a blood pressure. At that point, you can use albumin. The problem with albumin, when you are using a colloid, you need to see the output of that child. If the child has got a dodgy kidney or if urea creatinine is climbing up, output has gone down, then definitely it is hazardous to use a colloid in the high dose. So, but if the child is in the shock, then definitely you can use the albumin. Albumin has got definite role in the management in the patient with the shock.
right? Lakshmi, you want to add?
sir has already explained. And one more thing I want to add up, that is hydroxyethyl which increases the rate of renal replacement therapy. Almost 32% increase in the renal replacement therapy rate when you are using HES or the gelatin. Madam, no.
So the synthetic colloids, we have starch, we have dextran, we have gelatin. As Lakshmi said, starch we are no longer using because it causes more AKI. Dextran can cause coagulopathy. So synthetic colloids, what is left is gelatin, like your gelfusion, etc., which you can use reasonably safe. And otherwise, albumin is superior for all the various reasons said, except we get hampered by the cost of albumin.
Yeah.
And as Sagar pointed out, you have to be very cautious that your child is not entering into renal failure or something, because then you'll cause fluid overload and push them into dialysis.
So with caution, we need to use these colloids. Umali ma'am, I want you to summarize everything and give us a take-home message of entire this thing.
Yeah. So I would say, if you see, the commonest intervention done in a hospitalized child is IV fluids. Most of the time we admit because we feel they won't be able to take oral or tolerate oral, even for simple admissions. So IV fluid is a drug, like Dr. Kedar pointed out, it has to be treated as a drug. Which fluid you want to give, and the rate at which you want to give. For resuscitation, normal saline still, with all its limitations, is the fluid of choice. What has changed is the rate at which you give and the volume you give. Hypotensive patient, 20 ml per kg, repeat if needed till blood pressure comes up. At least 2 or 3 times. Non-hypotensive and compensated shock, go slower, give 10 ml per kg, need not give as rapidly as possible. Reassess after each bolus, because stopping is very important, that you don't give unnecessary extra fluids. When we come to maintenance fluid, choose more isotonic fluids for the sicker children like NS, and for not so sick children out of ICU, at least half NS who are over the neonatal period. And especially for the first 2 days or 3 days of the illness till they are out of the thing, then you can go back to whatever is needed. And colloids, we don't have a great choice. We have limited indications in special condition situations. So use it sparingly, use it well. Your choice is between albumin and gelatin, mainly because it's more cheaper than albumin. So can be a suitable substitute in given cases. And special conditions already mentioned will require totally different care, like dengue, DKA. DKA overall very rarely goes in shock. So kg. Generally, that 10 ml per kg over 1 hour is sufficient for most DKA children.
Great. So very well summed up. Thank you, everyone, and thank you, organizers, for giving us opportunity.
Thanks to the panelists and moderator for such a wonderful session. Now I request Dr. Jitendra Gawane to felicitate our panelists. Dr. Uma Ali, madam. Dr. Lakshmi Bond. Dr. Sagar Lad. Dr. Kedar Malvatkar. I request Dr. Sadachar Ujjalamkar to felicitate our moderator, Dr. Jitendra Gawane. Thank you. Thank you.
Although it's very cold here, but I would like to wish my very enthusiastic audience a very warm winter good afternoon. I, Dr. Kiran Motwani, heartily welcome you again for this academic fest as we enter phase 2 of the day. Now, I call upon stage the experts, Dr. Chetan Shah, Dr. Rajendra Khadke, Dr. Rajendra Vaidya, and Dr. Anand Deshpande, along with Dr. Sanjay Marathe, who will moderate the next session. What a comprehensible and clear session was presented a few minutes ago by the very fabulous and expert panelists here. A real thank you to all of you. So with a clear brain and without wasting any moment, let's move forward to the next most commonly encountered topic, our real bread and butter, that is vaccinology. It's surprising to see how far vaccinology has progressed from one bug, one vaccine technology to generic vaccine platforms for multiple candidate vaccines. We want to make sure that you are thoroughly updated with the latest in the list and to provide the best for your patients and be prepared to deal with those Google annoying smart parents who doubt our knowledge in the OPDs. So here I call upon and give the stage to Sir.
Good afternoon, everybody. It's a pleasure for me to be here once again in MAHAPEDICON. Thank you, Team MAHAPEDICON, Team Nasik, for the opportunity. And what an excellent academic feast we have received in last 2 days. I'm equally fortunate to have 4 experts with me. They are authorities in the subject of vaccinology. They do not require any introduction. Just a word about them. Dr. Chetan Shah, who is the Vice President of West Zone IAP. Then we have Dr. Rajendra Khadke, who is an ACVIP member for this 2022-23. Then we have Dr. Anand Deshpande, ex-EB from Maharashtra, and a very busy pediatrician from Pune. And then we have Dr. Dr. Rajendra Vaidya. And his specialty is, even if you have any problem, you can just call him. And before calling Google, you can call Dr. Rajendra. Friends, vaccinology is a very dynamic branch. And you will be surprised that almost all the vaccines, the recommendations have changed in last 10 years. So nothing is permanent. And the recommendations are based on the scientific evidence available at that time. So nothing is permanent. And all of us, we have seen that almost all except I think BCG, the recommendations have not changed. So don't think that this is the permanent recommendations. But what the people in their practice they are facing, lot many problems in their day-to-day practice. So our aim today is to give maximum take-home messages for the problems which we are facing. Sir, my request to all the panelists to be very crisp and precise so that we can cover maximum. Friends, it is very impossible to cover all the vaccines in 45 minutes. So I have selected 4 vaccines. The most important to me was IPV, PCV, HPV, and rabies. You have so many questions in your mind. We'll have 2 rounds in this. And if the time permits, we can go for the other vaccines also. Let's go. Let's discuss IPV. Friends, IPV was introduced in 1955. Unfortunately, was replaced by OPV. Without taking any credit from OPV, for 35 years, OPV has done excellent job and helped us in eradicating polio from this world, almost from the world. But then right from 1955, people were insisting that IPV is the solution. And though the world has used OPV, the Scandinavian countries and Netherlands, they have used exclusive IPV and they have also eradicated polio, minus the complications of OPV. Now, once we have eradicated OPV, polio, now we have started realizing the side effects of the live attenuated vaccine. And now we are facing the outbreaks of CVDPV and VAP. CVDPV is always a risk to the community, whereas VAP is always a risk to the indigent. With this background, my first question for that basic question, Dr. Anand, what are the recommendations of ACVIP 2020-21 for the use of IPV at present with the background of endgame polio program has already crossed 5 years, 2016 to 2022?
As you have pointed correctly, the OPV has taken out us out of polio eradication. And now the problem of VAP and circulating vaccine-derived poliovirus is going to be the bigger problem. In that way, everything was planned. Now, current recommendation of ACVIP are 3 IPVs at 6, 10, and 14, 1 at 1.5 year booster. And this new recommendation is at 4 to 5 years, along with the cellular or cellular.
So ideally 5 doses of IPV without forgetting the zero polio at birth.
This is one addition. Earlier there was oral polio there. And
even today
then it was dropped, and now there is a.
We have reintroduced IPV at 5 years. We'll discuss why. And do not forget zero polio at birth.
Yes.
Even today we are.
Should not be forgotten.
Is there any alternative schedule which is also equally good as this 5-dose schedule, which you would like to recommend to the? If it is not possible to give IPV all the time, he has come from an PSC where he has received some doses or without any fractional doses. Can you give some alternative good dose? Or can you suggest to
2
him?
doses 8 weeks apart, maybe 8 weeks and 16 weeks, followed by booster.
So this alternative schedule is equally good. You can give 2 doses,
And
one at
government
8
is
weeks and
giving
another at
fractionated.
16 weeks. Yeah. What government is giving at present is 2 fractional doses at 6 weeks and 14 weeks. And what we are practicing is a single dose at 14 weeks. This is just the risk mitigation recommendation, not an ideal one. If that is the one, what is ideal, what we should do? My second question, the 5 years booster was not there. So what was the need of 5 years booster in present context? Why ICVIP has recommended this booster and all of us must give this booster, and what are the different ways we can discuss?
They observed that the antibody levels were falling down at around 4 to 5 years. And they were reaching to 90% or 89, 90, 91%. And by giving this booster for another 5 years, the levels of the antibodies they got boosted. And that's why it has been recommended.
All these studies are based on 3+1 schedule. There is significant waning of the IPV against all P1, P2, P3 by the preschool entry. all the Western world is already giving the booster at 5 years. So what we have realized that there is significant waning. And if you give a booster at the time, there is an excellent boostability of all three components, P1, P2, P3. If you'll see the seroprotection rates have come down to 90% if you do not give the boosters, which is not acceptable at present. So, though we are not very sure whether at 5 years will be able to give boosters, should give booster a little late. We have decided to give a booster because it is practically possible also because we are giving DPT at 5 years. So why not to give IPV along with the DPT? So friends, if you are giving DPT at 5 years, please give DPT plus IPV. Whether you give in a combination or you give standalone is your choice, but give IPV. If somebody has come to your clinic and he has received, he said 5 years ka booster to mera ho gaya hai, recommend 1 dose of IPV, standalone IPV to that child.
Especially somebody who has received fractionated, there are no studies, long-term studies of the fractionated
Correct.
IPV received patient and what is the immunological status. So if somebody comes across and can be given at for the second booster, it can be used.
Yeah, and very unfortunately, in last 5 years, the patients have received very erratic doses of IPV in our this in-game polio program. So it is all the more mandatory for us to at least give some seroconversion and priming. At least that much will be done with the 5 years booster if he has not received any dose of IPV.
I think currently those are 5 years. They have gone through that unavailability of IPV and OPV bivalent. Around 16, 17 it happened.
Yeah.
So we went to the bivalent. And,
at least at present, and the day will come that the OPV will be gone and we'll have only IPV. So we must know IPV at what time IPV should be given, and very, very important vaccine for all of us.
Excellent.
Let us discuss the second.
We were supposed to have IPV prior to switch, but we could not
Very
give that
unfortunately,
IPV.
very unfortunately.
Those who have not received IPV previously, they would get a type 2 protection with IPV.
But now after 5 years, that importance of that previous IPV has gone. Now we'll have to protect individual. Absolutely. The second most important vaccine, which I personally feel is HPV, and very important vaccine, where this viral infection, apart from EB virus, has established an causal correlation with the cancer. Not only cervical, we'll have to think of beyond cervical cancer, vulval, vaginal, penile, anal, oropharyngeal. So the list is unending. There is apathy from the government, apathy from the pediatricians, apathy from the community. And what the world has done, they have almost eliminated HPV from their country. The Australians have goal of eliminating HPV by 2025. And Americans have already shown that the HPV given to everybody can eliminate this disease and subsequently the malignancy. Such an important disease, such an safe vaccine. So my first question to Dr. Rajendra Khatke, do we need a gender neutral HPV vaccine? That means vaccine given to both the sexes.
Yes, sir. Previously, our focus was only for cervical cancer because cervical cancer female, every 4th female is Indian. So our basic focus was only cervical cancer. Then later on, we know that basically it can happen in males also. Penile cancers are there, genital warts are there. Then you have papillomatosis, which is coming up. And now there is a strong association of HPV with head and neck cancer also. So basically, it has to be gender neutral vaccination. And we are fortunate that we are getting a gender neutral vaccination approval by DCGI in last July.
What were the disadvantages to the male where they were not offered the vaccine? What are the all disadvantages which we can see from the slide? The seroconversion was very poor.
That was one thing, and the transmission from female to male
was more as compared to male to female.
3 times more than the male transmitting the disease to the female.
Recurrence and repeated attacks of HPV infection was much more commoner with the male. Then 90% of the penile cancers were associated with HPV. Anal cancer, very high incidence. Oropharyngeal cancers in males, very high incidence of HPV. And a very long exposure to HPV as compared to the girls, where usually they are exposed up to 40 years, where the boys are exposed up to 70 years. So all the time they are exposed to that. So the male person can get even the genital warts at 50 years of age and a risk of developing malignancy. So all these were the risk factors. And unfortunately, we were focusing only on the cervical cancers in female.
And even the people who have male to male relations,
Yeah, that
they
is
also
high
are
risk,
not benefited by only female vaccination.
So these are all disadvantages, and it's a need that everybody should be protected. If a male is protected with the HPV vaccine, we have double advantages. He is not going to transmit it to the female, and he is protected himself.
In fact, the studies are there. The oropharyngeal cancer more common in the male than female.
Yeah, and you'll be surprised to know one study that 70% association with
Seven-
the
seven-
oropharyngeal cancers. This
70%
is something which is
association.
amazing.
That to HPV 16.
Yeah. This is what, if you give a gender neutral vaccine, such a rapid decrease in the HPV prevalence. Now, Dr. Khatri, do you recommend 9-valent HPV in India?
Yes, sir.
Without discussing the cost at present, we
Yes,
are
sir.
discussing science.
So, though the cost is very high, but we should use 9 HPV vaccine because we know that only 6, 11 and 16, 18 are not the only cause of cancer in male as well as female. But there are other viruses also which are involved in having cancers. So basically, if we have 9 serotypes which is being covered with Gardasil 9, I think we should use.
And this study, which was published in Journal Medicine in Virology by Indian study, they have shown that the 33 was more commoner as compared to 18 in India. And if you add these 7 serotypes extra, the extra protection is to the tune of 20%. So if I give 9-valent HPV to an individual, I am almost giving protection to the tune of 95% in our country, whereas it is 90% in the Western world. So it is better
And by
protection.
quadrivalent, we are giving only 70% protection.
Correct. So don't think that these are unwanted serotypes which have been included. And one person can be exposed to more than one serotype. So you never know, it is 16-18 or it is 16-18 plus. So I think it is highly recommended, very safe. In Western world, it is recommended from 2016 to every girl and a boy after the age of 9 years. So very safe.
And good part of this is now, few years back, we used to say we don't have any studies, there are Western studies, but now we are getting many Indian studies.
Indian
So it is
studies,
support
absolutely.
strongly.
Yeah. Now my question to Dr. Khadke, who is an ACVIP member, are you going to give us that facility of giving 2 doses of non-valent HPV to the age group of 9 to 14, where the CDC allows, the WHO allows, only the DCG has approved it for 3 doses because that kind of a study was published. So I was very sure that in very soon the ACVIP will come out with this recommendation that will reduce the cost, and that is what internationally it is being recommended.
There was
Any
a lot of
news, sir?
There was a lot of debate in ACVIP whether we should follow the rule of land or whether we should follow the CDC and WHO, which has already reduced the number of doses.
Sir, in rabies, you do not follow the rule of land. So we do expect that the 2-dose schedule will very soon will come to us, and we'll have 2-dose schedule even for an non-valent. And I'm sure they will come out, they will decrease the price, reduce the price, and it will be available for some 5,000-6,000 rupees. So it is very easily affordable to everybody. But one of the must give vaccines, HPV. So do not forget that HPV. Start recommending it when you give a second booster, because then after 5 years, they will rarely come to you. So insist that you have to take Tdap and HPV at 10 years plus.
Sir, but I just wanted to say that there was a discussion that whether this quadrivalent vaccine can be made as a gender neutral vaccine. If that is also made a gender neutral vaccination, the majority of the serotypes which are causing cancers in the female, as well as few serotypes which are causing head and neck cancers, can be covered. If that is also given by DCGI, probably we will be really in a,
Yeah, they have to submit the same study, because in the Western world initially it was the quadrivalent vaccine which was given. So that can also be done. Now the world was moving from 2 doses to 3 doses, and you'll be surprised that there is a strong evidence to say that even a single dose is enough. Sir, what is your opinion?
Yes, sir, but it has to be national immunization program. Then only it is basically possible to give only single dose, and which has shown that there is a reduction in the HPV prevalence significantly after the mass vaccination in national immunization program.
Is it going to be a game changer program?
Obviously.
And WHO has set a target of vaccinating every girl and a boy less than 15 years of age by the 2030. And these are the few studies which I have quoted, and it has given the same result, saying that single dose, if it is introduced in the national immunization program, will be as good as 2 doses or 3 doses. And WHO SAGE Committee report 2022 has strongly recommended that every country must give only 1 or 2 doses till the age group of 21. So friends, I'm very soon, we'll have only single dose HPV and see the number of patients which we can cover only with the single dose. So one of the very important vaccines to me, and all of us must have recommended and suggested to every patient who comes to you.
single dose, that trial.
So we
See,
can
as
avoid that discussion because the studies have shown everything. The most important study was this Kenshi study. And we can discuss it for 5 minutes, but if the time permits, subsequently we can go through that. Because there are so many another most important, very close to my heart, very frequently we discuss. And I'm sure the audience which is sitting here will be having maximum questions on rabies, because every day you must be getting few queries on the rabies. So Dr. Rajendra, the rabies, the dose schedule is changing from 4 to 5, will not discuss on that because it is unending. We were giving RIG, which was not available, very costly, not affordable, fear of anaphylaxis, so I will never give. So people were avoiding giving RIG even if it was available. Now two very good new, not vaccines, but the replacement to the RIG has come, monoclonal antibodies. That we'll also discuss. Before that, the most important to me, before giving an ARV, Dr. Rajendra, what should be the approach in post-exposure prophylaxis in category 3 bite? Friends, whosoever comes to you always is in category 3, otherwise he will never come to you. So category 3 the most common.
First and foremost is the wound cleaning, which normally we forget, and we straightway advise vaccine.
Absolutely.
Even before coming, if they phoned you, ask them to do a thorough washing with soap at least for 10 minutes at home, and then get the patient. That is the first thing.
Absolutely.
Then you can plan with if it's a category 3, then 100% we have to give immunoglobulin. If he has not received anything in the past, that we'll have to ask the history. And third is the vaccination, full course of the post-exposure vaccination. These are the 3 main.
So never forget, wound toileting is so important that 50% of the viral load can be removed by just doing an adequate wound toileting. So even if the patient has come little late, these are NCDC guidelines. Though primarily on day 1 you have to give a wound toileting, even if he comes at day 10 and wound is wet, still you can go ahead with the same protocol of wound toileting, and you can reduce some viral load of rabies, which is very, very important in the overall outcome of the rabies.
And first see that you should not miss any missed wound by the patients. Because many times they forget to tell that there is a scratch. We have to search it for it. And because vaccine failure, whatever we giving all RIG has been reported in that cases. So you search when your patient comes to you. So are the hidden areas.
Correct. Absolutely, I agree. Now with this RIG, all of us must have faced this problem. Very costly, very difficult to give, not available. And in the world literature, it says only 2% of the patients who had dog bite or any animal bite has received RIG in the world. So unfortunate. And maximum people are dying only because of the non-availability of the RIG, not because of the ARV was not available. If that is so, we have got 2 very good drugs available. They are monoclonal antibodies. Dr. Rajendra, what is your opinion about 2? One is monoclonal, one is cocktail murine monoclonal rabies antibodies.
In fact, both are good, excellent. There are no head-to-head trials, which is
Absolutely.
better. Definitely, this pin, which is having 2 component, which is little better, which will cover additional genotypes, but they are mostly in the bats, which is at present not in the India.
Correct.
So both are equally efficient, both are equally good. Cost is little factor in one, dose is different in both of these. Little academic point is that FinRab is little murine origin and Rabishil is a human origin. That is the only, but I have to give only single dose. So there is no point in that also. But take home message is that whatever is available, use it. But as you told, there are only 2% using.
Immunocompromised.
In immunocompromised, we have to,
You have to give more doses.
More, and immunocompromised patient preferably will prefer to use Rabishil because that is a human origin. Murine might give some problem in
Yeah.
future in case immunocompromised patient wants to repeat it. But use it, take home message, use it, use it, use it.
Take home message, do not wait for any alternative monoclonal antibodies. Whatever is available, you give it. As early you give, better the results. So don't wait. Till how long we can wait, give this monoclonal rabies antibodies or RIG?
If patient has not received any vaccine, then you can give at any time.
Anytime, yeah.
But if he has received the vaccine, then up to day 7, third dose you can use. After that, there is no use. And then you will have to avoid. Now, initially, the recommendations or what is remaining, you give intramuscular. Now
That has gone.
been taken out. You give maximum infiltrate locally. Don't give intramuscular.
So take home message, do not give any RIG or monoclonal antibodies intramuscularly. Infiltrate as much as possible around the wound and in the wound. Give whatever monoclonal antibodies available. Once you have started even with the 1 dose of ARV, you cannot give RIG after day 7. This is the rule. Okay. And what are the indications of intramuscular RIG? There are only 2 indications.
Few indications, yeah. If but there is a mucous membrane involvement, so in that situation we cannot give. You can rinse that mucous membrane either conjunctiva or oral, but in that some rare situation or in cases of organ transplant, they are been advising intramuscular. That's the only 2 indications, but they are very rare.
The indications are aerosol exposure, where you do not know where is the exposure. Second was if there is in Western world, if there is an exposure to the bat, and you are not very sure whether there is a direct contact with the bat, but maximum people in the Western world are dying because of the bat-induced rabies. So in CDC guidelines, they say if you cannot see where it has either attacked or it has touched your body, you give intramuscular and try to give as much as protection as you can. Aerosol exposure is another one. For a mucous membrane exposure, you can rinse the area by diluting the monoclonal antibodies. So these are only 3. A word about rabies or a 3-dose rabies by Zydus.
Actually, this is a new entrant. Fortunately, as a pediatrician, now it's available, advisable only above 18 years. So we don't have to.
So it's not available for a pediatric
But
patient.
definitely there are no efficacy trial yet to prove its efficacy in the real world. Another thing is that what studies they have done, they are done on the healthy volunteer. They are not on the animal bite or dog bite patients. So their efficacy studies phase 3, they are on the volunteers, which are be healthy.
Yeah.
So there is no. Another point is that they don't mention antibody titer, which is must for the long-term protection. Third is they are not, as they are on the healthy volunteer, they are not compared when giving
Dog bite
immunoglobulin,
patients.
because immunoglobulin might interfere with the vaccine efficacy. So they are not ideal for that
Yeah.
situation. And last point, these are based on the G protein. Other are on all whole inactivated virus. So they will take care of all genotypes. We don't know yet G protein whether it will take another genotype coverage of the rabies vaccine. So these are few points. So I think we should take pinch of salt. At
Just
present
as an
not available
information to
today.
all of us that this vaccine is available, not yet recommended in pediatrics, but you never know, subsequently might be recommended. Thank you, sir. The fourth, the PCV, the biggest global health burden across the world. Still, maximum people are under 5 population is dying because of pneumonia, and we are the major contributors from Asia and African countries. The Western world has said with the excellent vaccine with PCV7 was introduced in 1999, IPD has brought down to 0% because serotypes included were from the Western world. The same vaccine efficacy in our country was just 50%. Then they added 3 more to make PCV10. Then 3 more were added to get PCV13. We have reduced 3 more and added some different, and then we have new PCV10. So now there are 3-4 PCVs available with the excellent vaccine efficacy of this PCV vaccine. And it's very difficult to isolate pneumococcus in the serum or from the blood or from the CSF. The vaccine is the only way to protect every individual. The most common cause of pneumonia, the most common cause of otitis media, the most common cause of meningitis. Such an important organism. Let us discuss PCV. Now, Dr. Chetan Shah, my first question, this is just for our information what we talk. When I say PCV13 Prevnar, PCV10 Synflorix and new PCV10 Pneumocell, just for our understanding. What are the important findings mentioned in WHO paper 2021 on consideration for PCV product choice? Because now in India, we have all 3 available. So how to select and what WHO says on this?
See, basically, the thing came into picture after introduction of new PCV10. And the whole game rotates around 3 strains, 3, 6A and 19A. So entire thing is, comparison is always made on these 3 grounds. What has been found is new PCV10 has been found to be equally effective as PCV13 in most of the studies. Similarly, there is a game of cross protection. So cross protection against 19A there is no definite evidence that there is a cross protection which is clinically effective or effectively seen in the clinical practice. Then paper also states, compares the efficacy of these new PCV against different strains. And new PCV is definitely, as I told you, is comparably effective with PCV 13. Strain 3, all three means there are no studies which shows efficacy of any vaccine conclusively against strain 3. And last, it has shown non-inferiority. The new PCV10 has definitely shown non-inferiority over other available PCVs. And last and not the least is the safety profile. And all of them have been shown to be equally effective, safe vaccines, no major side effects apart from some local effects. So this is how the new paper has evaluated our new PCV10.
And PCV 13 has shown no impact on the serotype 3.
The three.
Serotype
what I
3, which
told.
is a very
There was-
resistant type of 3.
So-
So whether you include serotype 3 in your vaccine or you do not include will not make much of a difference at present. But now on what grounds, sir, do you select PCV when all three are available in your practice? Not considering the cost at present, but how do you select which is going to have a better impact in your patient if you give that?
Naturally, our target is to protect our patient to maximum possible percentage. We will try to protect him 100%. But as such, all of you know, no vaccine is 100% effective. So we'll go by strains. So which are the strains more prevalent in our area, or if you don't have studies of your area on the entire country. So we have gone through the studies, and what we have found is that the change in the two important strains that has happened is 4 and 18C in PCV10 has been replaced by 6A and 19A in new PCV10. So the comparison is always between these two. What has been found is that 6A and 19A are definitely prevalent in our country. And this data, which has been done in different studies, has definitely shown that around 8 to 10% difference in efficacy of vaccines which are having 6A and 19A. So this is how naturally our preference will be to give the maximum protection, and one which are covered maximum, one vaccine which covers more strains, will naturally try to prefer that.
So select a vaccine according to the seroprevalence in our country, not what is there in the Western world. If you go by all these studies which are done in India, it says 6A and 19A is contributing from 6% to 13.5. So it is mandatory for us to include 6A and 19A in our vaccine. Then non-inferiority. The non-inferiority has been proved in all three vaccines. So all three vaccines are good. The new serotype, the new PCV has got 6A and 19A, which is a definite advantage. PCV 13 has got all. So at present, it is covering the maximum. And if you'll compare, even if you compare the invasive pneumococcal disease serotype coverage of PCVs in Indian prevalence data, you can see PCV 13 and new PCV 10 are almost same. Slightly less is PCV 10. And even if you compare with new PCVs which are coming up, PCV 15 and PCV 14, not PCV 20, there is no significant difference. So these serotypes can match up to PCV 15, which has been recently introduced in Western world. Like in America, they give PCV 15 now. So even our PCV 13 or new PCV 10 is almost covering same as compared to PCV 15, which is being introduced in the Western world. So you can judge according to this and select a vaccine which is best in your practice. Now we go for the rapid round. This is the one where they will give you the take-home messages. Will be fast, a single or two-liner answers. My first question will be for Dr. Anand Deshpande. Sir, now the standalone IPV is available. How will you use IPV in the following situation? Means patient has come from PSC or your own patient. He says, I have received different ways of IPV in my first 9 years and 9 months. How you will protect him with the best possible option? Number one, 9 months of age has received only one dose of fractional IPV.
Two doses, 8 weeks apart.
So single dose is fractional IPV has no role at all. So you will give 2 more doses, 8 weeks apart. and continue with the boosters. Yeah. A child 9 months of age has received two doses of fractional IPV. He has come from PSC. Then
Single dose of IPV would, because he has received 2 doses of fractional IPV.
this has been mentioned in our ACVIP. If he has received 2 fractional doses, at least give 1 dose of full dose of IPV 8 weeks after the last dose of fractional dose. So that is what you will suggest him. Then a child who is 9 months of age has received only bivalent OPV and no IPV. So he has not been protected at all with the IPV. Then
2 doses 8 weeks apart and followed
continue
by
with the boosters. Then a child who has come at 4 years or 5 years who has not received any IPV till 5 years.
single dose of IPV.
Any alternative Dr. Rajendra would like to add? Single dose is at the minimum what you can give, because you are sensitizing, at the same time you are having some seroconversion, but
Yeah, but now CDC has recommended, even in the US also, up to
Yeah.
17 years, they can give, if they are naive patients, at least
Catch
1
up
dose,
vaccination.
4 weeks second dose and 6 to 12 months third dose. But minimum 1 dose has to go in.
Yeah. And it says, suppose he is already on the IPV schedule and he has received the last dose after the age of 4 years, and the gap between the last one and this one is more than 6 months, do not give any IPV. Those who are interested can just go on CDC guidelines. Excellent guidelines are given how to use IPV in your practice. Is it true that IPV can be given subcutaneously also?
Standalone can be given.
Very safe.
Combined cannot be.
So there is no problem. If there is a case of hemophilia or something, you are worried, you can give subcutaneous IPV and the standalone IPV, not in the combination, because combination has got some adjuvant. You cannot give subcutaneous, otherwise you will have severe reaction. What is the difference between polio eradication and endgame polio?
Polio, last case of polio was in 2011. Then we declared it as in 2014 April, and the end game started after that. In 15, we decided to shift to IPV, 2 doses, either fractional in government or
So
intramuscular.
eradication was related to the wild polio, and endgame
eradication was-
polio is basically with the CBDPV and VAP.
Yes.
The complications of OPV.
We
That's
are
what we are
interested-
facing at present.
And that's why we are interested in curtailing VAP and CDPV.
Now rapid round for Dr. Rajendra Khat. This is another. Do women still need to get a PAP test done if they have been vaccinated against HPV?
Yes, sir.
Strongly yes.
Yes.
No
strongly.
question. What should be done if a young female becomes pregnant after initiating the vaccination series?
Do not terminate pregnancy.
Wait for the pregnancy is over, then you can
Then you
complete
can
the
use
schedule.
a schedule.
But at the same time, no harm has been recorded in the Western world. They have got a big registry for that. Those females either got pregnant after receiving HPV or during this, there is no side effect identified till rather so far. So it is one of the safest vaccine. But on a precautionary measure, wait till our pregnancy is over and then you give it. Can we give HPV vaccine to a lactating mother?
Yes.
Yes, and many centers have started doing it. So go ahead with this program. A 10-year-old girl receives second dose of HPV vaccine after 8 months. Is it a valid dose?
Yes.
So minimum gap should be of 5 months.
6 months or
8
5
months
months.
is no problem. So it's a valid dose. If the dose is to be repeated, do not repeat the dose. It was a Google. So no need to repeat. Now I have changed the question. If 12-year-old received the first 2 doses of HPV series 2 months apart,
Yes, sir.
according to the 3-dose schedule, because that doctor wanted to give 3-dose schedule. But the recommendation for 9 to 14 was 2-dose schedule. So somebody says, I have received 2 doses. Is it enough? Or
No.
something is wrong.
The third dose is necessary because you want your memory cell to get activated. So at least 5 months gap between the second dose has to be there. If this would have been given as a first dose and after 5 months, probably we would not have given third dose. But this has been prematurely given in 2 months. So third dose has to go.
When will give this third dose?
6 months, 5-6 months.
So you have to give third dose 3 months apart from the second dose, provided the gap between the first and the last dose is a minimum 5 months.
5 months.
That should be there. And the second dose is considered as invalid dose. Can someone be infected with more than one serotype?
Yes, sir.
So not that only 16, 18, any multiple serotypes, the individual can be exposed. If series was started with quadrivalent HPV or a bivalent HPV, can it be completed with 9-valent HPV?
Yes. it can be completed.
CDC has also
CDC has
recommended.
also
So you
recommended,
can
and
go
there
ahead
are-
and complete it with whatever
there-
advantage that individual will get it with the non-avalanche if affordability is there.
There are studies for the mixed schedule also.
Correct. We'll not go into the details because there are so many other questions related to this. Can vaccine be a treatment of HPV infection?
No.
Big no. So never give vaccine for treatment of HPV infection. Should individuals be screened before getting vaccinated?
No.
Big no. Can the HPV vaccines be used interchangeably with one another?
Yes.
If it is not available.
If it is not,
If it is not available.
ideally it should
The
not be.
thumb rule says you give it the same, but now it will not come in this because there is only one brand
Now
available.
bivalent vaccine is not available.
Correct. So only one brand. Rabies. Dr. Rajendra Vaidya. Your patient was bitten by dog and you have advised 4/5 doses of ARV. He received ARV on day 0 and day 3, but he has turned on day 12 instead of day 7. What you will do?
First, you just ask whether they are category of the bite which they have received, wound properly, and then these doses must give immediately third dose. Even though there is a lapse, don't miss, because the first 3 are primary doses, and then 4th and 5th dose. If we are going 4 dose, obviously we will get 28 days. If you are following 5 days schedule, then 7 days after 3rd dose and 14 days after 3rd dose.
So do not change it. Consider this day 12 as day 7. Then 4th dose will be 12 plus 7. And then the next dose will be 7 plus 14 days more. So for suppose there is an lapse of 4-5 days or 1 week, do not change the schedule. If it is 4 weeks, a few weeks more, then you may think of giving additional doses. This is very frequently happening in our practice. A 4-year-old baby is bitten by a stray dog, category 3. He received a full course of post-exposure prophylaxis 18 days back. What schedule of ARV and RIG to follow?
Now with recent guidelines, any patient who has received any documented post-exposure or pre-exposure full course, then there is no need to give anything after re-exposure up to 3 months, that is 90 days. So you don't have to do, only wound management has to be done.
I will slightly differ in the sense, because suppose you have received for post-exposure prophylaxis, there is absolutely no problem. For 3 months, you do not have to give ARV, you do not have to give RIG. But what is happening? The ACVIP and WHO has recommended 2-dose pre-exposure prophylaxis, whereas NCDC or the CDC still says 3 dose. So if the individual has received 3 doses of pre-exposure prophylaxis, there is no need to give additional dose up to 30 days. So just keep it in mind. If the person has received 2 doses according to the ACVIP or WHO, then you will have to give the same. You will have to give 2 more doses. But if he has received 3 doses of pre-exposure prophylaxis, for next 90 days, you do not have to give anything. For post-exposure, there is no confusion. So this is just because people are giving 2 doses as well as 3 doses as pre-exposure. Now, most probably in few years, even the 1 dose will come. A leukemic patient in remission goes out to play in a park on Sunday, got class 2 state bite, not class 3, it is class 2 stray dog bite, taken to a nursing home, duty doctor gave ARV and TD on each gluteal region, comes to your clinic on Monday. What are all the wrong things he has done?
First and foremost, even though it is a category 2 bite, the patient is immunocompromised.
This is
So
take-home message 1.
Category 2 also we have to use immunoglobulin
Category
locally
3.
in immunocompromised patient.
Yeah.
Second point is that he has received ARV in gluteal region, which is absolutely no. If it is a
Invalid.
gluteal, that is invalid. You have to repeat the whole schedule with that.
Yeah.
And then give full schedule. And being immunocompromised, few might ask them to get antibodies level after a 28 days of RIG.
Because these antibody levels are very difficult to get it, so give RIG. That should be the take-home message. The RIG antibody, these rabies antibodies. Can I give ID doses for pre-exposure or post-exposure?
Yes, you can.
Big
give.
yes. The WHO says even the intradermal dosing is better than the intramuscular. It is cost-effective, more immunogenic, and can be given to a number of people at the same time. So like PSCs or government hospitals, this ID immunization schedule has already been begun. So ID is equally good.
Only one point practical I will mention here, Sanjay. Pre-exposure, if you are giving, or post-exposure, if you are giving intradermal, then this will not be applicable in the observation dog and
Yes,
cat. Then
absolutely.
if you are giving intradermal, you have to give full dose. There is no
Absolutely.
observation period for intradermal schedule.
I agree. I agree. Consumption of raw milk or meat of a rabbit, cow or animal, is there any need to give PEP?
No, no.
Big no. This is the recent recommendation. A 5-year boy had an abrasion with some bleeding following a bite by the stray dog 3 months back. Nothing was done. Now after 3 months, the mother gets the news that the dog was suspected rabid and was killed by the people. What should be done? These are the options.
Even though there is a gap of 3 months, we have to treat as a fresh wound. If it is a unfortunately unhealed wound, then wound toilet as usual. If it is a healed wound, then we'll have to give immunoglobulin locally, maximum whatever you give possible, and then full course of PEP. That is a straight way.
And
Even though there is a
suppose
gap.
this dog is alive at 3 months. Suppose this dog is alive. The mother got the news that the dog is still alive, but he
No,
has come to
But
you.
if it is you feel that the bite was category
So
3,
give vaccine, ARV.
the ARV will
No
give.
need to give
Yes.
RIG, because you can give as an, you can convert it into pre-exposure also, because in 3 months, if the dog has not died, definitely was a non-rabbit dog.
This applies up to 1 year.
You can give up to 1 year RIG if there is an history of dog bite, because the WHO says, but in private practice, there is no such recommendation. So even after 2 years, somebody has come, you have to give. I think we can skip this question. PCV, some rapid round with PCV. 4-year-old case of sickle cell disease visited your OPD, quite common. He has received 2 doses of PCV13 before 6 months of age. What is the PCV vaccine schedule for this child?
See, sickle cell disease means put in the category of immunocompromised high risk category. So you have to give 2 doses of PCV13 8 weeks apart, and followed by a polysaccharide vaccine PPV23 4 weeks after a gap of 4 weeks from the last dose of PCV13.
8 weeks.
8 weeks after, sorry. And then you have to repeat, because this being an immunocompromised patient, you have to repeat PPV23 after 5 years, second dose.
So the list is available. Give 2 doses of PCV13 8 weeks apart. First dose of PPSV23 8 weeks after the second dose, and second dose of PPSV23 after 5 years of this first dose of PPSV. The list is available. It is very clear. Now, the similar question. The person has received PCV in their national immunization program, and now is posted for a cochlear implant. What PCV schedule you will recommend?
So here I think what we believe is National Immunization Program has covered the primary schedule of PCV, which is now 2 doses before 6 months and 1 dose at 9 months. So 3 doses of PCV has been received. So he will need 1 dose of PCV13 followed by a PPV23 1 dose, because this is a immunocompetent child. This is not an immunocompromised child. So we'll need only 1 dose of PPV23 8 weeks after the dose of PCV13.
So only difference between these 2 categories, instead of 2 doses of PPSV, here we give only 1 dose. Otherwise, the recommendation is the same. If a patient has a history of cerebrospinal fluid leak, but no current leak, is this a risk factor for reason to administer PCV13?
No, this is not, because leak has already stopped. So
Correct.
there is no need to.
If there is no leak at present, don't give PCV13 additional doses. Last 2 minutes. My patient has had laboratory confirmed pneumococcal pneumonia. Does this patient still need to be vaccinated against pneumococcal disease?
Yes, definitely, because
Multiple
there are different
serotypes.
strains in the community, and there is no cross protection.
Suppose you have given simultaneously PCV13 and PPSV23 just to cut short the number of visits to your OPD. Is it valid, or should we do something else than this?
No, this is not valid. And,
What should be repeated?
Then we have to repeat PCV13. Because
After
it is after
8 weeks of the PCV23. Can we vaccinate on the same visit 2-year-old boy with PCV13 and quadrivalent MCV from Sanofi. Specifically, I'm saying Menectra.
So Manectra should be given at least 4 weeks after we have completed the PCV 13 course, because there is some hyper-responsiveness of
It
the
renders
previous
the
vaccine.
PCV
If
13
it
less
is
effective.
Yes, and if it is a Manvio, then I think we can do it simultaneously.
If you are giving Menveo by Glaxo, you can give simultaneously PCV 13 but if you are giving Menectra and PCV, always give PCV 13 first, wait for 4 weeks and give quadrivalent HPV. Then unfortunately PPSV 23 was given instead of PCV 13 in a 2-year-old child. Sorry, 2 months old child. Is it valid?
No, this is not valid because all
I close?
polysaccharide vaccines are not at all effective below 6 months of age. So you have to start as early as possible with the PCV 13 and complete the schedule according to the recommendations.
Thank you so much. Because time is exceeding, we cannot continue. Otherwise, we would have continued with few more questions. Thank you all the panelists for your wonderful interactive session, and thank you, audience, for your patient listening. Thank you.
Thank you so much for a wonderful session. I request Dr. Sanjay Marathi sir to felicitate the panelists here. I request Dr. Abhay Tidak to kindly felicitate Dr. Sanjay Marathi sir.
Let's now move on to our next session. We have a mixed bag session now. May I invite as chairpersons for this session, Dr. Uday Bodhankar sir and Dr. Archana Joshi ma'am onto the stage. I also welcome our next speaker, Dr. Raj Ganacharya, onto the dais. In the current scenario, the word pandemic immediately brings to mind COVID-19. But for centuries in India, we have dealt with a pandemic which is far bigger than COVID. A pandemic that seldom kills, but often disables the immune system and inhibits growth. I am alluding to iron deficiency anemia. We as pediatricians need to understand how to treat and what hematinics to use. We have with us today, Dr. Raj Ganacharya sir, to discuss this in his talk, The Overlooked Pandemic. Over to you, sir.
Good afternoon to all of you. I, Dr. Bodhankar and Dr. Archana Joshi, we both are accidental chairperson, having to chair the session on weeks back. We are going to have 3 important lectures. One on the overlooked pandemic, which is by Dr. Raj Ganacharya sir. Already Dr. Kopikar has given his biodata. Second will be on cell phone de-addiction by Dr. Suchit Tamboy, non-developmental pediatrician, and case-based approach to genetic disorder by Chaitanya Datta. Over to you, sir.
Thank you, sir. Thank you. Good afternoon, everybody. Namaste. Thank you, MAHAPEDICON team, Nasik, for giving me this opportunity, and thank you, Inspira, for the talk. The first thing I wanted to tell you, this is not a very mind-boggling session like the other sessions were before. So you can relax. and listen to it. So we are just going to look towards the overlooked pandemic in India. Now, this pandemic is not as serious as what the pandemic we have seen as the COVID pandemic. Now, after 75 years of post-independence, healthcare in India has taken a big leap, and there are significant changes in this. And I mean, we have overcome so many challenges, and we are way positively ahead of the things. For example, significant improvement in core health indicators is a sign of progress. If you see, vaccination percentage has increased, infant mortality has decreased, underweight proportion of children have decreased, and the under 5 mortality is also way too decreased. Now, the India's most overlooked pandemic still remains, which is unfortunately the iron deficiency anemia. So much about of it is spoken in every conferences, but still we are there where we were ages ago. If you see, in according to the NHFS data, in 1922 to 1993, 68% was the prevalence, and now here we are in 2019 to 2020. Still, this thing remains at around 68.9 or 69%. So anemia is not a rural issue anymore. It is also, walked into the urban cultures, and most so in the well-to-do people. Initially, it was a malnutrition issue in most of the rural population, but now it is a malnutrition issue because children are so addicted and used to junk food, unlike before. So, like pizzas and burgers have become the national food of India as far as. So children are so much into that, and there is so much nutritional deficiency because of eating such foods. Now, if you see in Maharashtra alone, one of the most affected states, if you see in Mumbai itself, this thing has gone above by 10%, the iron deficiency anemia cases, according to the NHFS. And in rest of Maharashtra, you can see it is around 15% jump in the prevalence of iron deficiency anemia. Now, according to the National Institute of Health, long-lasting neural and behavioral effects of iron deficiency anemia in infancy, adolescence, and childhood, we all know about it. The first thing is at 6 to 24 months, the risk of stunting is very much high. Mental developmental scores and cognitive scores significantly go down 6 to 15 points if the child is having iron deficiency anemia. In childhood, we can see each 1 gram per deciliter deficiency is associated with 1.75% decrease in the IQ. The cognitive abilities are also very much decreased. There is less of physical activity, verbalization, and language learning skills is also decreased. Coming to the adolescents at 10 to 15 years of age, there is low in arithmetic and writing development, concerns about anxiety, social problems, and attention problems. No catch-up growth in motor reflexes till 11 years, and widening gap till 19 years of age is observed. So is the problem recognized? Yes, definitely. There were a plethora of government initiatives starting from 1970, 1975, 1995, as you can see in the slide, 2012, 2013, and up till 2018. So vast measure of iron products like iron supplementations and folic acid supplementations were given free of cost at many levels in the school, in Anganwadis, even the diet was iron fortified, everything is done. On the level of media or awareness among the people, there are daily articles showing that there is this anemia is a serious concern across all age groups, particularly children and women. So the Indian Express, the Tribune, the Science, every day some articles are being produced. So the people are aware of it. But going further down the line, the lay people or the laymen are not so much interested in this topic, or they are unknown. I mean, they don't have the idea of what is going on with this subject. Coming to the pharma side, there are increase in the number of brands, as you can see. From in 1992, there were just 15 brands, and coming to 2020, now we have got 460 different brands of medicine. I'm talking about these brands only used in children, forget about the adults. So the number of brands have gone drastically up. But On the contrary, we are still at 69% of anemia, iron deficiency anemia, which is very unfortunate. So is more iron formulations the solution? No. According to World Health Organization, 60% of children drop out of the therapy due to poor compliance. Also with practical pediatrics, compliance with iron formulations, which are available, all the formulations available in the market, it is just 10 to 30%. So what are the challenges faced during iron therapy? This are some of the things on online portals. Today's mothers and parents have got this habit of putting everything online, that their child cries with the smell of the medicine. There is browning strings, or there is a black colored stool. It is making baby very colicky, causing vomiting and loose motion sometimes. The stools are black, the gums are, the teeth are stained, and there is even staining of the tongue in some children, as you can see in this pictures. So what are the challenges faced by the doctors? Everybody, as we know, we have to counsel our patient. These are the side effects the children are going through. The child vomits after the single dose of medicine. So we have to make the parents aware that these are the side effects. Your stools will be black. The child will have some nausea, vomiting. The child may have loose motions also. Iron does take metallic. And completion of therapy of babies is not possible due to adherence and taste of iron. Now, these are the few salts which are available. Salts change, but the problem remains. So we got into many salts so far, like ferrous sulfate, ferrous ammonium sulfate, IPC, colloidal iron, ferrous ascorbate. Everybody has their own side effects, like they're affected by the dietary inhibitors, there is teeth staining, there are GI side effects, and there are toxic side effects, toxic potentials with every one of them except a few salts. So clearly the side effect results in poor compliance. So the Indian Academy of Pediatrics says infants more than 6 months of age, iron supplementations for 3 months a year for the first 5 years is mandatory. This we should follow in our regular clinical practice also. That's what I think. So we have to rise against anemia. So how do we do that? Raise the compliance to iron therapy, which is pivotal in ensuring and improving health care outcome. So what are the alternative ways of giving iron? So there is one thing is this micronized liposomal technology, which is there, where these ions are, they're included in lipid sacs like, or lipid pellets like thing, and they are enclosed in that, and then they are allowed to swallow. So this liposomal ion never comes in contact with gastrointestinal mucosa, and it is directly absorbed in the intestine, causing low incidence of side effects. Liposomal ion treatment does not cause stomach upset because it doesn't come in contact with the gastric mucosa either, and constipation associated with the use of other iron formulations. That is often responsible for poor compliance. Liposomal ion allows the iron to pass to the gastric environment without entering in contact, as I earlier said. Now, these iron vesicles, they are directly taken up by the M cells, and it is absorbed from the small intestine. It goes into the bloodstream, goes into the liver, where it is released, and it is directly absorbed. Thus, it is 3.5 times better absorbed than traditional ferric phosphate, and 2.7 times more than ferric sulfate. So this needs to be understood, and this is, I think, a way towards a compliant iron therapy. Thank you.
Yeah, hello. It was a good preamble. I think what as the Indian we know, we should do Jaggery, as Dr. Archana, she was Premchand Joshi will tell. You use iron vessel like tawa, use palak in addition to. Over to Dr. Archana.
We welcome Dr. Suchit Tamboli, developmental pediatrician, to deliver his talk.
Hi, doctors. I hope your palate is beaming with a delightful lunch, and similarly, your brain is imbibing so much of the wholesome wisdom. Well, now let's listen to a lighter yet crucial topic which shall benefit you, not only as a doctor, but as a parent too. Today, wherever you go, you see all age group children along with their respective guardians, obsessed with their very own gadgets, with their very own electronic gadgets in their hands. How many of you are fed up of your child's habits who constantly gaze at their screen, and in spite of all the efforts, this habit has been too rigid to break? The question is, can we really keep this age, this generation away from cell phones? If so, then how do we do it? So I request, sir, to hit the nail on our heads and tell us how exactly do we de-addict ourselves from the cell phones? Over to you, sir.
Thank you, madam. And at the outset, I must thank the organizer as well as my respected chairperson, who are my teachers. And today's topic, I think, is very important. तुम्ही तुमच्या ओपीडी मध्ये जेव्हा बसलेले असतात तेव्हा आजकाल काय प्रश्न विचारला जातो आयांकडून की माझा मुलगा खूप सेलफोन वापरतो, माझा मुलगा खूप मोबाईल ऍडिक्ट आहे आणि आता मी काय करू? आता काय करू म्हणजे तुम्हीच जसं ते गांधीजींना एक विचारला होता प्रश्न की बाबा माझा मुलगा गुळ जास्त खातो तर मग मी काय करू? तर गांधीजींनी सांगितलं होतं की तू 3 दिवसांनी ये. आणि मग त्यांनी सांगितलं की 3 दिवसांनी ये म्हणजे त्यांनी त्या बाईला सांगितलं की नाही, मी तुला काही उत्तर देऊ शकत नाही कारण मी स्वतःच गुळ खाण्याच्या बद्दल माझं टेम्पटेशन मी रेज करू नाही शकलो, म्हणजे रेजिस्ट करू नाही शकलो, म्हणून मी तुला अधिकार नाही देऊ शकत. तसं आपलं आता होतंय कारण आपणच त्याच्यामध्ये इतके ऍडिक्ट झालेलो आहे की आपण त्यांना काय सांगणार आणि काय अधिकाराने सांगणार हा फार मोठा प्रश्न पडलाय. आणि त्याच्यामुळे आपल्याला हा फार मोठा प्रश्न असतो की आपण त्यांना नेमकं काय सांगायचं. आता ऍक्च्युअली व्हॉट इज फोन ऍडिक्शन? So it is obsessive use of a smartphone. So what is nomophobia, or the fear of being without a mobile device? The word addiction comes from Latin addictus, which means excessively devoted to something with loss of ability to choose freely. And what is process addiction? It is a disorder of behavior and not abuse of addiction for substance. So that is very important. Actually, we should know that there are 3.8 billion smartphone users in the world, and they receive 427% more messages and notification than they did a decade ago. And they also send 278% more text. So now it is a natural necessity of life that we all know that mobile we cannot throw out of our house. So increasing number of smartphone users in small children, school-age children improve the risk of addiction. And scientists says that release of feel-good chemical in the brain during social media activities can be more intense than heroin use. So that is very important sentence, that feel-good chemicals are very important. And this is we must know that how it happens. So this is a biopsychosocial perspective of smartphone addiction, where biological factors like neurochemistry, sleep disorders, eye problems, stress problems, or social environmental problems like loneliness or virtual relationship. Nowadays, actually, पूर्वी कसं असायचं की आपल्याला खूप मित्रमंडळी असायची. आता सगळेजण काय म्हणतात की बाबा तुला फेसबुकवर किती मित्र आहेत, तुला इन्स्टावर किती आहेत, त्याच्यावरती त्यांचा पॉप्युलॅरिटी काउंट केली जाते, म्हणजे मुलांमध्ये सुद्धा. म्हणजे ते खूप महत्वाचं असतं. आणि मग सायकोलॉजिकल प्रॉब्लेम्स पण असतात, सेल्फ एस्टीम, अँझायटी, डिप्रेशन, अँगर, आपण खूप प्रॉब्लेम हे पाहतोय सध्या रोज. आणि मग त्याच्यामध्ये बेसिकली ऑल दीज फॅक्टर्स अफेक्ट मेंटल हेल्थ अँड इंटरपर्सनल रिलेशनशिप. So actually what happens in the brain, that is very important. So it is a chronic phone overuse is proven to change reward circuit, and this is proved that scientifically, that GABA is an inhibitory neurotransmitter that produces a calming or euphoric effect, and it can control fear and anxiety. And the inhibitor plays significant role in addiction by rewarding substance use and reinforcing addictive behavior. So chronic phone use can increase or decrease GABA. And the most important is that the teens, this experiment has been done, and teen who received cognitive behavioral therapy, their brain chemistry reverted to non-addicted ratio. That is important. So that's why
it is not that it is a permanent effect. So there are other things which has been proved, that there is decrease in the gray matter. So that is also has been proved in those who are having cell phone addiction. So that is also one of the important factor we should remember. So actually almost all cell phone users, म्हणजे आपण सुद्धा आपल्याकडे काय करतो की झोपण्याच्या जागेच्या तिथेच आपला मोबाईल असतो आणि मग त्याच्यामध्ये ते वेकिंग आवर्स जे असतात त्यावेळेला पहिल्यांदा आपण काय करतो, उठल्या पहिल्यांदा आपण शेजारी आपले मुलं असतील किंवा नवरा असेल किंवा बायको असेल तर त्यांना कोणी पहिल्यांदा गुड मॉर्निंग नाही म्हणत, पहिल्यांदा आपण काय करतो तो घेतो आणि काय आहे काय नाही ते बघत राहतो. So that is very important. ते बऱ्याच वेळेला ते प्रॉब्लेम येतो की people may wish to cut back but continue to check their phones frequently, and many people check their phones upon waking even before they say good morning to their loved ones. So young adults reportedly check their phones every few minutes. In fact, society uses cell phone so much that they have become an extension of the self, like an extra appendage. So that has happened. So what are the signs and symptoms of cell phone addiction? So lying about the smartphone use, की मी कमी वेळ वापरतो वगैरे असे सांगणारे नक्कीच खोटं बोलत असतात. लव्ड वन एक्सप्रेसिंग कन्सर्न, की आईला वाटतं, वडिलांना काळजी वाटते. निग्लेक्ट और ट्रबल कंप्लीटिंग ड्युटीज ॲट वर्क, स्कूल और होम. More and more time using phone, checking people's profile repeatedly due to anxiety. ते काय करतंय, त्यांचा वाढदिवस आहे का, त्यांनी काय केलं, त्याच्या बाबतीत काय झालं, प्रत्येकाचं ते प्रोफाईल चेक करणं खूप चालू असतं. Accidents or injury due to phone use, working later to the complete task, and weak or non-existent social life, which has happened. Then other sign symptoms like isolation from the loved ones, feeling of lack of connection, angry or irritated if phone is interrupted, getting up at night to check a phone. अरे काय त्यांचं काय रात्री चाललंय, काय त्यांनी काही मेसेज टाकलाय का. Reaching for the phone the moment they are alone or bored. आणि फॅन्टम व्हायब्रेशन, अरे वाजला का, आपल्याला बऱ्याचदा असं अरे की खूप वेळ झाला बाबा नाही वाजला, 10 मिनिटं झाले, 5 मिनिटं झाले, फॅन्टम व्हायब्रेशन्स म्हणतात त्याला. क्रेविंग ऍक्सेस टू द स्मार्टफोन अँड अनदर डिव्हाइस अँड फिअर ऑफ मिसिंग आउट. हे खूप महत्वाचं आहे. म्हणजे अशा प्रकारे आपण त्याच्यामध्ये साइन सिम्पटम्स वरतून ओळखू शकतो. आता निगेटिव्ह इफेक्ट्स काय काय असतात. स्लीप डेफिसिट, आपल्याला माहिती आहे बऱ्याच मुलांच्या बाबतीत हा प्रॉब्लेम आता येतोय. लोअर कॉन्सन्ट्रेशन, क्रिएटिव्हिटी ब्लॉक, कारण सगळं आयतं मिळत आहे आणि त्याच्यामुळे ते विचार करणं सोडून दिलंय. ॲग्रिवेटेड आणि ॲडेड अँझायटी, रिड्युस्ड कॉग्निशन, स्ट्रेस, लोनलीनेस, इनसिक्युरिटी, इम्पेर्ड रिलेशनशिप, पुअर ग्रेड्स आणि सायकोलॉजिकल डिसऑर्डर्स. सो ऑल दीज आर निगेटिव्ह इफेक्ट्स. मग त्याच्यामध्ये या मुलांच्या बाबतीमध्ये काय प्रॉब्लेम येतो की त्या सगळ्या निगेटिव्ह इफेक्ट्समुळे त्यांचा परफॉर्मन्स स्कूलमध्ये पण कमी होतो. त्यांचा परफॉर्मन्स आपल्याला दिसायला लागल्यावरती मग त्यांच्या आई वडिलांना जाग येते, अरे की हा का असं करतोय, काय नाहीये. मग आता पूर्वी तर चांगला होता, आता जसं 5वीत गेला तेव्हापासून. आणि मग मागच्या करोनाच्या काळामध्ये तर असं झालंय की मुलांना आई वडिलांना हेच माहिती नाहीये की मुलं नेमकं ऑनलाईन शिक्षण घेत होते का मोबाईलवरती वेगळ्या गोष्टी करत होते. आणि मग ते त्यांच्या बाबतीमध्ये त्यांचे ऍडिक्शनचे बरेच केसेस आमच्याकडे अशा आलेले आहेत की ज्याच्यामध्ये आम्हाला बरेच काउन्सिलिंगच्या गोष्टी करायला लागल्या. त्याच्यामध्ये मी जे मीडिया हिस्ट्रीच्या बाबतीत सांगत होतो तेच आता सेलफोन हिस्ट्रीच्या बाबतीत सांगेन की हिस्ट्री कशी घ्यायची आपण, ती आपल्याला सवय लागली पाहिजे. हाऊ मेनी आवर्स टू विच मीडिया, अंडर व्हॉट कंडिशन, व्हॉट आर द कंटेंट ऑफ प्रोग्राम, सिलेक्शन क्रायटेरिया, सुपरविजन बाय अडल्ट, अदर लिजर टाइम ऍक्टिव्हिटी, इन्फरन्स डिस्कशन होतं की नाही. न्यूट्रिशन हिस्ट्री, आपल्याकडे सगळ्या आयात सांगतात मोबाईल बघितल्याशिवाय जेवतच नाही. आता मोबाईल नसताना पण मुलं जेवतच होती पूर्वी, पण आता हे त्यांना अगदी म्हणजे कॉमन असतं. तसंच आपल्याला एखादा असा एकदम हिरो येतो, तो काहीतरी सुरा काढतो, खून करतो आणि तो गॉगल बिगल घातलेला असतो, त्या मुलाला त्याचं खूप अट्रॅक्शन वाटतं. पण त्याच्या आईनी जर त्याच्या शेजारी बसून ते पाहिलं असेल आणि तिने सांगितलं की हे असं केलं तर सगळं आयुष्य जेलमध्ये जाईल, तर मग मात्र त्याला कधीच त्याचं आकर्षण नाही वाटणार. सो दॅट्स वाय इट इज व्हेरी इम्पॉर्टंट दॅट इन्फरन्स डिस्कशन इज व्हेरी इम्पॉर्टंट. आणि मग अदर लिजर टाइम ऍक्टिव्हिटीज काय आहेत त्या मुलाच्या, ते पण महत्वाचं आहे. सो आयदर वी आर युझिंग दॅट ॲज अ थर्ड पेरेंट or servant is very important. So how to break cell phone addiction? So don't use phone as an alarm clock. Resist the urge to check your phone immediately upon waking. Your phone charging should be in another room. Set limits of use. Do not use phone during meal time. Turn your phone off for a specified time. Leave phone at home or car and forget it. देन प्रॅक्टिस माइंडफुलनेस. मोठ्याने श्वास घ्या, ऍप्रिशिएट करा की आपल्या सराउंडिंग पण खूप चांगलं आहे, नुसतं फोनच नाही आहे, आपल्याला बाकीचं पण सराउंडिंग आहे. एक्नॉलेज युअर इमोशन्स, सीक असिस्टन्स फ्रॉम युअर हेल्दी डिस्ट्रॅक्शन. आता इन्व्हेस्टिगेशन हल्ली काय की आपल्याला सगळ्या गोष्टी एव्हिडन्स बेस्ड झालेल्या आहेत. त्याच्यामुळे एव्हिडन्स बेस्ड सांगायला लागतं पेरेंट्सना की खरंच तुमच्या मुलाला आहे का नाही सेलफोन ऍडिक्शन. मग त्यासाठी स्केल निघालेले आहेत. स्मार्टफोन ऍडिक्शन स्केल आहे, नंतर इंटरनेट ऍडिक्शन स्केल आहे, चेन्स इंटरनेट ऍडिक्शन स्केल, या प्रकारच्या स्केल्स आहेत. कारण आता अजूनपर्यंत DSM-5 क्रायटेरियामध्ये त्याचे डेफिनेशन्स आलेली नाहीये सेलफोन ऍडिक्शनची. So what is the self-treatment? Make rule for concerning phone uses, designate activities in which phone is forbidden, schedule back break times, download application to help cut down the phone uses. आणि सेलफोन ऍडिक्शन ट्रीटमेंट मध्ये या ट्रीटमेंट आम्ही आमच्या सेंटरला देतो की ज्या मला असं वाटतं की आपल्याला आता बेसिकली हे आपल्याला सांगता आलं पाहिजे पेरेंट्सना की काय काय करायला पाहिजे. की बिहेव्हिअरल ट्रीटमेंटमध्ये बिहेव्हिअरल मॉडिफिकेशन असेल, कॉग्निटिव्ह बिहेव्हिअरल थेरपी मी आता थोडा 2 मिनिटं सांगणार आहे, हार्म रिडक्शन थेरपी असेल, नॉन मॉनिटरिंग डिस्फंक्शनल थॉट, लर्निंग न्यू कोपिंग स्किल टू प्रिव्हेंट रिलॅप्स, टाइम मॅनेजमेंट, मोटिवेशनल इंटरव्ह्यूइंग हे खूप महत्वाचं असतं. त्याच्यामध्ये माइंडफुलनेस असेल, थेरप्युटिक रिक्रिएशन असेल, म्युझिक थेरपी, ड्रमिंग ऍक्टिव्हिटीज, या सगळ्या ट्रीटमेंट असतात. आता कॉग्निटिव्ह बिहेव्हिअरल थेरपीमध्ये बेसिकली काय केलं जातं, अतिशय सोप्या गोष्टी आहेत की त्यांचे जे थॉट्स असतात, सो लर्न हाऊ टू कंट्रोल देअर थॉट्स अँड फिलिंग्स दॅट कॅन बी डेट्रिमेंटल टू देअर फंक्शनिंग अँड मे ट्रिगर इम्पल्स. म्हणजे त्यांना सांगितलं गेलं पाहिजे की ते का नाही पाहायचं आहे, त्याच्यामुळे काय परिणाम होत आहेत आणि ते परिणाम आपण कसे नाहीसे करू शकतो. त्याच्यासाठी त्यांना ते सांगताना आपल्याला त्या व्हर्च्युअल वर्ल्ड मध्ये त्यांना त्या बाबतीतला गायडन्स दिला पाहिजे. सो ॲडिक्ट्स ग्रॅज्युअली लर्न हाऊ टू सॉल्व्ह द प्रॉब्लेम्स इन मोर कन्स्ट्रक्टिव्ह वे. मग मोबाईल द्यायचा नाही तर काय करायचं हे सांगितलं गेलं पाहिजे आणि ते फार महत्वाचं असतं. आणि मग याच्यामध्ये फर्स्ट स्टेज थेरपीमध्ये फोकस ऑन बिहेव्हिअरल आस्पेक्ट आणि नेक्स्ट स्टेजमध्ये पॉझिटिव्ह कॉग्निटिव्ह अझम्पशन. सो ॲडिक्ट्स आयडेंटिफाय फॉल्स बिलीफ्स अँड दे लर्न हाऊ टू मॉडिफाय देम. याला आपण कॉग्निटिव्ह बिहेव्हिअरल थेरपी म्हणतो. मग अजून बाकीच्या आर्ट थेरपी आहे, योगा थेरपी आहे की योगा इज अ माइंड बॉडी मेडिसिन आपल्याला माहिती आहे आता, आणि इट इज अ पॉसिबल सोल्युशन फॉर दिस स्मॉल माल अडॅप्टिव्ह बिहेवियर. आणि मग पेरेंट्स रोल फार महत्वाचा आहे. आता मी सांगितल्याप्रमाणे की यूज मीडिया वाईजली, दॅट इज व्हेरी इम्पॉर्टंट मेसेज. आणि मग पेरेंट्स शुड हॅव अ गुड सुपरविजन बिकॉज दे आर गेटकीपर्स हुज रोल इज to facilitate access restriction of the use of digital technology including time and content. याच्यामध्ये एक महत्वाची गोष्ट की काय नुसता टाइम महत्वाचा नाहीये, कंटेंट पण महत्वाचे. त्यामुळे कंटेंट कडे पण लक्ष दिलं गेलं पाहिजे. आणि डिस्कशन बिटवीन पेरेंट्स अँड चिल्ड्रन अबाउट द बेनिफिट्स अँड इम्पॅक्ट्स ऑफ द स्मार्टफोन युजेस. आता ऍक्च्युली स्ट्रेंथन द रिलेशनशिप हे फार सुंदर वाक्य आहे. देर इज नो ऍप टू रिप्लेस युअर लॅप. आणि सो रीड युअर चाइल्ड, दॅट इज व्हेरी इम्पॉर्टंट. सो त्यांना सवय लावा. हे जे मी मेडिसिन्सची स्लाइड दाखवतोय ही महत्वाची का आहे, कारण हे USA FDA अप्रूव्ड ड्रग्ज आहेत की जे आपण ज्यांना ऍडिक्शन जास्त आहे त्या मुलांना ते वापरू शकतो. आयदर अँटी डिप्रेसंट ड्रग्ज असतील, अँटी सायकोटिक ड्रग्ज असतील किंवा ओपिएड रिसेप्टर असतील, सायकोस्टिम्युलंट असतील. पण सर्वात महत्वाची गोष्ट काय आहे ती म्हणजे क्रॉनिक एक्सरसाइज एंगेजमेंट जर असेल, it is associated with less smartphone addiction and fewer withdrawal and mood related symptoms. So exercise is more important than other therapies. मग डिजिटल इंटरव्हेन्शन काही प्रकारचे दिले जातात की ज्याच्यामध्ये प्रॉब्लेमॅटिक स्मार्टफोन यूज इज बेस्ट मेजर्ड बाय सेल्फ रिपोर्ट्स टूल. तर सेल्फ रिपोर्ट्स टूल कोणतं असतं, MPPUS म्हणून एक आहे की ज्या टूलच्या साह्याने आपण ते त्याचे पॉइंट्स हे करतात आणि ते आपल्याला गायडन्स देत असतं. त्याच्यानंतर 8 to 12 वीक्स प्रोग्राम आहे हा की ज्याच्यामध्ये त्यांना डिस्कनेक्ट केलं जातं डिजिटल मीडियापासून आणि मग त्यांना त्यांच्या पुढच्या गोष्टी त्यांच्या शिकवल्या जातात. हा पण एक प्रोग्राम आहे. सो ऍक्च्युली these are last 2 slides. Don't let phone addiction win. We know that cell phone is definitely excellent source of information, but we know that it is potentially dangerous also. So be proactive. Do not let a phone consume anyone's life. Step towards recovery and all-out phone detox. As much awareness to the issues as you can and conscious of our issues and tracking our behavior as best as we can do. So what are the take-home messages? It's time to identify the impact of cell phone and media addiction. Talk about cell phone media addiction to our parents. हे अतिशय महत्वाचं मला वाटतं की ज्याच्या बाबतीत IIP ने आता खूप पुढे यायची गरज आहे आणि काही प्रोग्राम्स तयार करायची गरज आहे. म्हणजे मी सरांना पण त्याच्यामध्ये सांगेल की मीडिया पॉलिसी हा एक अतिशय महत्वाचा इश्यू आहे की त्याच्यामध्ये आपण IIP ने ऍक्टिव्हली इन्व्हॉल्व्ह होऊन करायला पाहिजे की मीडिया पॉलिसी शुड कॉन्ट्रीब्यूट टू पॉझिटिव्ह रोल इन डेव्हलपिंग चाइल्ड्स लाईफ. Work ahead is to discover what is beneficial, for whom it is beneficial, and when it is beneficial. So be vigilant to find out cases with addiction, and always prevention is better than cure. Thank you very much.
थँक्यू सुचित, खूपच छान सांगितलं तू. आणि तो आवडला आम्हाला की there's no better app than mother's lap. So be friends to your children.
One question, Suchit. Incidence of ADHD or like autism in relation to during COVID had been increased. What is your take home?
Yes, actually, pseudo autism cases has increased, and those patients who has been actually their addiction with, we have decreased that addiction, and now the school has started. Their symptoms are also decreasing. So many times it may be a pseudo autism also. So we have to just check it out and monitor them every 3 months or 6 months.
Thank you, Suchit.
Thank you, sir. Our next speaker is Dr. Chaitanya Datar. There can be no worse tragedy for man than the realization that his newborn child is suffering from what he calls the curse of God, and what you and I call as genetic disorders. We, the pediatrician, are bestowed with the task of not only diagnosing these inborn handicaps, but also at best to treat, and at the very least to allay the anxiety of the family. We have with us today Dr. Chaitanya Datar, who is going to take us through the journey of identifying these problems with his case-based approach in genetic disorders. Thank you.
Thank you, ma'am. At the outset, let me thank the MAHAPEDICON for this opportunity. And to begin with, my talk is on case-based approach to genetic disorders. It's a very short time to cover so many topics, but I've just tried to put everything together. Genetic technology is progressing like anything in these past few decades. We've moved from karyotype in 1985 to now we are just talking about exomes and arrays. And so also things have moved from bench to bedside. A lot of therapeutics is now coming. I'll show you some case-based examples, how we can apply the genetic diagnosis to specific treatments. So we have enzyme replacement therapy, we have specific diet medications which are available. And now we are progressing towards gene-based therapies as well. And therefore, now we are in this era of genomics. So wherein pan-India, the thing has spread wide. So earlier, we can be pre-genomic pediatricians, wherein we are just diagnosing based on our clinical cues, not doing many investigations and leaving it at it. Or we are uber genomic pediatricians, wherein we are doing a lot of investigation, directly ordering the exomes. But what we need to be is genomic pediatrician and strike a proper balance between both. So based on all these parameters is what I will be discussing today. But there's no one test fits all approach in genetics. So essentially, when we are dealing with things at the chromosome level, so chromosomes, disorders like Down syndrome, Patau-Edward is what we know. When we open up the chromosome, we have chromosomal segments. That is what is called contiguous gene syndromes. And if things are happening at the rung of the ladder, that is called as a single gene disorder. Now, dysmorphism. So typically karyotype now is limited to a few conditions like Down syndrome or Turner syndrome, only to confirm these conditions. Where you have physical traits, you are confirming that. Similarly, FISH as a tool is fluorescence sensitive hybridization is used for typical conditions wherein the FISH probe is available, like Prader-Willi or we have a Williams syndrome. But for all other practical purposes, now in pediatrics, we have switched to microarray, which is going deeper than the chromosome to look at chromosomal segments. Now you see a child has dysmorphic features. We have overall, see the facial and limb dysmorphism is noted. The child is intellectually disabled. The IQ is 43, a lot of behavioral issues and speech delay, and array has showed us a 1p36 microdeletion. So for cases with dysmorphism, autism, non-specific developmental delays, intellectual disability, microarray should be used as a first tier test in genetics. So when we're doing a microarray, I'm looking at all these 46 books. When I'm doing a karyotype, I'm looking at the 46 books from outside. When I'm opening up the chapter, that is when I'm looking at the microarray. And when I'm opening up the pages and reading each page letter by letter, that is when I'm doing the exome sequencing. So now here what we are finding is there are very specific pointers. You can see the tongue nodules, you can see the polydactyly, you can see the molar tooth sign. So now we know that this is looking like a Joubert syndrome. So when we have a specified condition which is at hand, we are directly opting for that particular test. In this case, it's going to be exome sequencing, which is going to pick up that specific mutation in the C5ORF42 gene. So when specific well-defined features are known, you're going for a single gene evaluation. But we have to be aware that exome will not pick up all and every condition. Like for example, here this is a case of methylpigment. Through an exome, it's going to come out to be normal. This is picked up by a methylation study. So what is very, very crucial is we need to understand that exome is not an answer for everything. So now I'll take some metabolic conditions. This child is 1 year old with a developmental delay. Motor is more than mental, with a poor head control, with a lot of tremulousness and a movement disorder, and a very fair child with light colored skin and hair. Here what we see, observe, is the phenylalanine level is raised. It's almost 1,100 is the phenylalanine level. So do we label it as a phenylketonuria? What we must understand, there are two conditions. One is the classical PKU, and the other is something called non-PKU hyperphenylalaninemia, wherein this is a very treatable disorder. It's a movement disorder and very well treated by tetrahydrobiopterin. So once we started this, we identified the mutation. Once we started this treatment, the child started walking, the tremulousness reduced, the activity improved, and the cognition improved. And now he's doing absolutely well on therapy, and he was started on tetrahydrobiopterin along with DOPA. So these are treatable things, especially from the metabolic point of view when you evaluate. Now this child was labeled, so essentially has spasticity with a fairly good cognition, and was called labeled as a spastic CP-like presentation. But ultimately we found at 5 years of age, he had a lot of bouts of vomiting, and he was admitted to the ICU. There he was diagnosed to have argyninemia. Once the treatment for argyninemia was started, this child started doing well. His spasticity reduced and he improved significantly. So essentially, similarly, suspected CP, you should be ruling out a metabolic etiology. You may find a metabolic etiology in about, or genetic etiology in at least 40 to 50% of such cases. So this is a video before and after the presentation. You can see the looks on his face, overall his activity as well. The other common thing that we come across in the ICUs is a hypoglycemic baby. So essentially both these cases have a normal birth history presented with poor cry, feeding activity with intractable hypoglycemia. Now both cases were consanguineous. In this particular family, the cortisol levels were low, and the parents informed about dark pigmentation. So this is a condition which is called familial glucocorticoid deficiency, a very well-treated condition. Vis-a-vis, this patient showed a hyperinsulinemia. Insulin was 34 at a BSL of 15. And though the treatment was started, this child succumbed. And this was a case, what is called as a congenital hyperinsulinism. So again, similar presenting cases you can differentiate based on genetics. Now, a 6-month-old baby presenting with hepatomegaly and cardiomegaly in the ICU, the BSL was 33. So what was found here in this particular patient on biochemical screening is a LCAT, the long-chain acyl-CoA dehydrogenase deficiency. Now, this is one treatable fatty acid oxidation defect. Once we started treatment, both the cardiomegaly as well as hepatomegaly reverted back to normal. And overall, now the child is actually going to school almost 7 years old. So that highlights the importance of an early pickup and a proper evaluation of these children. Similarly, in this case, you can see the MRI is so bad in the PICU. At 3 months of age, presented with acute encephalopathy and had seizures, lethargy, was comatose. MRI showed significant restriction, diffusion, with, and the parents were given that 90% the child will not survive. We identified this as a case of citrullinemia, gave her aggressive treatment, and now there was a regression of milestones. So with all the therapies, the metabolic management, now this child is again going to school, doing exceedingly well at school. So that, again, very, very important. Don't miss treatable metabolic conditions in these cases. In some unfortunate cases, however, what happens is we are not able to really give a conclusive diagnosis at that time. But in such cases, like for example, this baby presented with vomiting, crying, lethargy, hepatomegaly, and many abnormalities on TMS. Ultimately we stored the DNA and then gave them a diagnosis of a mitochondrial cytohepatopathy. Now for these parents, for the next pregnancy, this is going to be very, very crucial. Now, there are therapies which are available, though expensive, but because of the the rare disease policy is now likely to come up. So with this, the patients will have access to these kind of therapies as well. So here, this is a case of Gaucher's disease. Essentially, the liver was enlarged, the spleen was enlarged. The spleen was almost 17, 18 centimeters in size. And once we started this particular enzyme replacement, there were significant improvements. The liver almost normalized. The spleen has become quite soft. The child improved in milestones. Hematological parameters improved and the child became quite stable. So these are therapies wherein essentially we can offer a good outcome to these patients. Now, a quick word on the neuromuscular issues that we face. Now, what we know that essentially if the issues are at the brain level, we are calling it as a floppy strong or floppy weak. The commonest condition that we come across is spinal muscular atrophy. Now, it can present at any age. Essentially, what we know is the spinal muscular atrophy type 0, which presents in the newborn period, but we have seen a 55-year-old gentleman being diagnosed with an SMA just after a fall. So essentially, the test of choice here is an MLPA, and it's different from an exome. It's not picked up again on the exome. And this is the one gene, SMN2, which is a modifier gene for SMN1, which is causing a late onset phenotype in the SMN0 individual. So more the number of copies of SMN2, the milder will be the presentation. Duchenne muscular dystrophy, a very common muscular dystrophy, 70% will be diagnosed by a test called MLPA, while about 30% will have a point mutation. Now we'll go to seizures as a presentation. So essentially those with seizures can have a genetic origin. So in this particular child, again labeled as a CP, had seizures with microcephaly, a non-consanguineous family, presented with intractable seizures, and he showed a mutation in one particular gene called DIAPH1. But we have treatable epilepsies as well. Biotinidase deficiency and excellently treated epilepsy, if you pick them up in time, they may not present always with the hair and the skin manifestations, or a pyridoxine responsive seizures. These patients have an absolutely chaotic EEG, and 1 or 2 doses of pyridoxine of 100 milligram IV that would improve the seizures and lead to completely normal outcomes. Again, we have these channelopathy related seizures. Nowadays, neurology, almost about 80 to 90% neurology is largely based on genetic identifications. And these channelopathies, we have specific drugs which are available to manage these conditions well. So these are called as genetic channelopathies. Now, quickly going to some other behavioral issues. We have dysmorphism, and we see that the brain MRI is abnormal. So just based on the GestOT, that is physique, we identify this as coffin Cyrus. Why we need the mutations? So that we can offer a prenatal diagnosis for the future conception. Autism. Is autism genetic? When the child is syndromic, that is showing dysmorphism, developmental delay, intellectual disability, these cases must be investigated for genetic etiology. This particular child had all these issues, and she showed a duplication in chromosome 15q. Now, another child, this baby had, along with autism, she has a developmental delay, she has a lot of motor issues. You can see the CPK is raised. This turned out to be a mitochondrial cause for autism, so which is called as a megaconial congenital muscular dystrophy. It is a muscular dystrophy causing autistic features. This was one of the highlighting case wherein 2 siblings are affected. Essentially, the older sibling is 9 years, has a lot of intellectual disability. The younger sibling was the concern, who presented. You can see the video is not there, but global developmental delay, no speech, extremely tremulousness was there. There was increased tone. In this child, we identified that certain branch chain amino acids in the brain were low because of a genetic deficiency. We could supplement these amino acids orally, and the child showed significant improvement. So these are treatable causes of intellectual delay, and within 6 months' time, the motor milestones improved quite well in this child. Similarly, you can have these kind of skeletal involvement in children. So wherein this particular child, what you can see and appreciate, the significant osteolysis of the mandible, and you can see the osteolysis of the tips also. So skeletal issues presenting. So this is what is called as mandibular acral dysplasia, with lipodystrophy. Again, all these conditions, essentially, we can offer a proper counseling, prognosis, and future prenatal diagnosis for the parents. A very dreaded condition wherein the child absolutely cannot move the limbs, gets frequent infections, and this is a particular condition which is called hyaline fibromatosis syndrome, lethal syndrome, but again, for future prenatal diagnosis, it's quite helpful. Hearing loss. What we must remember for hearing loss cases, almost 80% hearing loss is genetic. So it could be syndromic in 30% like Waardenburg, 70% it's only hearing loss, no other feature that may be present. So there's a spectrum of features, how a genetic disorder can present. It can be a skin related issue. It could be kidneys, it could be liver, genitalia. So it's almost all the systems that genetics would really encompass. So what is crucial here in these cases, and what is the role of the pediatrician here? Now, in both these cases, what we know, the outcomes are extremely guarded. Now, this particular first baby had a cutis laxa-like presentation, hypoplastic lungs with emphysema, and you can see how lax the skin is. So essentially, the survival is extremely bleak. But two things that are necessary in these cases is one, DNA storage, and second, photographs of the baby. DNA storage is essentially to plan the further investigations so that, for the future children, they can prevent these issues from occurring, because antenatally there may not be any physical diagnosis on ultrasound. So we need to have a genetic diagnosis to be able to offer prenatal testing. Or this particular case, two siblings born full term by cesarean section. Essentially, the first baby did not cry at birth, passed away at 1 month of age because of seizures and all the other issues. Second baby also with an MRCP-like picture. So do we expect two babies born with a cesarean section, good birth weight babies, having these issues? So this turned out to be what is called as hyperhomocystinemia. There was antenatal brain thrombosis of the blood vessels, which was causing these issues. So have a high index of suspicion towards a genetic diagnosis for unexplained perinatal deaths. So any death which is happening between 28 weeks in utero to 1 month, always have a high index of suspicion. 30 to 40% cases, you may get a genetic etiology. So in summary, a proper clinical approach is what is required, and it should not be a random approach of directly ordering certain tests. Proper phenotyping, as I showed you, is necessary to be able to reach a conclusive diagnosis. Proper genetic counseling is essential. And all genetic reports should be subject to something called reverse phenotyping. We have the report, we should go back and check whether the condition matches, because most of the times it will be a variant of uncertain significance, which may not really match with the clinical presentation. So why do we need a definitive genetic diagnosis? It's to discuss the risks of recurrence, accurate prognostication, and planning therapeutics, as we discussed in some of our cases. Thank you so much.
Tanya? Thank you for a very wonderful presentation. My colleague has a question for you.
Thank you, Dr. Zadra. Very wonderful eye-opener for us, which we don't do exon sequencing, then store DNA. Many of things were not known, but we refer to our pediatric neurologists and they do it. One question, simple. We come across many cases of Duchenne muscular dystrophy, and there we are left with only steroid. Is there any advances in the management, including stem cell or anything?
Yeah, so as far as current this thing is concerned, deflazacort is the only approved therapy at this point in time. Gene-based therapies are coming up, but that is, essentially antisense oligonucleotide therapy or, exon skipping therapies are coming up. But as I mentioned, they are still, it may be a little time wherein we have a few cases which are ongoing currently under trial basis actually, but not actually, it may be a little expensive therapy at this point in time to afford.
Thank you very much. Thank you all the three speakers, Dr. Datta, Dr. Tamboi, Dr. Gunachar. Give a big round of applause to them. Yeah. Thank you, Dr. Kopika, for giving opportunity to us.
I request Dr. Bodhankar sir to felicitate Dr. Raj Ganacharya.
By the way, both are classmates, batchmates. Hemant Doshi, Archana and me. Same batch, 72.
I request Dr. Archana Joshi ma'am to felicitate Dr. Suchit Tamboli sir. Dr. Tamboli sir. And I request Dr. Bodhankar sir to felicitate Dr. Chaitanya Datar. May I request Dr. Mohan Tembe sir to felicitate our chairpersons?
Thank you so much, all the dear panelists here. And thank you very much, Dr. Chaitanya Datar, because I don't know about others, but I am usually too scared of genetic disorders, sir. So taking a divergent talk from here, I call upon stage our next set of lecturers, Dr. Atul Kanitkar, Dr. Swati Bhave ma'am, Dr. Sandeep Vakde, for our next talk. Nowadays, everything is digitalized. And as social media has become an integral part of our lives, we come across a lot of high-level media designations. By the way, do you know we are called millennials? Because we were born before 9/11 and got access to social media in our adulthood. Similarly, there is a lot of buzz going around our children who are labeled as Gen X, Gen Z, and the latest comes the succeeding generation designated as Gen Alpha. So this Gen Alpha are the youngest of the lot who spend hours and hours in front of screen. And sometimes it terrifies me to the core when I think what is coming into the future. So while having a little tea, let's have some chai pe charcha together so that we shall understand the mentality of this generation kids and how to cope up with it. Atul sir, yes sir. Sorry sir.
So namaskar. When I entered this hall, मला सूचित मराठीत बोलताना दिसला फार बरं वाटलं. म्हटलं चला आपणही आता बोलू शकतो. कोणी मराठी समजणार नसेल तर त्यांनी हात वर करावा. ज्यांनी हात वर केलाय त्यांना मराठी समजतं म्हणजे प्रश्न समजलाय म्हणून असं मी समजू शकतो. Now with the permission of my senior Nasik teachers, Bodhankar sir, my colleague, my friend, Dr. Sandeep, ज्यांना मी आज सकाळीच भेटलो, who is a locum for Dr. Swati Bhave madam. Swati Bhave madam will be here with us virtually. काही लोक साथ सोडत नाहीत त्यापैकी त्या आहेत त्यामुळे त्या असतील आपल्या बरोबर. She is not well. She has atrial fibrillation आणि बाकीचे issues आहेत. So at the outset, I would like to thank my home team, especially the scientific committee of MAHAPEDICON, and of course the office bearers for this particular platform that has been offered to me. I must also thank the timekeepers for giving me some extra time because I may need so. आणि यशवंत पाटील सर आहेत, आमच्या संगीता मॅडम आहेत तिथे. सुचित, shall I start the show? So basically the flow is like in next 40 minutes or 45 minutes, whatever. We'll have a basic discussion मग मॅडमचं एक व्हर्च्युअल प्लॅटफॉर्म आहे, त्याच्यावरती मॅडमचं एक 20 मिनिटाचं भाषण आहे, प्लस केस बेस सिनारिओ आहे. That will be followed by Sandeep sir's case, which is of primary importance for all of us, academic worsening. आणि त्यानंतर जर वेळ उरला तर माझी एक डेलिकेट केस आहे थोडीशी. सो शॅल बी चाय पे चर्चा मध्ये निदान पाणी तर पाजा लेको. अरे मी घेतो थांब. एवढ्या मोठ्या क्राऊड समोर तोंडाला जरा कोरड पडते म्हणून, बाकी काही नाही. So how do we start this show? ही एक मुलगी माझ्याकडे आली होती साधारण 5-6 वर्षापूर्वी. दिस वॉज अ 14 years old गर्ल. तिच्या आईला शाळेच्या बॅग मध्ये आय लव्ह यू ची चिठ्ठी सापडली आणि नाशिक मधलीच विद्यार्थिनी, अतिशय सुंदर. मी तिला जन्मापासून बघत होतो. सो हेमाला फार असं काही डिस्कस करायचं नव्हतं, बिईंग 14 years old. आणि घरी आईने आले आले तिला धपाटा मारला. शी कॉल्ड ऑफ द फादर. फादर केम फ्रॉम द ऑफिस. वडिलांनी पण 2 धपाटे घातले. अँड दिस गर्ल गॉट बग्ड अप. तिने स्वतःला खोलीत कोंडून घेतलं. नेक्स्ट डे मॉर्निंग वेन शी डिडंट ओपन द डोअर, दे वर पॅनिकी आणि दे ब्रॉट हर टू मी. आता जेव्हा ती माझ्याकडे आली तेव्हा शी वॉज विथ ऑल रेड आईज, स्वोलन आईज, आणि इतकी सुंदर दिसणारी मुलगी, पण शी वॉज नॉट ऍक्च्युअली लुकिंग वेल. आई वडील टेन्शन मध्ये. सो आय वॉज लिटल alarmed to see such a beautiful girl in such a distressed mood. So I just asked them one question. Which question would that be? Can you guess? Anyone? Madam? एकच प्रश्न विचारला आई वडिलांना, and then I sent them in the waiting area. पटपट बोला, माझा वेळ कमी होतोय. Anyone? When was the LMP? When was the last menstrual period? आणि त्यांना कळेना हे असं का विचारतायत. सो वेन दे सेड की एक 8 दिवसापूर्वीच पिरियड्स आले होते, आय सेड प्लीज गो आउट. व्हॉट आय वॉन्टेड टू रूल आउट वॉज टीनेज प्रेग्नन्सी. राईट. ते बाहेर गेल्यानंतर आय जस्ट यूज ऑल माय पॉसिबल कम्युनिकेशन स्किल्स टू मेक द चाइल्ड व्हेंट आउट. मी पहिल्यांदा तिला खाली बसवलं माझ्या जवळच्या खुर्चीवरती. द फादर अँड मदर वेअर स्केप्टिकल. माझ्या काचेतनं दिसत होतं त्यांना, पण दे कुडंट हिअर अस. सो आय प्रोव्हाइडेड ऑल द प्रायव्हसी अँड कॉन्फिडेन्शियलिटी टू द चाइल्ड. आय आस्क्ड हर, बाळ काय झालं? जस्ट तिच्या हातावरती हात ठेवून विचारलं, अँड शी क्राईड. शी क्राईड. आणि तिने सांगितलं की अशी अशी चिठ्ठी मला मिळाली. अँड देन आय आस्क्ड हर वन ओपन एंडेड क्वेश्चन. ओपन एंडेड म्हणजे ज्याचा आन्सर तुम्हाला डिस्क्रिप्टिव्ह मिळतं तो. सो दॅट वॉज, व्हॉट वॉज युअर रिॲक्शन वेन यू गॉट दिस पर्टिक्युलर चिट? आणि ती म्हणे काहीच नाही काका, यु नो अशा चिठ्ठ्या मला खूप मिळतात, आमच्या शाळेतल्या प्रत्येक मुलीला मिळतात. ही दरवेळेला मी त्या मुलाकडे बघते, स्माइल करते आणि फाडून फेकून देते. ही चुकून माझ्या दप्तरात राहिली आणि ती नेमकी आईला सापडली. आणि आईने मला जाऊन, मग मी पण ठरवलं नाही. त्या मुलासमोर बघितलं, हसली ती आणि फाडायच्या ऐवजी ती चुकून दप्तरात राहिली. आणि आईनी आणि वडिलांनी जेव्हा तिला मारला तेव्हा शी वॉज रिबेलियस. इफ यू कॅन डू दिस टू मी, आय विल शो यू व्हॉट आय कॅन. अँड देन शी लॉक्ड हरसेल्फ. आणि देन आय सेड, व्हॉट डू यू फील रिअली अबाउट दॅट बॉय? सो शी सेड, काहीच नाही मला, म्हणजे आय हॅव नो फिलिंग्स फॉर दॅट. आय सेड ओके फाईन, आता तुला कसं वाटतंय? मला आता फार बरं वाटतंय, पण हे यांना सांगा, बाहेर बसलेले आहेत त्यांना, यु नो. अँड देन शी वॉज स्माइलिंग. देन आय आस्क्ड हर टू कॉल द पेरेंट्स अँड दे वर एस्टॉनिश्ड की कालपासून रडत असलेली, अबोला धरलेली मुलगी आज हसते लगेच. अँड देन आय लुक्ड ॲट द पेरेंट्स. द मदर वॉज व्हेरी प्रिटी. मुलगी आईवर गेली होती. वडील थोडेसे माझ्यासारखे होते, यु नो. म्हणजे स्मार्ट होते पण माझ्यासारखे होते. So I asked the mother की मॅडम तुम्हाला तुमच्या कॉलेजमध्ये शाळेमध्ये अशा काही प्रपोजल्स काही आले नाही का? आले म्हणे डॉक्टर. फादर वॉज लाईक माझ्या बायकोवर माझ्या समोर असा प्रश्न कसा काय विचारतोय. अँड देन आय आज द फादर की का हो तुम्हाला असं वाटलं नाही का किंवा अजूनही वाटत नाही का कोणी सुंदर बाई दिसली की काही तिला 2 शब्द जास्त बोलावे. नाही डॉक्टर ऍक्च्युली ना आमचं लव्ह मॅरेज आहे. आईला म्हटलं मी स्वतः केलं ते सगळं चाललं तुम्हाला त्या एजमध्ये आणि या मुलीला काही वाटत नाहीये. सो देअर द इम्पॉर्टन्स ऑफ फॅमिली कम्युनिकेशन कम इन टू पिक्चर. हाऊ टू कम्युनिकेट अदरवाइज द चिल्ड्रन. शी वॉज ऍक्च्युअली विलिंग टू लिव्ह द हाऊस अँड गो. सो काही महत्वाच्या टिप्स आहेत की व्हर्बल कम्युनिकेशन मी फक्त 1-2 प्रश्नच विचारले. कीप इट शॉर्ट अँड सिम्पल. ओके. आणि मुख्य म्हणजे तुमचा टोन आणि पिच हे अतिशय कंट्रोलमध्ये पाहिजे. वेदर इट्स युअर पेशंट, वेदर इट्स युअर स्पाउस, वेदर इट्स युअर चिल्ड्रन ऑर व्हॉट एव्हर. आणि नो सायंटिफिक जार्गन. आणि ॲज द चाइल्ड ग्रोज युअर व्हर्बल कम्युनिकेशन शुड गो डाऊन. मोठ्या मुलाच्या टीनेजरच्या फक्त खांद्यावर हात ठेवले, डोक्यातलं केस फिरवले, आय मीन केसांमधनं हात फिरवला, पाठीवर थोडीशी थाप मारली, एक सकाळी हक दिला, एक संध्याकाळी हक दिला, जस्ट टू नो की सकाळी जाताना तू घराबाहेर चाललायस, नीट राहा, शांत राहा. घरी आल्यानंतर दुसरा हक जो असतो आल्यानंतरचा तो टू टेस्ट ड्रग अब्यूज. जे बच्चू ड्रग अब्यूज करतात ते थोडेसे आई वडिलांपासून लांब पळायला बघतात. सो these 2 hugs are very important. Basically 80% of communication is non-verbal, which includes eye contact, your proximity, touch and silence. When she was crying I was keeping my mouth shut. बाहेर रडू नको नाही. Go on, vent out yourself. Okay. आणि तुमचे हँड्स आणि लेग्स असे पाहिजे की तुम्ही असे बॉस सारखे नको वाटायला. You should look like a friend of your type. प्राप्तेषु षोडशे वर्षे पुत्रम मित्र भवाचरित असं काहीतरी म्हणतात. So 10% conflicts are due to difference in opinion and 90% are due to wrong tone of voice. If we remember our conflicts with anyone, we remember the tone of voice and it bounces back as a PTSD. I think that's the end of it. Now, मॅडमचं आपल्याला 20 मिनिटाचं चालू करायचंय. I'll come back to the stage. किंवा आता कोणी नसेल तुमचा जो बसलं चालेल प्लीज.
Say that Dr. Bhave has explained to me and it's okay, and she'll hug him in my presence. So we called the son back in. After the maternal acceptance and hug, he broke down, cried in relief, and poured out all his feelings why he had changed over the last 6 months. And then the smiles on both their faces when they left my clinic was a reward itself. Then I did many more sessions with him to reduce his frequency of masturbation, got him to engage in other normal activities again, brought him out of his depression without any medications. And today, he's a very happy, healthy boy. And I also helped him to reduce his weight. So what is the take-home message? When we start doing exclusive adolescent practice, we find that adolescents can mask their true feelings. And after rapport development, we can understand the root problem of their various manifestations and discover the problem behind the presenting problem. Most of these signs, academic deterioration, change in behavior, aggression, withdrawal, change of friends, change in sleep, eating habits, weight gain, weight loss, can be pointers to a variety of conditions, flag signs for depression, substance abuse, romantic relationship, and other addictions. Guilt of masturbation is one such issue, and it can also present with a variety of symptoms. The queries which are fed in our practice by boys about night ejaculation and wet dreams, we need to explain to them this is normal and benign. Natural way to reduce stored semen, like a tank which has to overflow. There's no need to feel ashamed. And there are no relationship to reality because it is not necessary to have sexual fantasies or erotic dreams to have wet night ejaculation. And this we need to do in school and parenting programs. There are other queries, how do I prevent this? What precautions to take? Because when I go for trek or camping and I'm sharing rooms with other people, how do I stop this? They also want to know what is excess. And we have to tell them this is a spectrum. There's no hard and fast rule, there's a frequency. But if it distracts you from all activities, your academic performance deteriorates, you lose interest in extracurricular interest, and you get recurrent UTI or local injury or local inflammation, that can be called as excess. There are some boys also want to know, I don't feel like masturbating. Does every boy masturbate? Am I abnormal? If a boy says he finds masturbation painful, we need to look for tight phimosis or any local problem. We have other queries, like my male friend and I mutually masturbate. Is that homosexuality? If my girlfriend helps, does that come under category of safe sex? Is oral sex completely safe? Do girls do it? Do married men do it? Do married women do it? If my friends keep getting nocturnal ejaculation, I don't get it. Does that mean they are more macho than me? And girls are trained not only about menstrual hygiene, menstruation, also to clean the stained bed sheets or their underpants, and they're taught to put it in cold water because otherwise the body fluids, being proteinous, stick. And this is never told to the boys, and they're very afraid and very embarrassed what to do with the stained bed sheets. And we need to give them this information, and this is all available on the net. So thank you very much.
Fourth presentation. So first of all, I would like to thank the organizers, Kanikar sir and my teacher Bhave ma'am for this opportunity. So we are discussing about the various interesting cases. So this is one more case which is very common, academic deterioration. So 17-year-old boy was brought. He was going to appear for the 12th exam and followed by 1 month for the NEET exam. So he had conflicts with the parents related to studies. There was sudden academic deterioration and he was refusing to give exams. There was no physical symptoms and academically he was very good till then. Till 10th standard, he was in the toppers in his class. So we initially think about exam anxiety, depression, substance abuse. So what could be the causes for this? Here, both the parents were postgraduate doctors having their own hospital. So they were very keen. He was doing well till 10th standard.
So their expectation was he would join this profession and continue the tradition. Now both parents got extremely worried because of this. Father was stressed out and started to have repeated conflicts with this son. Mother was worried, but at least she was cooperating, giving support to the son. Both felt that they were betrayed, as at the last moment the son was refusing to appear. Till that time, he was even scoring good in the coaching classes. So what the problems are perceived by the parents and what their expectations are, we have to note them. But we are here, we have to tell the parent that we are not here to side with you, or we are not here to achieve your goals. We are here to help the adolescent prosper. So when we evaluated him, he did not have any clinical depression, any physical illness. He was the only child in the nuclear family who was close to his mother. With his father, because of the less time spent, he had a very formal relationship. What had happened is, due to COVID, he was very active till standard along with academics in sports. Suddenly his school was changed. He had online school, online colleges, where he did not have any friends, and there was no relationships with the teacher also. So many times adolescents are very reluctant to open to us. There was sudden disruption due to COVID. And even now we see few kids. For some, it is very easy to attend online classes. For most, it is very difficult to concentrate on a screen and get information, especially when there is no observation or somebody authority figure who is watching over them. So lots of coaxing we had to assure him the trust, because we were also doctors. He did not trust us. He thought that we were his parents' friend. Later on, he confided that he was not doing well in his online classes and he was lagging behind. Initial exams, he cheated and got good marks, but now he could not cheat in the exams as they were more formal. Even some offline exams were there, and he was realizing that he would not be able to score enough to get admission. So before we reach this point, it took us 2 or 3 sessions. So in one day we cannot. Gaining trust of the adolescent is the most important thing. We have to be non-judgmental, and we should not take parents or the child's side. We should be neutral. So we made him realize that he had to confide with his parents. He was initially hesitant, but with support, he decided, and he came out and he told everything to the parents. Now, parents were from low socioeconomic background initially, who had struggled to reach their current position. And they were crestfallen when they heard that son had cheated. A mother was also blaming. So blame game starts immediately. What mistakes we did during early parenting, and that conflict started to happen. So we counseled the parents. We had separate sessions with them, that even though the child had some shortcomings and mistakes, he has confided in him honestly. He did not want to continue this. So we have to support him. Blaming him or targeting him is not going to help you achieve. Parents' only expectation now was that he at least should give the NEET exam. They thought that at least he'll score some amount of marks. So parents usually want a quick fix. Any failure on the child, they take it as a reflection on their parenting, and they become defensive. Adolescent also watch that. Many parents say that we are supporting our kid, but adolescent is also watching the body language of their parents, and they just don't take them for face value. So the student was not keen to give the exams. He thought that he did not even want to continue in the medical field. He was not clear what career he wanted, and there were multiple common and individual sessions with him. So it was ultimately the student decided that he will give the exams, but my parents should not have any major expectations, as I am unlikely to score enough. And he would take time to decide what he wanted to do further. So many times we are over there like negotiators. We are helping parents and the adolescent to find a common ground, having clear expectation. And there are many communication problems which have arisen by years of wrong parenting. And now there is no immediate quick fix. So we become the communicators in between to assure both parents and the adolescent to have a common agenda. So parents agreed to the same. Then all of them decided to have a calm home environment. And for this, repeated backup was required. After exams, we had session with the child, what and career options were explored. Parents were told that no matter what he chooses, you are here to support him and not put pressure on him. And adolescent was told to explore other kind of information. Till then, he had not thought about it. So adolescent, especially late adolescent, they should always feel that they're in control of the decision making. Parental role is that of a guide or coach. Not fulfilling parental expectations should not be taken as a sign of problem. He may have his own aspirations, and this has to be inculcated with the parents. After few sessions, the child confessed that he was not against becoming doctor. He wanted to, but he was worried that he won't be able to meet his parental expectations lifelong, even if he had success in the field. So parents also, we had to counsel that you have to support without judgment. The child enrolled to offline classes as he could not cope up. Till then the waves had reduced. Over the year, we had to give him support for exam anxiety, stress related skills. He required guidance, and this child has given NEET this year and he got admission to first MBBS, and both of them are happy now. So each adolescent has a different temperament. Every adolescent does not react to criticism or negative opinion. Some require support. So we as a parent have to understand what my child requires and give that. Parents want the control the goals as well as how methods which the adolescent should achieve them. So that should not be done. Parents should tell their expectations, but they should help the child explore his own way. And solutions require time. This case we had handled over a few months. So this cannot be achieved in 1 or 2 sessions, because trust building, change in behavior over long periods is not achieved in 1 session. And we were fortunate that doctor parents were there and they were cooperative in this process. Otherwise, it becomes very difficult. 1 or 2 sessions, they do not get the result, they move on. So the take-home messages from this case would be that adolescent health experts are not only there to deal with obvious physical or mental issues. Many times there are no obvious issues itself. Conflict resolution, tempering parental expectations, and even simple support will help to bring the children back on track. COVID and online school experience will have residual problems for many kids for years to come. These are just overcoming. There are behavioral issues, pseudo-autism, many things which we have to face. So we have to be careful. Just because COVID has ended, the problems have not. And we as adolescent expert have to work on the life skills of these children, or what are now known as transferable skills, because these are the skills which will be used lifelong. We do not know with the change in the world what career options would be good 5 years, 10 years, or 20 years down the line. There may not be any doctors, all clinicians may be online, but there are certain skills which are required lifelong, no matter what stage of life. And we as doctors should try to inculcate towards parents, involve the children in those skills, like life skills. Thank you very much.
लवकर करा, वेळ चालली. ओके, लास्ट केस थोडीशी सिरियस केस आहे. दिस वॉज अ गर्ल, 11 वर्षाची, ब्रॉट बाय रिसेंट हिस्ट्री ऑफ बेड वेटिंग आणि बिझार बिहेवियर. ओके, आणि सिन्स फ्यू वीक्स शी हॅड ऑल दिस सिम्पटम्स. द टीचर ऑल्सो कंप्लेंट. टीचर जेव्हा कंप्लेंट करते स्टुडंटची, तेव्हा इट शुड बी टेकन सिरियसली बाय पेरेंट्स एज वेल एज डॉक्टर्स. ओके, she had chemical dermatitis on palms and redness in the perineal area. So the diagnosis was pakka. What? Anyone? Patapat bola, madha veil kami. Any suspicious thing? She was referred to me by a gynecologist. Sorry? Absolutely correct. So basically, organic causes आपल्याला पहिल्यांदा रूल आउट करायला लागतात. ओके, UTI चे, आणि दुसरं सायकोसोशल मध्ये ऑब्सेसिव्ह कंपल्सिव्हचे. ओके, सो हे याच्यामध्ये बेसिक हर्डल्स जे असतात 11 वर्षाच्या मुलीकडनं टू ऑब्टेन द हिस्ट्री आणि वेंटिंग आउट ऑफ हर इमोशनल व्हॉट एव्हर फिलिंग्स ऑर व्हॉट एव्हर. तर याच्यामध्ये आपण नवीन असतो अशा मुलांसाठी. शी वॉज रेफर्ड टू मी बाय अ गायनेकॉलॉजिस्ट, सो शी वॉज नॉट सो व्हेरी फ्रेंडली, आणि आय हॅड नो टाइम टू गिव्ह हर टाइम टू ओपन अप, एस्टॅब्लिश रॅपो, आणि सो कॉल्ड सरांनी जे सांगितलं ते, इट वॉज अ व्हेरी व्हेरी डेलिकेट अँड इमर्जंट केस इन माय क्लिनिक. सो विदिन व्हॉट एव्हर टाइम आय हॅड, I again used those communication skills which made the child think, yes, this fellow can understand me, I can tell him what is the problem. Although she had told this problem to the mother, mother said, जाऊ दे, लक्ष नको देऊ, दुर्लक्ष कर. And this girl had typically a post-traumatic stress disorder, where she was again thrown into this obsessive compulsive. She was washing the areas again and again, causing chemical dermatitis. आणि पेनफुल मेमरीज होत्या तिला. ऑफकोर्स शी वॉज व्हेरी मच डिप्रेस्ड बोलताना. आता ही गोष्ट पेरेंट्सना सांगणं वॉज अनदर चॅलेंज फॉर मी, बिकॉज पेरेंट्सचेच एक म्हणजे काका का कोणीतरी होते घरी येऊन राहिलेले 15-20 दिवस. He had molested this particular child. So ही गोष्ट सांगायची कशी? So you need to give separate time for maybe 5-10 minutes, 15 minutes to the parents also. आणि याच्यामध्ये डिफेमेशनची भीती असते फॅमिलीच्या आणि फॅमिली एन्व्हायरमेंट. समजा आईच्या माहेरचं कोणी असेल तर सासूरवाडीचे लोक आरडाओरडा करू शकतात. वडिलांच्या आई म्हणजे बाबां काकांपैकी कोणी असेल तर आईकडचे लोक आरडाओरडा करू शकतात. सो हा फार डेलिकेट कॉम्प्लेक्स इश्यू असतो. आणि तिसरं महत्वाचं म्हणजे बिईंग 11 year old, पॉक्सोचा एक महत्वाचा इश्यू येतो. वी नीड टू रिपोर्ट. हा खूप मोठा विषय आहे. पॉक्सो आणि सेक्शुअल अब्यूज वरती वी कॅन हॅव 1 week's कॉन्फरन्स. इट विल बी नॉट सफिशियंट टू कव्हर दॅट टॉपिक. आता याच्यामध्ये ओपनिंग अप साठी व्हॉट टूल्स वी कॅन यूज इज अगेन प्रायव्हसी, कॉन्फिडेन्शियलिटी, basic counseling skills. I urge to all the pediatrician in all the conferences that I attend ki basic counseling skills, communication skills, heads assessment हे प्रत्येकाने शिकायलाच पाहिजे. Because 50% of adult mental health disorders have their origin before 14 years of age. आणि 14 वर्षाच्या मुलाला सायकियाट्रिस्ट कडे नाही जाऊ शकत. पेरेंट्स पण नेणार नाहीत. They come to us. आणि we are the primary mental health professionals for this particular 22% of the population in India. So आपण ते पिकअप केले तर we can actually sort out so many mental health, adult mental health disorders early. So storytelling असते, pictorial charts, video clips we have, drawing diagrams, some toys, पुतळे, खेळणी, त्याच्यातनं आपण शिकवू शकतो मुलांना to help them open up. आणि बरेचदा आपल्याला खूप टूल्स वापरायला लागतात टू सी दॅट द चाइल्ड इज स्टिकिंग टू द स्टोरी विच वॉज टोल्ड बाय द चाइल्ड. इट कुड बी अटेन्शन सिकिंग बिहेवियर ॲज वेल. आता हे इंडिकेटर्स आहेत. आय वोंट गो इन टू द डिटेल्स, मला 2च मिनिटं कारण. पण लॉस ऑफ इंटरेस्ट इन फन फील्ड ऍक्टिव्हिटीज, अकॅडमिक वर्सनिंग आणि स्वतः अब्यूज झालेले लोक इतरांना बुली करतात किंवा अब्यूज करतात. These are the most important things apart from substance abuse, disturbed and restless sleep and discomfort in the presence of certain adults and objects. So this girl wanted that person to actually go away from the house and she had told this to the mother. पण जाऊ दे, आपले किती साले तरी संबंध टिकवायचे असतात वगैरे टिपिकल फालतूपणा जो चालतो घराघरामध्ये, त्याच्यामध्ये ती मुलगी अडकली होती. आणि समटाइम्स और मेनी टाइम्स आय वुड से चाइल्डहुड सेक्शुअल अब्यूज कुड बी टोटली कन्सील्ड only to reveal later on in adult life as unexplained headaches. Now in the management it's again a very very delicate आणि म्हणजे पॉक्सोमुळे तर आता खूप जास्त स्ट्रिक्ट आणि डेलिकेट झालेला आहे इशू. I later on learned that the gynecologist had also suspected this, but she wanted की पाहुण्याच्या हातून साप मारावा म्हणून माझ्याकडे रेफर केलं होतं. सो डिटेल्ड रेकॉर्ड कीपिंग आणि इन्फॉर्म्ड कन्सेंट हा आपल्यासाठी फॉर आवर ओन सेफ्टी is very much essential that you have reported the case to the parents and the parents have refused to report the case to the POXO committee किंवा police. हे आपल्याकडे रेकॉर्ड मध्ये पाहिजे. मेडिकल ट्रीटमेंट डेफिनेटली वी ऑल कॅन डू. सायकोसोशियल सपोर्ट टू द चाइल्ड अँड पेरेंट्स ॲज वेल. आणि पेरेंट्सनी सेक्शुअलिटी एज्युकेशन द्यायचं आहे. जसं सर म्हणाले, मॅडमच्या लेक्चर मध्ये होतं की मुली निदान आईकडे मेन्स्ट्रुअल हायजीन किंवा बाकी गोष्टीसाठी जातात किंवा ही मुलगी गेली, पण अनेक आयांसारखं या तिच्या आईने पण सांगितलं जाऊ दे, लक्ष नको देऊ. मुलं काय करणार? And 2 studies in Mumbai NGOs have proved that sexual abuse is equally bad in boys as well. So असं नाही की फक्त मुलींनाच त्रास होतो. मुलं नाही सांगू शकत. मुलांना बेसिकली कळतच नाही. परमेश्वरांना आम्हाला ती अक्कलच दिलेली नाही इनअप्रोप्रिएट टच ओळखायची. मुलींना ती नॅचरल इनेट काहीतरी कळतं तरी की आपल्याला कोणीतरी इनअप्रोप्रिएटली टच करायचा प्रयत्न करतंय. अँड मेनी टाइम्स यू नीड अ काउन्सिलर्स हेल्प. सो दॅट्स इट. थँक्यू व्हेरी मच. तुमचे काही प्रश्न असतील तर मॅडमच्या परवानगीने आपण विचारू शकता. टाइम अप. जाऊ.
Sir, I call upon stage Dr. Subhash Kashyape sir.
Yes sir, please.
To
मला आवडेल
come
सलाम
and
द्यायला.
felicitate Dr. Atul Kanikar and Sandeep Kavde sir.
Thanks for omitting the tea, madam.
Sorry, sir.
Yeah, sir.
Now we have two short 15-minute lectures for which I welcome as chairpersons Dr. Hemant Joshi sir and Dr. Abhay Patil sir. For the first one, I invite our speaker, Dr. Shetan Shah, to the podium. The word headache itself is a huge headache for the one who perceives it and for the one who has to manage it. In childhood, there are morbid headaches like meningitis and intracranial tumors, and sometimes simply due to refractory errors. But jump to adolescence and a new category of headache comes up. Could this be migraine? A lot of us are under this misplaced apprehension that migraine can never happen to children. To dispel this myth and elaborate further, I invite Dr. Chetan Shah.
Thank you, organizers, for inviting me here and allotting me this very interesting and nowadays more frequently appearing in our OPD practice, headaches. Of course, all of you must have got little headache by now. Since morning, you have been listening to a lot of lectures. But I'll try to be a very short and brief and very practical in our approach because I'm a general pediatrician, not a neurologist. So I'll just tell few important points regarding diagnosis and management of headache. So migraine, of course, is a headache to manage because many times, as was told in the introduction, we don't see migraine or we don't expect migraine in this age group, our pediatric age group. So we don't think, and once in a while, if at all we tell to our parents that this can be a migraine, they are not likely to believe it. So it's difficult. So by definition, there are episodes. Some important points in definition, I think, are to be marked here. There are episodic attacks of headaches of moderate to severe intensity. So headache, episodic, moderate to severe intensity, focal in location, throbbing in quality, and associated with nausea, vomiting, light or sound sensitive. So these are 5 important parts that can help us in thinking about migraine. It may or may not be associated with an aura. Aura could be a visual, sensory or diphasic, or atypical aura in form of hemiplegia, or Alice in Wonderland type, means patient observe different shape, altered shape, distorted shapes in front of the eyes. So this is by definition. And it's very common, up to 75% of children below 15 years have already experienced headaches. Up to 10.6% children between 15 years have migraine-like headaches. 25 to 28% of adolescents have experienced migraine-like headaches. There is a strong family history. This is a very important point that again will help you in the diagnosis. I have told you previous 5 important points. Now, in addition to that, if there is a strong family history of up to 90% patients have their first or second degree relatives, they have migraine or migraine related complaints. What are the migraine related complaints? Either they have cyclical vomiting or they have menstrual headaches or motion sickness. So this is a group. So just headaches grossly, we divide into 3 types of headaches. It could be primary, secondary facial pain. 3 types of primary headaches. It could be a migraine, tension type headache, or trigeminal neuralgias. 3 modes of treatment. You treat acute attacks, you give them preventive treatment and behavioral therapy. 3 acute management drugs, NSAIDs, antiemetic and triptans. And 3 chronic management drugs, that is for prevention that you use is propranolol, flunarizine and topiramate. So this is how a group of 3 will simplify. We'll go with the cases. First case, 7-year-old boy having complaint of headache once in 15 days since last 1 year. Headaches were more during daytime, severe in intensity, almost 7 to 8 on scale of 10. They are located over forehead, associated with increased sensitivity to sound, light, and sometimes with vomiting. So just note all the points. Headache lasts for 2-3 hours and relieved after sleep. Sometimes it requires analgesics. Headache is not associated with night awakening. The past history of unexplained abdominal pain between 4 to 6 years of age. And family history suggests that mother is having similar pattern of headache and child has normal neurological, general and systemic examination. So this is a presenting complaint. Now what will you think? Some important question we'll ask is how often, how long, and since when? So we have very clear criteria here. It's since few months, it's long is 2 to 3 hours, and since when it's a last 8 months it has started, and it's coming often means it's coming almost daily or maybe twice, thrice in a week. How severe? It is moderate to severe. What are the accompanying symptoms? Child has feeling of nausea, vomiting, and other complaints. So this we start thinking of migraine here. So here we'll think most probable type migraine, but at the same time, such a patient, you will always like to rule out that what means we are not missing something which is sinister. If whether child is developing some intracranial tumor, intracranial space occupying lesion, or maybe benign hypertension. So you have to see certain important points. Persistent headache in child younger than 5 years is important. This is a red flag. Headache persistently awakening child from sleep. Recent change in pattern of the headache. Headache with persistent vomiting on awakening. No response to conventional treatment, and new persistent headache that has come up. There are some important points with SOL. An intracranial SOL patient will have headache just getting above from the sleep. And then what happens is once he attains the upright posture or starts moving around, the headache disappears. Whereas in the other way around, the headache increases with activity in migraine. So this is how you can differentiate. So some red flag again here, you note that child doesn't have any focal neurological deficit. So you just rule out symptoms of raised ICP. Occipital prominence of headache is important. Positive pronator drift, optic disc edema, new onset squint, hypertension, behavioral changes, or some endocrine changes. So these are some of the red flag signs where you will pay more attention and try to find out some other cause, secondary cause for headache rather than primary. Now, the moment patient comes, many times comes with the MRI and other things. So whether you need MRI in all the patients of headache. So there are some areas where you will definitely go for MRI. That is, if the history is suggestive of recent onset of severe headache, change in the type of headache, neurological dysfunction, or focal neurological symptoms. So these are 4 or 5 of the important things where you will say MRI could be ordered and you can get the MRI. So migraine, what are the important criteria? At least 5 attacks, headache lasting for 1 to 72 hours, and following 2 of the 4 characteristics: bifrontal or bitemporal in nature, pulsating quality, moderate to severe pain, and aggravation by routine physical activity. During headache, at least 1 of the following: nausea or vomiting, or 2 of the 5 symptoms of photophobia, phonophobia, difficulty in thinking, lightheadedness, and vertigo. Headaches are just, you have to rule out any other cause. So headaches not attributable to another disorder is an important point that can go to diagnosis of migraine. Now, management wise, as I've told you, divided into acute management, chronic management, as well as the management of behavioral changes. Now, most important analgesics that we use, either paracetamol, ibuprofen, or naproxen. Something we use for vomiting, here vomiting, MSET, which we use ondansetron, is second choice. First choice here is metoclopramide, because metoclopramide has a lot of CNS effect. It has an antidopaminergic effect. So it's more effective in the vomitings that is caused by migraine. Other drugs that are used is triptans. They are in the older children. There are sumatriptan, that is Sibelium, which is very commonly used. Other drugs are the zolmitriptan and rizatriptan, but these are used in the older children, and these are selectively used and only indicated. Some nasal preparation are also used in treatment of migraine. Now, preventive treatment is given to those patients who are having chronic debilitating migraine. Their routine is disturbed and their school absenteeism. I use many times preventive treatment whenever child is having board exams. These are some of the areas where you can use preventive treatment. So apart from lifetime modification, all of you know it is precipitated by stress. So you need proper rest, proper sleep, daily routine, less screen exposure, and dietary restriction in the form of avoiding fermented food items, those C items, coffee, chocolate coffee, and then cheese, Chinese food. These are some of the aggravators, so avoid it. Pharmacological treatment in prevention is, few of the commonly used drug are flunarizine that we use. Sorry, this is Sibelium. Propranolol is used. Amitriptyline, that is Triptomar, topiramate, and valproic acid. These are the two anticonvulsants that are very effective in treatment of prevention of migraine. Now, how do you choose a particular drug? Flunarizine is usually the first choice in almost all the patients. If patient is obese, then topiramate is a good option. If patient is having associated psychological problems, then amitriptyline is a better choice. If there is doubt about associated seizures, in that case, you can use sodium valproate, or topiramate is a good choice. If child is very young, then cyproheptadine can be tried. And if patient is asthmatic, you have to avoid propranolol. So these are some of the things that you keep in mind before going on to preventive treatment. Usual duration of the preventive treatment is around 6 to 12 months. So this case is a primary headache. Child had a migraine, and here just migraine was non-debilitating. So we have just gone for non-pharmacological treatment. Now this is a second case, 12 years old female. She has complained of episodic symptoms, experienced headache, but here note down the other features. Headache was bearable, but had visual symptoms in form of blurring and occasions of falling of curtain-like pattern in front of both eyes. And headache subsides after 45 to 60 minutes by itself. Frequency was initially 3 to 4 per month. Now it is for more frequent 3 to 4 times in a month. Previously it was once in 3 to 4 months. Now it has become 3 to 4 episodes in month. Eye examination was normal. There was other normal examination was normal. So now there is a differential diagnosis. Either it's occipital lobe epilepsy, or you have a headache with visual aura, migraine with visual aura. So some differences. The epileptic form headache, that is occipital epilepsy, the attacks will be only seconds to 3 minutes, and moving to the opposite hemifield. There will be eye deviation. Important thing is loss of consciousness here, and blindness is common and almost occurring daily. Whereas if you see the headache with occipital aura, the distribution is center to periphery, almost never daily, and blindness is rare. So seizures are rare, and vomiting is common here. So these are a few of the important differentiating points between a headache with visual aura, that is migraine with severe visual aura, and second was the occipital lobe epilepsy. So this is how you can differentiate between two. So this case was headache, was primary migraine, but this patient, because it was disturbing her routine activity, she required the pharmacological treatment also. So last case, a 12 years old male having headache lasting for the whole day. Headache was mild in intensity, not affecting routine activity, relieved by sleep. Episode once in every 2 to 3 days since last 8 months. Child did not have any associated complaints such as vomiting, photophobia, and phonophobia. Now, what is your take on this? This is a common, what is the second type of headache after migraine, primary headache, that is tension headaches. So this is a child was taken and even MRI, everything was done, normal general and physical examination. So this is most probably has tension type of headache. And what are the criteria for diagnosing tension type of headache? At least 10 episodes in a month, lasting 30 minutes to 7 days. Headache has at least two of the following characteristics. It is usually bilateral in location as compared to migraine, which is very occasionally bilateral in location. It is and it is pressing and non-pulsatile. If you remember, migraine is throbbing headache. This is non-pulsatile. This is mild to moderate, whereas migraine is severe and not aggravated by routine physical activity. Migraine is aggravated. So these are the very important point that can differentiate between a tension headache and migraine. And headache has both of the following: no nausea or vomiting, and no more than one of the photophobia or phonophobia. So headache is not attributable to any other disorder. So this case falls into primary headache, tension type of headache, and here also again you have non-pharmacological treatment in the form of general modification, lifestyle modification, avoidance of screen, proper rest, and other measures to control this. So to summarize, headaches are broadly classified as primary or secondary. 90% of all the headaches are primary headaches. Most common type of primary headache is migraine. Primary headaches may cause significant daily pain and disability, and they are not dangerous. Certain red flags and warning signs you have to keep in mind, and because they can indicate a secondary headache, which can be dangerous and life-threatening also. Treatment requires 3-level approach: medication in the management of acute episode, which we have already discussed, analgesic, antiemetics, often requiring a primary and secondary medication, prophylactic treatment for frequent or disabling headache, and behavioral management for lifelong effectiveness. Thank you so much for patient hearing. Thank you, all of you.
Thank you so much, sir. I request Dr. Hemant Joshi, sir, to felicitate Dr. Chetan Shah, sir.
Headaches in our OPDs. Next, I call upon stage Dr. Sandeep Vasankar, who is a respiratory medicine, asthma, allergy, infectious diseases, and vaccinology specialist, for the next talk, which is chronic cough. Cough has always been a nagging subject, whether it's in OPD or during hospital rounds, and it becomes all the more difficult and worrisome when the coughing complaint goes on and on and on. Children in different age groups have different etiologies for cough. Leave alone the causes, there is so much more to cough up when it comes to writing a treatment plan for such children. While we struggle with the diagnosis, we fall prey to so many medicines and all possible over-the-counter drugs that are available in today's scenario. So let's hear from the speaker himself on this very topic. So,
Madam, phone. So, first of all, I will like to welcome you all, seniors, colleagues, for this talk in MAHAPEDICON. And I would also like to thank the MAHAPEDICON committee and hardworking NASIC IIP committee who work hard for this event. I would like to talk on chronic cough. Basically, what is the need of talking on this cough? So, is it moving? So the need of talking on this cough is chronicity. What is the need? What is the cause of chronicity? So what we came across common scenario and practice it, we try to suppress the cough. So that is not the answer. So with lot of cocktail soft mixtures, antihistaminic steroids, so that is giving a wrong message to the patients and doctors and medical, and they reuse it from the medical pharmacy. So the other thing is, it's easy to suppress the cough, but it's difficult to detect the underlying cause and pathology. So we'll be focusing more on the detection of pathology and the cause and its management. So can I start with the basically with the case scenario? So basically it's good to start with the cases because that will give us a more practical learning as compared to theory. So we move on to the case number 1. So it's a 6-year-old boy. He's been coughing from last 5 weeks, and his cough has a typical pattern. When he lies down, his cough increases. And when he wakes up in the morning, also his cough increases. So he also has a very bad continuous rhinorrhea with frequent sneezing episodes. And his nose is itchy, and he's got a constant throat clearing off and on over the past 5 weeks. So now he's also has got itchy eyes. So this type of clinical scenario is hinting towards something. It's already this history is actually giving you a clue what you are dealing with. But we need to move forward. He also has got a noisy breathing when he's asleep. He's got a hyponasal voice and behavioral issues. He has had one admission for his complaints already for almost 7 days for chronic cough. And he received many cocktail cough mixtures and steroids. He also have received 2 antibiotic courses, but the issue is he's not improving. It's a non-responder pathology. So that's why it was referred to me as labeled as LRTI and rhinitis. So what do we do about it? What we as a pediatrician team or respirologist, what we going to approach? So first of all, we need to have certain questions crossing our mind. What is the major organ involved? Are there any other system organs involved associated? What are the underlying pathology giving us a clue on clinical examination on history? What are the possible causes and what are the possible diagnoses possible in this situation? And what are the specialists am I going to refer to or what other specialties to help to get the cause and the diagnosis? So this should be a thought process for the approach, not rather than sitting on this chronic. Already his patient is suffering from more than 5 weeks. And he has spent a lot of money on medicines and admissions and all. Still, we don't have a diagnosis. And the parents are not at all happy. So let's move. So we went ahead after thorough clinical examination and history. And after following the guidelines, the pulmonary function test was within normal limits. There was no reversibility. And coincidentally, we came across that he was positive house dust mite. 2 mites, in fact, not the one, and was strongly positive. So that is hinting towards the allergic disorder, nose, throat, and the eyes. So what next? What is the extent of the pathology? What are the associated complications? So I went ahead with a nasoendoscopy, which showed a classical enlargement of the inferior turbinate. Can you see that? So, and this has got a pale mucosa, but it's not coming, it's coming red on this slide, but it's actually a pale on examination. And there is a swab stick, which is, this is easily compressible edema and swelling. So it is a classical sign of allergic rhinitis. Then we went ahead for nasopharyngoscopy because we wanted to see what is happening to the adenoids and nasopharynx. So we came across this interesting finding of enlarged mass-like appearance of adenoids. They were boggy and pale mucosa. That was also going in favor of the allergic rhinitis nasopharyngitis and adenoidal hypertrophy signs. There's too much of hypertrophy was there. And then we put all the bits and pieces together. So what is the diagnosis? So diagnosis of chronic cough is a 6-year-old boy. He has upper airway cough syndrome. And you take a note from me. This is my serious suggestion. This is one of the commonest cause of common cough in our daily pediatric practice. There might be episodes of more frequency of cough or intensity of cough. Intensity might go down because we prescribe the what? Cocktail cough syrups. So that gives us a wrong impression the patient is responding. So that some chronicity features are suppressed. So we be mindful before prescribing, rather get the detection of cause and diagnosis. So this is, and with this is the, in short form is UACS, and associated with persistent allergic rhinitis with conjunctivitis. He has conjunctivitis also, and adenoid hyperplasia, and it is because of the house dust mite sensitivity. So initially, he responded to pharmacotherapy, and in the next step, we'll go for immunotherapy if it doesn't respond. But he responded in 4 weeks' time, gradually. Initial response judged in 2 weeks' time. Next, move on to the case number 2. Let's talk about the upper airway cough syndrome, because it's a common thing. We need to learn about upper airway cough syndrome. The child starts coughing as soon as he lies down. That's a classical thing. Little bit different to GORD. Otherwise, also GORD, isolated GORD is not common in pediatric practice. It has to be associated with some underlying disease or complication, tube fistula, motility disorders, and syndromal kits. So it's not isolated. So when he wakes up in the morning and changes body position, keep on coughing and coughing and coughing. And it's worrying the parents. When he lies down, he can't have a sleep and we can't have a sleep. So it is impacting on the family as well. So what are the nasal findings? Nasal findings are rhinorrhea, mucopurulent discharges, nasal obstruction, sneezing, and itchy nose. Nasal findings are very classical, and we have already seen in the nasoendoscopy and laryngoscopy. Throat findings are very classical. You can absolutely observe when the child is sitting next to you in the cabin. So throat clearing and dry throat and sort of a foreign body type of clicky sensation. And on examination, there is a cobblestone appearance of the posterior pharyngeal wall with mucopurulent discharges or exudates on the pharynx. And of course, adrenal hypertrophy is also there. And sinusitis associated morbidity problem is actually seen in a little bit older children. This was a young child. When all sinuses are developed, they affect the sinus. But it's a part of UACS. So what is the mechanism of cough in upper airway cough syndrome? So a lot of studies were going on. So it is because there is a concomitant inflammation of the upper airway, and the inflammation is actually going down tracheobronchial tree also. And also now you might have heard about it, the recent concept of the cough reflex. Nasobronchial cough reflex and the bronchionasal cough reflex can cause the cough. So the pathology might be somewhere else, but the reflexes are stimulated, your receptors are stimulated, your C fibers, cough fibers, afferent fibers goes to the medulla, they are stimulated, and you get a cough. So there is a message here that you don't, when in the respiratory system, you need to thoroughly examine all the parts of respiratory system, right from nose to nasopharynx to the lungs. Don't focus on one system. आप चोर ढूंढने को यहाँ जा रहे हो, पर वो और कहीं पकड़ में आएगा. So this is a message. Move on to the next case, case 2 scenario. This is another interesting case and pretty common case, but undiagnosed. It's a 5-year-old, 3-month-old baby, the boy. He has had daily wet cough, productive cough. What is the difference between wet and productive cough? Can anybody tell? This is not a quiz, but I'm going to give the award to that person. What is the difference between wet cough and productive cough? We use daily. We use these words daily in practice. Very practical. And that gives a wrong message to the child, and family gives wrong message to us. So the wet cough, the word, it's a simple word, is used in the younger children who can't spit out. They swallow it. And the productive cough is the word used in the children who have a wet cough and they spit out, they expectorate. So he's been going through that. The other thing is his breathlessness has been increased over the past 2 weeks. He was breathless initially also, but he never ever had fevers. And he never ever had a history of asthma, wheeze, or atopy, allergic rhinitis. And he has had ERA episodes, 2 episodes in first 2 years of life. So that's his past history related to respiratory system, allergy, infectious diseases. So you cover everything in one line. So common things are common in practice. Next, no, he's not responded at all to bronchodilators and all your lovely cocktail cough. You love them. We love the cocktail cough mixtures. We love all sort of cocktails in India. So, and then he also received IV Ceftriaxone for 5 days. There was no response. They actually shifted him on piperacillin. Again, there was no response. And he also additionally got azithromycin. So there was a pretty much of a cocktail in antibiotics also. So we are not following antibiotic rational policy. We are not following steroid cough rational policy. So that is one aspect. The thing is that because of this non-responder situation with asthma, LRT, as referred to me. So again, you need to generate your thought process. You need to ask the questions, what is going on? So what are the major organ system involved? What is the underlying pathology? What are the possible causes and differential diagnosis? And does it need a proper evaluation? Does it need a referral to the specialist, respiratory or other specialist? So we went, when the patient came to us, we came across very interesting finding. And I was not surprised though, because I have seen this type of patient, but they are not identified. So the key investigation here is a bronchoscopy. Did you see the X-ray? I skipped the X-ray. You might have noticed that I skipped the X-ray. But anything is there in the X-ray? Okay, we'll come back to that later on. So the key investigation is copious mucopurulent secretions and edematous bronchial walls. This, while suctioning the ball, bronchoalveolar lavage fluid, I came across a lot of copious purulent secretions, but classically, you can see here. Can you see here? The bronchial walls are collapsing in the lumen. This is one of the classical signs. And here you can see the mucopurulent secretions and some exudates. So here it is not collapse, here it is collapse. So this is the classical sign of one particular entity on bronchoscopy. So what did we do with the ball? Why want to do ball? Because that is diagnostic. So significant neutrophilic infiltration, neutrophilic reactivity, these are the significant counts and significant bacterial counts. And this strep pneumonia was grown. Strep pneumonia was grown and we gave the sensitive antibiotic. Child responded in 10 days of time. So what is the final diagnosis? 5-year-old, 3-month-old boy with chronic wet cough with protracted bacterial bronchitis. So this is another common entity, protracted bacterial bronchitis. So what happens to this? PB is persistent or protracted. The issue with this issue with PBB is unidentified. Unidentified and misdiagnosed as asthma, LRTI pneumonia. That is a dangerous thing about the PBB. So diagnostic criteria, wet productive cough, more than 4 weeks, absence of other differential diagnosis, other differential causes which are close to PBB. So absence of the bronchoscopy, shows mucopurulent secretions, edematous, as we already discussed. So I move on. What are the classical signs of bronchoscopy and ball cultures? There are classical 3 common organisms grown in ball fluid. So these are the commoner ones, which causes other respiratory infections. So if you don't treat this, what happens next? And here the area of immunization also comes into picture. We can prevent PBB by covering with this immunization. So what is next? So with the response, the usual response results in 2 weeks time, but the complete treatment is 2 to 4 weeks. So 2 to 4 weeks for complete antibiotic therapy. This is a rational antibiotic therapy protocol. तो यहाँ पे अपने को antibiotic देना है, वो भी specific sensitive देना है. बाकी जगह भी waste time and money on antibiotics and cough cocktail mixtures. So, but यहाँ पे भी problem आता है. We give, because we don't know the underlying cause diagnosed by the respiratory infection specialist. We give for 1 week, we give for 7 days, and the patient leave the patient comes back, rebound with protracted bacterial. This is the common scenario I came across. So that is a take-home message. So if you come across PBB, treat completely PBB with 2 to 4 weeks of antibiotics. अभी यहाँ पे antibiotics का use है तो खुश रहो, use करो पूरा. Don't keep the patient partially treated. Why? If you don't diagnose it and keep it partially treated, what happens? It will develop to chronic superiority lung diseases, bronchiectasis, which is irreversible. So this is the very dangerous thing you want to prevent. So we had to be mindful about this. So chronic superiority lung. All features were present in I presented cases. Move on to next case. What we learned. Thorough clinical history, examination, vaccination history. This child was partially immunized. And medication history. Always focus on red flag signs, guidelines, algorithms, chronic pointers. And they are updated time to time. So red flag signs are very important. Guidelines, algorithms, chronic cough pointers, we need to follow, refer to it when you get such type of chronic cough cases with respiratory symptoms and signs. Consult respiratory specialists, ENT, other required specialists, early phase, not in the late phase, because irreversible pathology. And do not assume and treat every case as asthma, pneumonia, TB, and viral infection. Think beyond that in a chronic cases, chronic cough. Do not use our lovely cocktail cough mixtures, steroids, antibiotics without diagnosis and detection. Next, this is just a short and sweet definition. Chronic cough is defined as cough lasting more than 4 weeks in children younger than 14 years. And there are many other acute, relentless cough and other definitions are there. But what I would like to point out very important thing, in the checklist, the type of cough, the pattern of cough, you make a checklist for yourself in the clinic, IPD, OPD, or you can take a photo from there. That you have to go through it when the patient comes in the OPD and IPD. What is the checklist for history? Because you will get the clue almost 60 to 80% on history and thorough examination. So this is the graph, which will come back later on. So there is a proper classification with regards to the causality of chronic cough or prolonged acute cough in different age group, infants, preschool, school age group. You can see the USCS is standing upper airway cough syndrome in the top. It was not there. It was never used to be identified initially, and that's why not published in previous studies. So upper airway cough syndrome, respiratory allergies, again, preschool and school age group, then viral, then pertussis. Pertussis mycoplasma is still cropping up in certain pockets in India. Immunization is one thing, and there is still information available that you should keep in a differential diagnosis. Very important, you keep this chart in your clinic or in your whatever device you have. Cough pointers, it will guide you to take you to the closer differential diagnosis in chronic cough. So these are the examination points based on history, positive history findings, compare with the positive examination findings, pointers or indicators. Very important. Now, there is also a flow chart available. You can take it from me. This is a simplified overview assessment. What does it say? At certain point, how do you go from A to B and then C to D, and where to refer to the specialist in such a chronic cough situation to avoid irreversible lung damage. Now, red flag signs, chronic recurrent wet or productive cough. Systemic symptoms, fever, weight loss, failure to thrive, clubbing and cyanosis. Clinical examination finding, sudden onset cough with choking, shortness of breath, preceding chronic cough. Why did I mention about this? Sudden onset cough with choking, with shortness of breath preceding cough. Why I am pointing? But this is a chronic cough. It is sudden onset, but we are discussing chronic cough. उसका foreign body आपने छोड़ दिया 4-5 हफ्ते के लिए. The question is, never ever ignore foreign body. So here we'll be going into the sector of the retained, partially retained foreign body or retained or impacted foreign body causing chronic lung changes, non-resolving pneumonia, consolidation, and empyema, and superior lung diseases, lung abscess. So we are going in that track. Why? Because we have not taken the history. The first colleague has not taken the history. Abhi, I have one foreign body which I'm going to show you. There was a plastic whistle, and this whistle part mother has removed from the oropharynx, and the other part she inhaled down, and that retained for many months. And patient was having recurrent cough, infection, 2 admission, multiple presentations of pediatrician. क्यों? Because mother बोल रही हमको वो निकाल दिया है. So you have to think like a detective if you want to become good physician and policeman, apart from physician qualities. So this is one thing. So it is still possible, foreign body, stridor, upper respiratory tract, obstructions, noises, significant dyspnea, and during exercise, recurrent pneumonia, you ought to be very much watchful. Recurrent infection, उनको सिर्फ नाम देने से कोई मतलब नहीं है. Recurrent pneumonia, recurrent infection, no. Find the underlying cause. जो recurrent हो रहा है, वो अच्छा नहीं है. So you have to detect the cause and pathology. Feeling, whatever it may be, immunodeficiency, allergic, whatever. Feeling and swallowing problem, choking and vomiting, recurrent aspiration. Neurodisabled children, syndromic children, prematures, recurrent, persistent hemoptysis, and persistent abnormal radiological finding should not be ignored. Scratch the brain of the radiologist and respirologist. ये मुझे abnormal लग रहा है. Impact is huge. The key messages, we'll come to key messages because they are getting jittery regarding the time. So key messages are, if somebody wants, we'll come back to that foreign body, other slides also. Cough is a symptom of, is that okay? 1 or 10 seconds. Okay. So cough is a symptom of underlying disease. Cough is not a disease by itself. ये आपको पेरेंट्स को बताना है हमेशा. खुद को तो बताना ही है, पेरेंट्स को बताना है. And you tell them that this cough cocktail mixture is going to suppress the cough for few days, and you will be happy for just couple of hours, few days, and then it is going to rebound back. So we need to find the underlying cause. I'm talking about chronic cough. So do not suppress it. Find the cough. Chronic cough can be a simple, spontaneously resolving after ARI, viral ARI. That we know. But 3 weeks tak agar cough jata hai, the pattern of cough you saw in that graph, even the acute post-viral ARI cough frequency intensity goes down after 2 weeks. It is not sustained from 1 to 4 weeks or 3rd week goes down. So it goes down. But in the 2nd and 3rd week of post-viral your diagnosis, the intensity and frequency is still.
Hello. Hello. Hi. Can I talk to you? I'm listening to that MAHAPEDICON. Oh, okay. Aditi was complaining.
The alarm bell should start ringing in your mind. You're telling me something else. The viral ARI could be the trigger factor. Or कुछ भी है अंदर. So that is one thing. So we got to be mindful of that. And let's go back to the key message. So don't red flag signs. We already discussed. Focus on red flag signs. It's just take a snapshot of red flag. screen every patient in OPD, IPD with this type of symptoms. Then they always refer to updated algorithms and cough pointers, so to be able to reach to the diagnosis and cause. All chronic cases, chronic cough cases are not TB. Not all of them are allergic disorder. Not all of them are viral. Not all of them are asthma. पहले ये slogan बना लो. You have to think something else. Okay? You have to come out of that mindset. So all chronic, what is the impact? Actually, there was a slide on impact. They have done a lot of studies all over the world about the impact on the child, parents, family, and the caregivers. What are the impacts? Impact is horrible. It is causing problem in their schooling, growth, feeding, sleep is very important. I am a sleep disorder. If you can't sleep well, you can't do anything. So it is interfering in the sleep of the child, not only the child, parents, they are all anxious. They are coming to your OPD every time, sir, hamara bhi neend nahi hua, bachcha bhi sota nahi. So that's why the cause is important. So the impact on sleep, on the financial, psychological impact on the parents, and the heavy burden on healthcare system by spending so much of money in multiple cocktail medications and investigations. So you save the money and save the child by finding out the right cause and diagnosis, and consult the specialist, respiratory, allergy, infectious disease, whatever the specialist required for that particular case. So thank you all for the patient listening. If you have any questions, we are more than happy to answer any question. And this is the book on the similar topic. This topic is also there in the book. This is a very simple, handy book on cough and wheezing, which was released on the IAP Respiratory Respicon platform. And this is available online also. So this, all recent aspects, updates, everything is there, right from basics, physiology to anatomy, everything is there. So thank you very much. And if you have any questions.
Thank you, sir. I request Dr. Abhay Patil, sir, to kindly felicitate Dr. Sandeep Vaskar, sir. I request Dr. Jayashree Suryavanshi ma'am to come on stage and felicitate all our panelists, Dr. Abhay Patil, Dr. Hemant Joshi, and Dr. Chetan Shah, sir.
एक मिनिट मला मायग्रेन बद्दल सांगायचं आहे. चेतन भाई, आय एम टेलिंग अबाउट युअर थिंग. आपल्याला विपश्यना केंद्र माहिती आहेत, ते सत्यनारायण गोयंकांनी सुरू केलेत. पण ते का सुरू केलेत तर त्यांचा मायग्रेन जगभर ऑस्ट्रेलिया, जपान, ग्रीस, अमेरिका, कॅनडाला जाऊन पण बरा झाला नाही. मग ते विपश्यना करून बरे झालेत. सो विपश्यना शिका, योग साधना शिका आणि खूप आजार कमी होतील. येस, थँक्यू.